Everyone, respected President of TOSA, Dr. P. Sudhir Kumar, Secretary Dr. Vijay Bhaskar Garu, and TCOS President Dr. Somashekar Reddy sir, and all faculty and delegates. I welcome you all for today's program. We'll have a welcome message first by President of Telangana Orthopedic Surgeons Association and Secretary of Telangana Orthopedic Surgeons Association, Dr. P. Sudhir Kumar and Dr. Vijay Bhaskar. Sir, over to you, sir. Dr. P. Sudhir Kumar, President Telangana Orthopedic Surgeons
Good morning, everybody. I welcome you all to this TOSA midterm CME, which is a very important topic and it is a nightmare to every surgeon. Postoperative infections, and I thank TCOS, Dr. Somashekar Reddy sir and Srinivas Kasha for choosing this topic and giving important sessions on this. TOSA is being an academic body, is concentrating on all these kinds of CMEs and thing, and hope everybody is fine and safe with COVID, and looking forward to the physical conference which is going to happen in August, wherein the new body will come down, and it will be there in Hyderabad, organized by TOSACon 2021 by Dr. Tima Reddy sir and team. This TOSA CME, midterm CME is very important, and to the young orthopedic surgeons as well as consultants, and the topics are chosen. The most recent advance has been given in this CME, which should not be missed. Thank you, Srinivas Somashekar sir and Kasha and team TCOS for organizing this. Thank you.
Thank you so much.
Vijay Bhaskar, Secretary.
Hi, Kasha.
Hi, sir.
Am I online now?
You are online.
Okay.
Yeah. We are going to have welcome message by Secretary of Telangana Orthopedic Surgeons Association. Over to you, Dr. Vijay Bhaskar, sir.
So, good morning, all of you. Welcome to the midterm CME. This is a very great academic feast for after a long time. And then I congratulate Dr. Somashekar sir and then Dr. Kasa Srinivas sir, who is enthusiastically organizing this interesting topic, which is most important. Day-to-day practice, we are seeing the fracture and prosthetic infection rate about 2 to 5%, which is to be known by everyone, even young surgeons and older surgeons, senior surgeons also. Because the resins we use for the antibiotic resins we use for the infections, we must know about it, and we should inculcate in our practice to take care of our patients. Anyway, we should have been a physical conference because this month we are opening up all the lockdowns, but still there are some restrictions. So this is a virtual conference which is conducted by Dr. Somashekar sir and his team. I congratulate them again, and let all of us in large gathering attend this CME program virtually and make it successful. Thank you so much.
Thank you.
Thank you, sir. So, on behalf of TCOS, I again welcome you all for today's program. This is a midterm CME of TOSA 2020, in fact, which is supposed to happen in Siddipet. So it became virtual because of the COVID. And if you see, the topic chosen is prosthetic joint infection and fracture related infection. Because the incidence is rising nowadays, it is probably going to be another epidemic in the future. So we all orthopedic surgeons know that infection in orthopedics, once settles in, difficult to get rid of in spite of the best efforts. That's the reason one should know how to prevent infection, how to pick up it early, and the ways to tackle it, which all are covered in this particular program with most eminent faculty. So across Telangana and faculty, national faculty and international faculty. So before I start, let me just start sharing my screen. Can you see? Yeah. So the program starts sharp at 9:10 a.m. And ends at 1:30 afternoon. And we have done a small survey on infections to the general orthopedic surgeon, how frequently they get. So I just want to show up the results of this particular survey. The average number of infections encountered in one's practice among 100 people who participated in survey, 35% of them told it is around 1, and 2 to 5 in a month by around 25 people, 25%. And how many times you send it for culture? Most of them, they told they send it for culture whenever they see any kind of infection. And what percentage of you get culture positivity once you send it for culture? This answer was around 40 to 60% of the times. The culture positivity is seen in most of the persons, most of the orthopedic surgeons practice. So I'm just taking an average, and most of them find that maximum number of infections are encountered from open fractures, or preceded by open fractures. So rules of this particular program, Telangana State Medical Council has allotted 2 credit points. You will get the certificate only if you participate in the program to the full length. So we have to, which is recorded in Zoom. Those who actively participate in the program and listen to it carefully, you will have a chance to win a Pixart prize, which is 1,000 rupees gift prize from Pixart. And all you have to do is to answer the question which is going to come on the screen, and you have to answer it in chat box. The first person who answers will get the prize. And so this is only a fun activity, don't take it too seriously, and this is to increase the attendance and to focus on the academics for the attendees. So that's the Pixart prize, one who is going to win. We have got 11 talks, and after each talk, we have got a question which you can answer in the chat box. So with this, let us start with our first talk. By none other than Dr. Krishna sir, who doesn't need any introduction. So the first and foremost important topic is theater protocols in orthopedic surgery. Over to you, sir. Krishna
Okay,
sir.
just have a problem with sharing again. Just give me a second.
Sure, sir.
Oh my God. This again, it's not coming, Srinivas.
Just take the cursor onto the end of the window, sir. Then you will see share screen in green color.
Yeah, share screening. It's my topic is not coming on that.
Okay, but
Okay.
see, once you start sharing,
Is it visible?
it is not yet visible, sir.
Okay, just give me. Very sorry. Just.
You can just open your presentation first and then do this. No issues.
Got it now?
Yes, yes.
All right, Srinivas, really sorry for the hitch up. Thank you very much for asking me to speak on this very interesting topic. I'm very glad you picked up this rather extremely important topic and then focused on a small area. Let me share my experience over the last 40 years. I've had the opportunity to work in various hospitals, nursing homes, government general hospitals, corporate hospitals, and institutes. I have observed certain things regarding the theater protocols. We know that we have no right to do any harm to the patient, and everyone should try to ensure safety in operation theater. Even if you cannot do good, the bottom line is you should never do a harm. And as you rightly picked up, the infection is the one that always worries us. The consequence of deep infection following orthopedic operations can be catastrophic. Now, once you see a situation like this in your post-operative rounds, relying on antibiotics alone is not a good idea. Many times they end up in surgeries and complex surgeries. Often these surgeries are very expensive, many times more expensive than the index surgery itself. Now, this may be surprising, but it is a fact. 90% bacterial contamination of surgical wound is airborne and occurs during surgery. That's why the theater is extremely important. The most of these infections, no matter what we blame, except in small specific conditions, are due to implantation of bacteria during the surgery. So therefore, operation theater should be the inner temple of the hospital. That's where we talk about this, sanctum sanctorium. So I can't say more than this, the importance of the operation theater as a whole. When I say theater, it's the physical infrastructure of the theater and the kind of procedures and protocols what we follow during those surgeries. Broadly speaking, there should be 4-zone concept. I know it's sometimes difficult for a small nursing home to have all this compared to a big institute, but however, it is important. And you should have an outer zone where, general public intermix area for receiving patients, toilets, administration, etc. And then you have a restricted zone where changing rooms, staff rooms, recovery rooms, storerooms, etc. are located. Then you have a very strict aseptic zone where patients are prepared, surgeons scrub, and the real operation takes place. Nobody should enter there without theater gear. Just wrapping a gown around and then peeping in, I don't think it's a good idea. A disposable zone outer where all the waste is disposed of is a preferred area. The air quality in the operation theater is the one that matters the most. The use of clean air theaters installed, maintained, and checked according to national health standards is considered essential for orthopedic surgery. This was said a very, very long time ago. And of late, we're very glad now NABH has come up with more or less same guidelines and then insist on, they are not going to give you the certificate unless these things are fulfilled. Joint Commission International is more international equivalent of NABH, and it has much higher standards. So those of you who do not have NABH approval, but still please try to keep certain minimum standards at least. Because the operation theater for orthopedics is way different than general surgery and gynecology, etc. It should be higher air quality. Ultra clean airflow system in operating theater decreases infection rates in joint replacement. This was said in 80s, just after Chanley. Chanley has gone into such an extent, and I had the opportunity to work in one of these Chanley stands where you see the surgeons wrap completely with space suits and you have a circulating, cool, sterilized air, and nobody is there in the tent except the operating team and the patient. Everything else is sealed up. That was the extent they went up to, because they've noticed no matter how good your operation you do, if it gets infected, that's going to be utter failure. Now, we don't go for such an extent these days, but we have laminar airflow, which is consistently said that, provides better quality air in the operation theater, because airborne particulate matter carries bacteria. And these in the laminar airflow, you have microfilters and positive pressure laminar airflow that flows from the roof and then in a linear fashion away from the actual operating side. This is the kind of, on your right side, you see that these are the standard theaters these days. But please remember, ultra clean airflow reduces infection only if used in conjunction with good theater discipline and protocol. Just because you have a laminar airflow doesn't mean automatic passport for perfect theater condition. Another important thing in our country, in our area in particular, temperature and humidity. I mean, I have noticed many theaters are under air conditioned, and ideally speaking, it should be 20 to 22 degrees centigrade temperature, and humidity should be 50 to 60 degrees. You don't want to end up like this, especially after wearing all those lead aprons and waterproof gowns. You would be terribly irritated and also not safe for the patient. NIBH again has very strict guidelines about the temperature and humidity in operation theaters. Traffic in theater is another important protocol. 130 years ago, you see that this was the operation theater scene where like a conference, and that's how they didn't realize how important it is. But now, of course, it's completely different. But we still see scenes like this. This is not at all unusual. Very commonly, you see this much amount of crowd in operation theater. But please remember, each person sheds 1,000 colonies per minute, and therefore you should minimize people movement. Only the necessary surgical team members and equipment should be allowed inside the ultra clean theater. Cap and mask. COVID has brought more awareness about the mask, but you see many times mask means mask only for the mouth. It's not a nose mask. I mean, a very competent anesthetist, as you see in here, extremely good anesthetist, but look at the way they wear masks most of the times. And his boss is no better either. So here you are, one of our scrub nurse, and she put the mask very well, but look at the cap. There is every possibility of some of those loose hair can fall on the instrument's trolley. And this is I recommend to mask and cap during surgery. Now, a while ago, WHO has acknowledged this about the theater setup and then done a pilot study in 8 places. One of them was New Delhi. And after that, they have recommended 19 simple checks. By following this, they've noticed 30% reduction in complications and 40% reduction in deaths. And this is the surgical safety checklist, what WHO recommends. I mean, you can download that. If you don't have this practice already, I strongly suggest please download and print a page and then stick in your operation theater wall and make sure it's done. I mean, it's an elaborate, but not very difficult. And you have few things before induction of anesthesia you have to follow, and anesthesia only after checking those. And then before skin incision, again, you have few more. And then at the end, when the patient leaves the theater, you have to make sure certain checks are followed. By doing that, in their publication, they have noticed the antibiotic compliance has increased from 69% to 80%, and the surgical site infections reduced from 15% to 7%, and the other complications from 45 to 15, and then deaths from 4 to 1. So substantial improvement. Another important aspect we hear, although the incidence may be low, but if you see something like this post-operatively, it's a huge news and very embarrassing and difficult. Scrub nurse informed surgeons of swabs and instruments and needles in only 16% of cases. So unless you have a strict protocol, you might end up in like this. I mean, orthopedic surgeons don't operate in this area, but must have been done by a gynecologist or general surgeon, but still we do that. I have done that myself. I left a swab at graft donor site, and patient continued to discharge, and luckily she came to me. So I had the opportunity to go back and take that swab out very quietly without telling anyone, but many times you don't get that opportunity. So retained surgical foreign bodies after surgery, RSB, you see that 0.3 to 1 per 1,000 surgeries published in one article. And these are the scenes. The swabs sometimes inadvertently left, especially after a difficult surgery. But many times the swabs are radio opaque tagged, but I don't think that's done in this country. But it must be there. The swabs must have a radio opaque string. So in strict protocols, please make sure that the instruments, swabs, and needles are checked before surgery and after surgery. Before you close the wound, you must make sure they are accounted for. It is important to check that before surgery also. Sometimes the swabs may be inadvertently packed. The count should be tallied by a person who is checking. Now, in orthopedics, we have two sides. So marking the side is extremely important. Wrong side operations in USA, 1 in 50,000 procedures. There are 7.5 million surgeries done in the United States every year. 2,500 are on the wrong side. And there are 10 million flights per year in the United States. If the same thing happens in the airline, there will be one crash per day for the airlines. But there aren't one crash per day. The reason being, the airlines follow very strict cockpit drill. Unless, no matter how senior you are, how experienced you are, unless that drill is completed, the airplane should not start. That's why they reduce the accident. And WHO recommends cockpit style checks for orthopedics. Scrubbing, again, extremely critical, much different than other types of surgeries. If you don't have non-touch instruments like this, but at least make sure that you scrub well and there is a well-working system. Povidone and chlorhexidine, I've done some workup on that research, and then they generally chlorhexidine seems to be better compared to povidone. I don't think it matters much. But whatever you do, when you scrub, make sure you scrub above the elbows, and when you finish it, and make sure the water drips from hands towards the elbows, not the other way around. And when you wipe the hands, there is a procedure in a sequential manner from fingers, hands, and to the elbows, and then discard that. Don't move from back to front without understanding. Gloving, again, there is a specific procedure described for gloves. That's why they are folded in a particular manner. If you're lucky, you may have nurse doing that for you. Please make sure that you're covered both at front and back very well. It doesn't cost that much. When you get your gown stitched, make sure that they're fully covered, because often we have more people in the surgical team and there is inadvertently every possibility of contaminating. Sterilization is another important thing. Small hospitals used to have bin sterilization, but I don't think there are that many. But I just wanted to put this horizontal soak-free autoclaving is the one what is extremely important. So when you sterilize, it's a good idea to pack them in 3 layers and stock them, put the names and the date of sterilization. And when you open them, open them in a sequential fashion. And I recommend at least 3 layers of coverage so that there is better security. And please do not put this thing in theater and try to pick up instruments and other things with the sterile forceps. Positioning and draping is extremely important part of the operation, and you have to do that yourself until you're fully convinced with your other assistants. Proper supports and paddings, or again, that's the time you should do that. Otherwise, you curse yourself, scold yourself throughout the operation. Preparation, it's a good idea to prepare the scrub area before surgery. And in this day and age, especially joint replacements, waterproof drapes are important. As you see there near that ankle, there's a pool of water in there. And if you don't have waterproof drapes, there is every possibility of contamination. Well, should cell phones be allowed during surgery? Currently, there are no regulations, very interestingly, but we know pretty well they do cause distraction and contamination. I want to thank Kasha Srinivasan here for posing. He doesn't use cell phones. I vouch for that, but however, very kindly posed that for me to put this picture for. But please turn off your cell phone. They do cause a lot of distraction. Let me just end this talk, why it is so important, prevention of infection. Here is a picture of post-op knee replacement. The patient paid for this operation, a lot of savings. And then post-operatively, this is what happened. And then surgeon recommended him a 2-stage, very complex, expensive operation, as you see in there. Again, infection. After repeated surgeries, etc., this guy has ended up in life. Maybe you would have managed with a simple overrun SR 2 to 3 times a week, and just because of the infection, look at what happened. Extreme though, but this is what worries us. This is why we call it as disaster. So, ladies and gentlemen, it's our duty to continue to study and practice methods of eliminating post-operative infection because of its tragic seriousness. So, in summary, infections in orthopedic surgery can be serious. We know they are serious. Bacterial implantation mostly occurs during surgery. Orthopedic surgery requires high standard theaters compared to other surgeries, and strict theater protocols and discipline to be observed. Thank you very much.
Thank you very much, sir. That was a wonderful talk. How to the theater protocols in orthopedic surgery, which is very, very important to prevent infections. Sir, can you stop sharing? Krishna, sir.
Pause sharing.
Yeah.
Okay, done. I stopped, yes.
Okay, thank you, sir. Let me just put a question. After that, we'll take questions. Can you see my slide?
Yes, Pixart. Is that you are going to give cash or voucher?
It's a it's voucher, sir. They have all the numbers. They'll transfer to the concerned whoever wins with the certificate.
All right.
The question is, what is the most important factor in reducing infection in orthopedic surgery? The options are theater setup, theater discipline, surgical techniques, prophylactic antibiotics. So you can choose to answer this in the chat box. Whoever answers the first, they will have a chance to win that whatever prize money. With this, I'll stop sharing, and sir will take questions in the panel discussion. I think we are a bit late, and I would like to ask Dr. Ivireddy sir to start sharing and to speak on surgical discipline, which is equally important to prevent surgical site infections. Over to
Dr.
you.
Kasa, am I seen?
Yes, sir. Yes. And very much.
Okay, very good. Good morning, all friends. Just now we heard Dr. Krishna talking about. In
sir,
my talk also.
You have to
yes,
enlarge
yes.
the PPT, sir. That is one thing.
Okay.
Yes.
So my talk is surgical discipline. Does it matter to prevent surgical site infection? The answer is without any doubt, yes. And there might be, I'm sorry about that, there might be some overlapping between my talk and Dr. Krishna's, but it is not going to be too much. And some of the important aspects, I think even if there is overlap, it is going to be of use for us. Surgical site infection is a disaster. If particularly in orthopedics, a post-implant or like no arthroplasty, or for that matter, a major fracture when it's fixed and it gets infected, it is a disaster not only for the patient, even for the surgeon concerned, because the confidence levels will go down immediately and a lot of stress there will be on the part of the surgeon to cope with. So why this? Because the morbidity and mortality increase whenever there is surgical site infection. The patient has to stay in the hospital for a longer time and he has to spend more money. And the outcomes at the end are going to be poor, definitely poor, not as we expect them to be. And as I said, it is a big drain on the part of the surgeon also, psychologically, physically. And if these things happen in a couple of times, the surgeon's confidence levels will go. In spite of you doing joints or for that matter, internal fixations without any complications. So WHO has observed 7 to 10% of the hospital patients develop hospital-acquired infections, 7 to 10% of inpatients. Out of these, 70% of them occur in patients who have undergone a surgical procedure. So you can understand how important it is to follow the surgical discipline to prevent infection taking place in the operation theater setups. So coming to the surgical site infection pathogenesis, this is the source of organism. Endogenous and exogenous, you can broadly classify them into two categories, but the exogenous means that is generated by the patient himself from the body commensals. For example, if the surgical site is not clean, not prepared well, there could be the commensals on the surface of the operating area, and they can gain access into the wound and the infection can start. But this is only a small percentage. Majority of the times it is exogenous. And this exogenous could be direct or indirect. Direct in the sense from the operating personnel, the team, the surgeon, the assistant, the scrub nurse directly breathing onto the wound can contaminate the wound. But again, such studies have shown this is not going to be that great as long as the team follows certain surgical principles. It is the indirect contamination through the contaminated instruments, implants, surgeons' hands because of the circulating flakes of the particles that are shed by the operating personnel and contaminated environment. So this is because of the breach of asepsis, the squams, otherwise the shedding from the skin released by the theater personnel will contaminate the entire atmosphere of the theater, and these can land on the instruments, equipment, or even surgeons' hands, and ultimately the wound can get contaminated. This is what I mean indirect. Direct is directly breathing onto the operation wound. So it is very important for us to take all the precautions to prevent surgical site infection. So the discipline starts not only in the operation theater, it's not restricted to, it starts in the preoperative evaluation of the patient itself. This is because we would like to know, particularly in elective cases, you would like to know high-risk individuals. And in those individuals, because it is an elective surgery, wherever it is possible, identify the risk factors into modifiable, non-modifiable. And whenever it is a modifiable one, you try to put in efforts to eliminate them. So for this, you need to have a detailed history, a careful examination, and relevant investigations. That will identify the risk factors, which can be divided into modifiable and non-modifiable ones. So of course, if it is an emergency surgery, you will not have much chance to modify the risk factors. You may have to accept, explain the risk and go ahead. But if it is an elective surgery, you have got all the time in this world to rectify those things. Coming to the patient factors in general, malnutrition, immune compromised states, metabolic disorders, we all know all these are very important risk factors for surgical site infection. So we have to keep them in mind. Local factors like previous surgical scars, particularly when they are very large, wide, and then unstable, there is a risk of them harboring organisms in larger numbers. And when you go again through the same area, the chance of surgical site infections are going to be very high. So you have to respect the previous surgical scars and plan your surgery accordingly. So similarly, local skin lesions. I must say a word about the bed sores, particularly in elderly people who will be lying down, say, for more than 48 hours. There could be a bed sore. And if you don't look for them, you might be planning a major hip surgery. And if you don't look for them, you will be cutting a sorry face later on. So inspect the operating area thoroughly all around and make sure that the skin is healthy. Sometimes there might be some subclinical infections also, like cellulitis, bursitis, in minute quantum, but still it is surgeon's responsibility to make sure that such things are not there nearer to the operating site. Coming to the malnourishment, these are the parameters which will tell us whether the particular individual, whenever you have a doubt, you evaluate these things. The lymphocyte count, if it is less than 1,500 per cubic millimeter, either serum albumin levels are less than 3.5 grams per liter or transferrin levels less than 200 milligrams, they indicate that the patient is malnourished and he is a high-risk patient for surgical site infection. Similarly, smoking. If somebody is a smoker on a regular basis, you have to tell them to stop smoking at least for 3 weeks before you plan an elective surgery. Septic foci, it is the surgeon's responsibility to search for this. It is part of your preoperative assessment, part of your surgical discipline, I must say. Without proper preoperative care and analysis, you are not supposed to post the case for surgery, particularly in elective cases. So look for urinary tract infections, sinuses, throat, dental. These are the common sites where the individual can be having infections. If any doubt is there, obtain swabs and try to identify the organism and rectify those things. And obesity, a word about obesity, these people are prone for infections, surgical site infections, because the duration of surgery is going to be certainly prolonged. and extensive, because a smaller incision will not be enough. You may have to go almost, your incision can get doubled up sometimes, and tissue is subjected to, because you need to have heavy retractors and all that, tissue is subjected to crushing, heavy, lot of bleeding will be there, blood transfusion required. So all these can pose a high risk for surgical site infection. So one must be aware of this before embarking on surgery on obese individuals. Similarly, steroid therapy, this will lead to an immune compromised state, poor wound healing also. When people are on steroids for a long time, there will be water retention. We all know all these are not good for a proper healing, which can lead to surgical site infection. Similarly, antiplatelet agents, these can lead to hematoma formation, suture line tensioning, and sometimes oozing of the wound, wound breakdown, and secondary infections. Coming to the surgical team related, already Dr. Krishna has shown some of them. I would like to once again emphasize on these things. Surgeon's personal hygiene is very important. So ideally, you should have a nice bath before you enter into the operation theater area and change into decent theater suite dress. And this dress also is supposed to, the cotton that they say should have a tightly woven ones, not the routine ones, because the pore diameter should be kept very small so that the bacteria cannot gain access from the surface of the surgeon onto the exterior. Particularly if it gets wet, as Krishna has shown, in humid atmosphere, the fluid channels will act as easy passages for the bacteria from the surface, and then they can contaminate the surgeon's hands. So hair and nails need to be trimmed regularly. And in the case of females, long hair will be there. They need to tie them up properly and cover them as I have shown in this. And Krishna has shown how they should not be done. And now you can see how they should be done. The hair need to be completely covered, whether it is male or female. There is no excuse for that, because hair will be harboring a lot of microbes. And even if one or two hair fall onto the surgical field, there is a chance of infection. So here I have shown how a face mask and a cap should be. And another thing, important thing is, even if you limit the number of persons in the operation theater, their movement in and out of the theater should be restricted. You can't go on moving in and out for 10 times. Even if you are the senior most surgeon, it is not correct. The door should not be open time and again, and you should not. Your movement also should be restricted, because every movement of an individual is going to shed more number of particles into the theater environment. That is not good. Coming to the operation facility, the training. So newly recruited technicians should not be posted in the orthopedic theaters. Orthopedic theaters need to be people who are well trained in the aseptic matters. So sometimes this happens in our hospitals also. When there is shortage of personnel, they try to recruit and then put them on the uniform onto them, and then they send. These people don't know anything about asepsis, and they can contaminate any of these aseptic areas. So you have to be very careful about the new recruits. The number of personnel also matters, as already Krishna has said. This should be limited to the bare minimum, and these people again need to be restricted, not to go in and out of the theater. Once they are in, they should be in, unless there is an important need for that. And unnecessary equipment. This is another important thing many a times people ignore. You keep everything that is not required, like C-arms, that, so many things. I am very skeptical about that. I don't like any unnecessary equipment in the operation theater. As you can see in this particular image, an operation theater should be like this. You should be to have only that is essential for your surgical intervention, not all rubbish inside the operation theater. Coming to the scrubbing and gloving, already Krishna has said adequate scrubbing is important. After scrubbing, you have to dry them with sterile towels and then apply an alcoholic hand rub, and gloves must be worn very in a systematic way. See, this scrubbing is supposed to be very important. When you enter into the operation theater and you are preparing yourself for the first case, your scrubbing should be at least for 3 to 5 minutes. There is no shortcut in this. Nowadays, we are not using brushes because brushes will cause erosions of the skin, and they bring out the organisms that are there at the deeper layers of the skin. So brushes are not being used, only hand washing, hand scrubbing. So the solution that is recommended is this one. You can see here, iodine 7.5%. This is one we use normally. Of course, as Krishna said, chlorhexidine also can be used. And the difference between these two is not much. The only difference is they say chlorhexidine, the antiseptic effect of chlorhexidine lasts for a longer time in comparison with your povidone iodine. That is the only difference. So you can choose whichever you want. So as I said, after your scrubbing, you dry your hands thoroughly with a sterile hand and then apply this alcohol hand rub, which is going to eliminate the bacteria from your hands almost to a negligible level. Very important step. And gloving, this should be in a no-touch technique. Your theater staff should be trained how to help you in wearing them properly. And double gloving is now recommended. Routinely we use double gloving in our orthopedic surgeries. And it is also recommended that if you can wear the first glove, a colored one, the punctures of the outer glove can be easily recognized. It has been shown that 10% of the times the outer glove gets punctured, and out of this, 80% of them, the surgeon will never notice the puncture. That is why they have recommended the underglove to be colored. Patient preparation. So these are important aspects. Prophylactic antibiotic, we will have briefly I will tell about each of them. I like having a tunica in limb surgery, shaving of the operation area, preliminary scrub by the OT staff, scrub by the surgeon, or painting of the operation area by the surgeon, draping and alcohol application, and then offsite adhesive drape. Prophylactic antibiotics, it has been already touched. Nowadays, we are using only 3 doses. The antibiotic that is chosen should be guided by the local protocols and particularly by the input from the bacteriologist. So whatever antibiotic you want to give according to their guidance, it has to be in 3 doses. The first dose should be given not earlier than 1 hour before you start the surgery. So within 1 hour, you have to give so that you will get maximum concentration in the blood. And at the same time, if you are applying a tourniquet, the antibiotic, IV antibiotic should be given at least 10 minutes before the inflation of the tourniquet. Very important. So this is the first dose. And then after that, you have 2 more doses to be given. One is 8 hours post-operative. The second dose is 16 hours post-operative. And the studies have clearly shown there is no extra benefit by giving antibiotics for a prolonged time. 3 antibiotics, this is our standard protocol even in our hospital. We don't give beyond 3 doses unless there is a overriding reason for it. So coming to the tourniquet, some people say we don't use tourniquet, but I like limb surgery. The advantages are you have a bloodless feel. Tissue display is very good and your operation can be very tidy and you can identify it, particularly when you are dealing with some delicate tissues, you will not cause damage to them. And to the extent that is needed, you can dissect out very nicely. Not only that, the surgery duration also will get lesser if you have a tourniquet. And suppose, let us say there is no tourniquet and it continuously oozes in some areas and you are going to use the swab time and again and the catheter tip, that can itself cause damage to the tissue, which can invite trouble. So I would like to use the tourniquet. Shaving the part. Sorry. This is another important aspect. You are not supposed to shave the part of the body in the ward the evening before or before releasing the patient from the ward. This has to be carried out in the operation theater after the application of the tourniquet, if at all it is needed. Studies have shown it makes no difference whether you shave or not. But for our, we most of the times, particularly the hair is very heavy. It is not good to look, not only for look from hygienic point of view also, it is better to shave. But if you want to take the hair off, they suggest electric trimmers like what we are using here regularly in our hospital. They will not cause any abrasion or damage to the skin. And so there is no question of colonization. And since we are doing this immediately before the application, after the application of the tourniquet, there won't be any chance for bacterial colonization also. So coming to the limb preparation, on the left-hand side, you can see the technician scrubbing the limb using 7.5 povidone iodine, thorough scrubbing from one end to the other, including the foot and ankle. This is my case for a TKR. I go like this. The technician scrubs this thoroughly and then dries it up. After that, with all the aseptic gadgets on me, I will paint the part. But I don't paint the foot and ankle area because I feel by painting that area, the antiseptic solution can gravitate onto the operating area and that can get contaminated. So the technician scrubs, but I scrub only up to the supramalleolar area. And I isolate that part by using such sterile drapes. Draping is an art. Everybody has to master it. Every area, you need to know how to drape it and isolate your surgical site so that there won't be any scope for bacterial contamination. And at the end, before you start the surgery, alcohol rub definitely will eliminate the few organisms that might be lingering around that area. This is one good stuff. Similarly, as what has been used for our hands, here again, the same alcohol rub will be applied before starting the surgical procedure. Of course, this is the operative site adhesive drape. Studies have not shown much difference whether you use it or not, but definitely it will assure the surgeon that everything is going to be okay. Actually, it has got a layer of antiseptic also along with it, and it seals off the operation site from the rest of the area. Coming to the surgical technique is very important. You have to plan, as Dr. Krishna has said, pre-operative planning matters a lot. Whenever you are embarking upon a surgery, you have to have a proper plan as to the type of surgery you are going to do, and the position of the patient, position of the limb, the supports that are needed, all these matter. If you don't plan that, your surgery is going to be clumsy. Sometimes you might land in difficult situations where the operation time can get prolonged and you will be inviting trouble in the form of surgical site infection. So plan your surgery. Before you put the incision, identify the local bony landmarks properly and place the incision in an appropriate location so that even if your incision is smaller, you will be able to reach the depth of the wound in a very easy fashion without the need for heavy retractors and other things. So identify the bony landmarks, placing the incision in a sharp way will eliminate the chance of infection. Clean and bold cuts through the tissues are possible only when you have the experience of identifying the bony landmarks and the surgical, surgical techniques and other things. So crushing and devitalization should be avoided. And as I said, your clean cuts should be there through the tissues whenever it is needed. Don't cause more damage to the tissue. Already the disease or the trauma has done enough damage to the tissues. You should not, as a surgeon, add further damage. But of course, we have to reach the area with the minimal damage so that the chance of devitalization are less, the chance of infection are going to be less. At the end of the operative procedure, I always would like to go for wound debridement and then irrigation, and finally achieve hemostasis before closure. So if you can see here, this is a TKR, a clean sweep with the knife. That is what is important. A clean sweep. Once you put the knife on the skin, don't lift it again. Take it to the other end with a bold, clean sweep. And similarly, if you see the forceps, the tooth dissection forceps is another thing very dangerous, particularly the knee where the skin can be very thin. Don't catch the skin flap with the tooth forceps. Try to displace the flap with both the jaws of the forceps rather than catching it. It can crush the tissue and can have healing problems. So as I said, at the end of my procedure, I would like to take out all the loose and crushed tissue. At the end, the surgical wound should have healthy bleeding tissue so that even if there is a little bit of contamination, that can be taken care of by the antibiotics that we are going to give and also the host defense mechanisms. Coming to the wound closure, suction drainage. This is a closed suction drainage. I always prefer, some people, they don't. I would like to use a suction drain. So at the end of my surgery, see anybody's surgery for that matter, at the depth, there is going to be some amount of blood and tissue fluid. And of course, we are giving prophylactic antibiotic and aseptic, you talk of all that. Suppose if it gets contaminated by any chance, this is a dead tissue and there isn't contamination, the infection is going to be there. I don't want this fluid at the end of my surgery, the depth of the surgical wound, it has to be drained out so the chance will get less. So what most important in the closure of the wound are two areas. One is the deep fascia and the second thing is the skin itself. So the deep fascia need to be closed watertight. So if you don't close the deep fascia watertight, what happens? As I said, some accumulation of blood and tissue fluid in the depth will find its way to the subcutaneous plane and the wound starts oozing post-operatively. And oozing wound is not at all good because the fluid channel will encourage the surface bacteria, commensals like Staphylococcus aureus, Staphylococcus epidermidis, can pass through these passages very easily to the depth of the wound. We don't want that. If you don't want to invite such thing, if your wound has to be dry at the end of 48 or 72 hours when you change the dressing, you have to have a watertight closure of the deep fascia. Very, very important. Please remember. Then coming to the fatty layer closure, wherever the fatty layer is thick, try to put some interrupted stitches. But you have to remember, you should not crush the fatty layer, just coapt. loosely, bring them together. This will help you in reducing the thickness of the scar and also helps proper healing also. So fatty layer closure is important. At the same time, you are not supposed to crush it too much. Coming to the subcuticular suture, nowadays we are all doing this. It gives a nice coaptation of the skin edges. It is very important because if you coapt the epidermis nicely without exposing any raw area, within 48 hours, there will be epithelial bridge across your incision and it becomes waterproof. Even if you pour one bucket full of water from the tap water on the wound, it is not going to get infected. If provided, you have achieved good coaptation of the epidermis. That is why proper suturing of the skin also is important. So of course, at the end, we put a compression bandage. So this is what, just to show that how we close the retinocular layer. In the case of knee, it is equal to your deep fascia. This layer should be watertight with a continuous suture, watertight closure, very, very important. And then this is the skin closure. You can see nice coaptation without exposing any raw area. So here what happens, within 48 hours, there will be epithelial bridge across and your wound is going to be very safe. There won't be any chance for contamination. Of course, this is a compression bandage. A few words about the post-operative care. Antibiotics, I already said, 8 hours, 16 hours post-op, we give two more doses and then we stop. And as I said, I prefer to use the drain, which I am going to pull out at the end of 24 to 36 hours. At the same time, one has to remember when you are using the drain, it should not be left for more than this period. If you keep the drain longer, there is a chance of the organisms gaining access into the depth of the wound along the drain itself. So never leave the drain. It doesn't matter, even if the collection is a bit high, you remove the drain at the end of this period, don't leave it. And we usually keep the compression bandages for 48 hours before we go for a change because by then what happens, the hemostatic mechanisms will make, stop all sorts of bleeding from the raw area and there's the scope for further oozing will not be there. At that time, I can safely take out all these heavy dressings and put a small adhesive drape. If the wound oozes, stop anticoagulants and also slow down physiotherapy for a while, particularly with regards to total knee replacements. This is what I practice. This has been said by even great surgeons also. If your wound is going to ooze, initial steps should be to stop the anticoagulant for a while and also slow down the physiotherapy. Suppose if the wound continues to ooze beyond 5 days or 7 days, then it is a dangerous thing. Don't ignore it. Don't ignore it. Take the patient back to the operation theater, open it up. As I said, your deep fascia closure may not be good. There might be some collection inside. That is what is coming out. So open that area, irrigate the wound thoroughly. You don't need to do anything. Take out the stitches, take out all the collection that is there and resuture. That's it. Your wound is going to get dried up. So don't be hesitant. If the wound is oozing beyond 1 week, don't sit on that. Take the patient back to theater. Open the sutures. Clean that area, irrigate that area, and resuture. You are going to be fine. Thank you very much. I thank all the TOSA executive as well as Dr. Kasa Srinivas and Somsek Reddy for giving me this opportunity to participate in this beautiful webinar. I would like to learn more from other speakers. Thank you very much.
Thank you so much, sir. That was a wonderful talk. Can you stop sharing, sir?
Yes, I will do that. Where should I go? Pause share. Yeah. Is it okay?
So, yes, sir. Thanks. There is one question from the attendees that can they use normal water for scrubbing? So you both can answer, Ivy Reddy sir and Krishna sir.
You mean to say at the time of scrubbing? Yeah, I have seen this. RO water or whatever call. In our hospital, I think we have some treated water we are having. If the water is going to be clean, I think you can still use that. Yes. Tap water, I mean.
Sir.
See, for example, if you take, for example, in England, sorry. Should I or not?
I don't think it really matters. I mean, if your water system in your hospital is a decent, clean water. I mean, you don't, I've seen people using autoclaved water, pouring from a jug by an assistant in some hospitals, which I don't think is necessary as long as the water is clean.
Yes.
are not contaminated. A regular tap water at these days is quite adequate. You don't need to go for any specialized.
All tap
Don't
waters,
use saline.
treated waters. Yes, correct. Thank you so much, sir.
I agree with that. You don't need to have special water. As long as the water is clean, I think that is good enough.
Thank you, sir. The last question answer is the question is, what is the most important factor in reducing the infection in orthopedic surgery? The answer is two, theater discipline. The person who has won is Dr. Neha N. And the current question for Dr. Ravi Reddy sir's talk is limb preparation, painting by the surgeon. What is the percentage of providone iodine used for painting the operation site? Whoever answers first in the chat box, they'll have a chance to win the Pixot prize. So now I request Dr. Somasekhar Reddy sir to introduce Dr. Andrew Jeffers, who is going to speak on new innovations in early diagnosis of surgical site
Hello.
infections. Over to you, Somasekhar sir.
Good morning, all, and thank you, Dr. Srinivas. It is my real privilege to introduce Dr. Andrew Jeffers, who is currently the medical director at St. John's Orthopedic Institutes in Oxnard, California. And more important to us is he's a chief medical officer at Crilly Healthcare. He is involved in developing novel digital biomarkers and the medical devices to continuously monitor the wound site during the post-op phase. I hope Mr. Arun Sethuraman has logged in, who is the main person who is the connection to us to bring Creli to, I think, to India and trying to popularize it, and who is the critical person to introduce Dr. Andrew Jeffers to us. And Mr. Arun Sethuraman is a CEO at Creli Healthcare based in Singapore. Now it is Dr. Andrew Jeffers. Thank you.
Thank you very much. Like I said, I'm Andrew Jeffers. I'm an orthopedic surgeon. I'm practicing in Southern California, and I'm the Chief Medical Officer of Crowley. And I'm here with Arun Sethuraman. He is the founder and the CEO of Crowley. And both of us really do appreciate the invitation to allow us to talk with you about Crowley, our company, and our hope to what we'll be able to achieve. A lot of what I may cover today may have already covered, but we hope to at least talk about some potentially some new innovations in how we address and diagnose infection. So I really didn't need to title this slide. I know that you all are familiar with this presentation, and I know that you have the same amount of dread when you see that coming into your office in your patients. And these are obviously surgical site infections. And they really show the classic signs of infection, redness, swelling. You can imagine that it's quite warm, and you can also imagine that the patient is in a fair amount of pain. And all those four signs are what
Dr. Andrews. We are not able to see your slideshow.
Oh, I am so sorry. Let me fix that. Better?
Yeah.
Yeah.
Okay.
You may restart.
All right, I apologize. So now you can see these incisions, and I know that you, again, have the same amount of dread, and they show infection, they show redness, they show swelling, and you can imagine that there's a fair amount of warmth and a fair amount of pain. And these are really the four signs that we've been using basically for millennia to diagnose infection. And the hope is what else can we do? And it's not just
So we are not able to get you, Dr. Andrews.
Johnson
Arun?
people can do anything.
Srinivas, let's have some questions while we
Yeah.
waiting,
Sure,
but
sir.
there is some interruption.
I think Dr. Andrew Jeffers is back.
Okay.
Okay.
Oh, Mr. Arunshit Ravan.
Yeah, I think he's back. I mean, if this continues to be a problem, I can share the updates as well. But I think Andrew is back. Yeah.
Can you hear
Andrew,
me
you're
now?
on mute.
Yeah, yeah.
How
I
about
think
now?
we
Can
need
you
to
hear me?
start sharing again.
Oh, my goodness.
Sorry for the technology issues. We are in the technology industry.
Yeah. Thanks.
Better?
Better.
Okay. I apologize. You know, I feel like I've done this before, but today I just seem to be running in all the rookie mistakes. So did you see this slide at all?
Yeah, we can see. Yeah.
Okay. All right. Did you hear me speak about it? I guess
No.
Okay. So
The last we saw was the skin incision redness.
Okay. Surgical site infection is not just an individual problem that affects our individual patients. You know, it's really a worldwide, global problem. And each of these circles represents the incidence of infection in that particular geographic area. And you can imagine that it's really a huge number of patients that causes a significant amount of pain, discomfort, extra work, and potentially even deaths of the patients involved. And a huge amount of money is spent trying to both prevent and care for these patients after they develop their infections. So this slide really represents our difficulty that even though we know that these infections exist, we still can't prevent them from happening. And so 60% of surgical site infections were detected after discharge from hospital. And I think the reason for this is really multifactorial, but I really think that there's probably two main reasons why this is the case. One, infections really take time to develop. It's that usually after you've done an elective surgery, by the time they're closed, most likely they're not going to develop an infection if they are going to develop one, at least for a couple of days. It's been a trend over the past couple of years that patients are spending less and less time in the hospital, especially for elective surgeries. When I first started my practice, not unheard of for a total joint to spend 3 or 4 days in the hospital. Now we are doing them as an outpatient. Overall, I think that getting the patients out of the hospital is a good thing, but while they're not there under the care of the surgeon and the nursing staff, the wounds are not able to be monitored. And so we simply just cannot see the wounds from day to day. As a corollary to that, we really can't diagnose infection unless we're actually looking at it. We may hear a good story, and unless we hear over the phone that the wound has started to drain, really the only surefire, reliable way we have to develop or determine an infection is actually by clinical observation. And if the surgeon and the patients are not in the same room, then it's really hard to diagnose that infection. So this shows the timing and when its infections occur. And again, this critical phase is a couple of days after the discharge from the hospital. To go along with this, if you have a 45-hour delay in treatment, it increases the infection-related death percentage by 3.8 times. So it's very important to not only diagnose infection, simply because you need to be able to start treatment as soon as possible. And if there is a delay in treatment, then that's going to have a significant impact onto the patient. And to some degree, this is sort of similar to the avocado problem. I'm sure many of you, like I have bought an avocado, waited daily for it to ripen, only to ripen very quickly, and then suddenly it's no good. And trying to diagnose infection by simple observation can be difficult, even when we know what we're looking for, because simply the same cardinal signs of infection, redness, swelling, warmth, and pain, those are completely expected and normal after surgery. And trying to determine which ones are normal and which ones are not can be really difficult. And of course, time is of the essence, because if you do have a delay, that can have a significant problem with the patient. So we really have sort of two problems that we're trying to solve with Crelly. One is we'd like to create a tool, a device that not only assists the surgeon in diagnosing an infection early, but also do it in such a way that the surgeon doesn't necessarily have to be present, i.e. remote monitoring. So Crelly is developing a medical device-enabled clinical decision support platform. And what this simply is an entire system that will monitor the patients in the immediate postoperative period and being able to let the surgeon or clinical team know what is exactly happening with that particular wound at any particular moment. So the way that it might work is we have a sensor that's applied over the incision at the time of surgery. So this is adjacent to the wound. It's not next to the wound, so a surgeon is free to use their own dressing. But it stays on, placed on a sterile field, and we expect that dressing to be able to stay on for that first postoperative period of 10 to 14 days. During that time, it continuously sends information of biomarkers surrounding the tissue around the wound by way of either a phone or an app or another internet connected device. And it's going to be connected to the clinician's emergency medical or emergency healthcare, not emergency, electronic health record. So that the information, that data gets sent, and then at the same time is analyzed by artificial intelligence. So with a combination of the biomarkers as well as pre-entered information about the particular patient and their risk factors, whether they might have diabetes, whether they have kidney disease, how old they are, their weight, we can then make a prediction or at least a determination as to whether the patient has an infection, hopefully predict an infection if it is about to occur, and get that information in a timely fashion to the surgeon or the clinical team so that they can then quickly make some treatment and changes, and thus help try to prevent that surgical site infection from getting to be very severe. So this is a mock-up of our clinical device. This is one of our early stages, but we envision that it's going to have sensors that sit adjacent to the wounds. There's going to be various lengths to accommodate various size wounds. These will then be connected to this device right here, which contains the battery as well as some initial processing equipment. This will be connected wirelessly to either the phone or another internet connected device, which then sends this to the cloud for information processing afterwards. We expect that we'll get about 10 to 14 days. It will be waterproof. The patient will be able to shower and walk around and do their normal daily activities while this is in place. So what do we have to show that it works? So again, what we're really sensing here are the biomarkers. And these biomarkers, there's plenty of devices that do each one of these individually. They are well studied, and they have their own particular device that there's a lot of background for. That's what this represents over here, is that there is a lot of literature which supports the use of the individual biomarkers over here in helping to determine whether a patient might have an infection or not. What's unique about Crelly is we've been able to combine a number of these in really a unique way that has not ever been done before. And so by taking the biomarkers plus eventual assessment of the patient's clinical picture beforehand, we'd then be able to make a prediction as to whether an infection might occur. So we have done our own studies, which have proven to at least some of the beginning stages. And our first test was in 2019 when we started a study with one pig. And this was basically a proof of concept. And it was very, very basic, but we were able to make a determination between infected and non-infected tissue, and we could see that over time. We are encouraged enough that we planned a human study that was intended to start in 2020. 3 patients in, COVID hits, and so we had to stop, and so we were unable to finish that. But from the very limited information that we got from the human studies, again, we were very encouraged. In 2021, we have just finished the phase 1 test of a repeat porcine study. And this is a much more robust, much more comprehensive evaluation of our hypothesis. And if Arun is still on, I think literally the study just finished within the last 24 hours, and he may actually need to leave to go finish this up. Right now, we just have raw data. We don't have anything to say otherwise, but we feel that, just looking at it very briefly, that it does show some positive indications that we are able to do what we are setting out to do. So where Corelli goes from here, obviously this has an application for essentially any wounds, but we'd like to try to focus on what Corelli can do with a couple of different markets first. So we're looking at orthopedics, open GI surgery, cesarean sections, as well as reconstruction. Some of these are chosen for their high rates of infection, such as open GI surgery and cesarean section. And the other one, for instance, knee arthroplasty, although the risk of infection is relatively low, the consequences of having a knee infection, especially a deep knee infection, can be very severe. And so we're hoping that by, again, identifying this infection early, we can make some changes and prevent further problems. So we envision it to be, the system to be somewhat like the Holter monitor, which is currently in use. Some of the parts would be recyclable, some of them would be disposable, but we expect it to last from anywhere from 3 to 14 days. These are the many of the institutions that we've spoken to and gotten information about and over the past couple of years. We have a number of different contacts with pretty much to everyone has been highly encouraging, and we hope to be able to bring this to market so that these people can get involved as well. We feel that there's going to be value for every stakeholder in the healthcare system, not only for the healthcare system players, but also the payers, and of course, most importantly, the clinicians and the patient caregivers. The patients and the caregivers, simply because it'll help reduce infection and it'll give peace of mind to them as well, and it'll help the clinician be able to take care of them. This is our team. This is Arun over here. We have a multiple national team. I am from the US. Arun is based in Singapore, and that's where Corelli is based. Frederick Nyberg is our Chief Strategy Officer. He's from Sweden, although he's currently living in Singapore right now. And our technology advisor is from Germany. We do have a scientific advisory board. Again, a couple of surgeons from the US associated with the Henry Ford Health System and Harvard Medical System, and Dr. Harry Van Goor from the Netherlands. We have been able to win some awards simply by the promise of what we've been able to do so far. This is our best investment in the Harvard Business School, new venture competition, the Asia Pacific division. And then we were the winner of the Australia MedTech Innovator contest and a finalist in the Asian Pacific competition. And then finally, we feel that we hope to be addressing a huge unmet need. That is being able to really assist the clinician in identifying infection, and then be able to do it in such a way that the physician, the surgeon doesn't need to be there. We can do this with remote monitoring, and we hope to create a good business out of this. If Arun is still on, he can chime in. He may have needed to leave, but I'm open for any other questions also.
Thank you, Andrew. Wonderful, excellent. Yeah, thank you. Happy to take any questions from the group. Again, once again, I want to thank everyone for giving us the opportunity to share our story, especially Dr. Reddy, Somaseka Reddy. Yeah, thank you very much, sir.
Thank you so much, Dr. Andrew Jeffers and Dr. Arun, for your excellent innovation. So newer things are always good, and happy to know at least at this stage. Thanks for that. And we'll move on with the next talk. And before that, can you just stop sharing, Dr. Andrew?
I can, yes.
Let me just check if you have any questions.
Technology and things. Anywhere in the world can be connected each other.
Yeah, thanks.
So phone virtual ఎక్కువ అవుతుంది physically తక్కువ.
I just want to share. So the next question is from the last talk. So how many hour delay in the treatment increases the chance of infection related to deaths by 3.8x? So this was discussed in the talk. So whoever answers this first in the chat box, so we'll have a chance to win a Pixar prize. With this, and please put your questions to Dr. Andrew in the question and answer box so that we can discuss during next talks or next panel discussion, as well as in between the talks, because I could not see any question there. So I'm just moving on to the next talk here. So
Dr. Jeffers, stop sharing the screen.
Yeah, it's with me. Yeah. So next, I would like to invite Dr. Vaishali Tadokar from Sancheti Institute to talk about how to get maximum yield of culture positivity in orthopedic infections. I know we all know that we keep sending culture tests, and even in the survey which we have done yesterday, the culture positivity rate is only around 40 to 60% among most of the participants who have participated in the survey. In fact, I feel it is far, far lesser. So in spite of sending it at various, diagnostic centers, my culture positivity rate is less than 20%, I'll tell you. So, Madam, please, the background for this particular talk is that how to get maximum yield of culture positivity in orthopedic infections. Over to you, ma'am.
Very good morning to all of you. I'm heard clearly, right?
Yeah.
Okay. At the very onset, let me thank organizers for giving me this opportunity. Now, my topic is how to get maximum yield of culture positivity in orthopedic infection. And the simple thing is microbiology laboratory works on a principle of garbage in, so garbage out. So the quality of the specimen which is you are sending to microbiology laboratory will highly define what will be the outcome. So there are certain factors which can be modified to get a better yield. Correct specimen. Now the frank pus or the tissue specimen is much better than a pus swab. So wherever possible, go for that frank pus or a tissue specimen. Similarly, urine catheter tips, they are inferior specimen or a not acceptable specimen in the laboratory as compared to the midstream urine, which can easily be sent. Then the correct quantity. Again, it is very important, especially in case of synovial fluid culture. Minimum 2 to 5 ml of synovial fluid in 2 to 5 set of the blood culture bottle has to be sent to the microbiology laboratory to get a better yield. Similarly, in case of a tissue sample in prosthetic joint infection, it is suggested that 2 to 5 samples of tissue are to be sent to the microbiology laboratory to get a better yield. Correct transport media. Now, there are some fastidious organisms like streptococci, which can easily, get killed during transportation. Or then there are anaerobes, which might be present in a surgical site infection. So, to keep these organisms alive by the time they reach to microbiology laboratory, we need to have a correct transportation media at the hand in the OT itself. Correct laboratory test. What is the expected pathogen? Is it an anaerobic infection? Is it a mycobacterial tubercular infection? Or is it a fungal infection or a aerobic infection? So based on these clinical diagnosis, you have to choose the correct laboratory test so that we can give you a better yield. If I have to pinpoint a single important factor to improve the culture positivity, it will be correct timing. So always send a microbiology culture before starting antibiotic. If patient is already on antibiotic, then try antibiotic interval of 2 weeks. Again, timing becomes important when we are opting for a blood culture. So either send a sample before starting antibiotics therapy, or if already a dose of antibiotic has been given to a patient, send the culture before giving the second dose when the effect of first dose has already been weaned off. You can send the blood culture at the beginning of a fever spike if possible. Expertise of laboratory personnel, they also play important role in getting a better outcome. And correct incubation time, especially in case of prosthetic joint infection, delayed onset or late onset, where you are expecting a less virulent organism like Peptostreptococci or Propionobacter acne, it is suggested to keep those cultures for 14 days. Otherwise, the routine incubation time in the laboratory is 5 to 7 days, but in these specific cases, it is advised to extend it to 14 days. The new age microbiology is quite equipped to help you get a better culture yield. We have enhanced liquid transportation or culture medias like Bactec or Bacti-Alert bottles. We have availability of automated incubation systems like Bacti-Alert, which provide round-the-clock monitoring of these culture bottle and flag the signal at the earliest when the bottle is positive. We have automated system for identification and antibiotic susceptibility of the pathogen. So the surgeon is precisely aware of the infecting pathogen. And then there are mass photospectrometry methods like Melditov, which can provide identification of pathogen in as less than 2 hours. So definitely these new technologies have reduced the turnaround time, have helped us identify accurately the organism along with its susceptibility pattern, and have helped us to increase the yield of the sample. These are the common specimens which we receive in microbiology laboratory from an orthopedic setup, and I'll be talking about them in detail in next few slides. Synovial fluid culture, very commonly sent to the microbiology laboratory. It has got a sensitivity of 72% with a specificity of 95%. Preoperative aspiration, if possible, is recommended because surgeon is already aware of the infecting pathogen and its sensitivity pattern, which will help him to modulate or decide his further intervention. The disadvantage might be negative culture. So what might be the reasons for this negative culture? Patient is already on antibiotic and inadequate quantity of synovial fluid has been sent to the laboratory. So here are some suggestions which can help improve positivity from synovial fluid culture. If patient is already on antibiotic, practice an antibiotic interval of 2 weeks. Keep appropriate culture or transport media ready in the operation theater and inoculate it directly, that then and there. Minimum 2 to 5 sets of the blood culture bottle to be inoculated with 2 to 5 ml of synovial fluid in each bottle, and Suggest or ask for appropriate culture test. Now, intraoperative periprosthetic tissue cultures. It has got a decent sensitivity of 78% with a specificity of 97%. Other advantages, direct visuals of infected tissue are available. Again, negative culture or growth of contaminant could be one of the disadvantages. Now, here I'll talk specifically about prosthetic joint infection, that minimum 2 or more than 5 samples are suggested to be sent from different quadrants of infected periprosthetic tissue. Cultures, they should be sent before starting antibiotic therapy or by practicing interval of 2 weeks. It is advised to perform aerobic and anaerobic culture on all tissue samples and mycobacterial or fungal culture on need basis, depending upon the clinical suspicion. Use of liquid culture media and thioglycolate broth for anaerobic culture is advised. Now here important thing is use of liquid culture media. In our institute, we have observed that previously we used to do the culture on solid culture media, the yield was very less. Once we shifted to liquid culture media, we have been able to improve positive yield by decent margin. Use of automated system will help to improve the yield, and again the extended incubation of 14 days is advised. Sonication of explanted implant. Now, this comes into picture when patient is already on antibiotic and it is not possible to practice the antibiotic interval. This method has a higher sensitivity than culture as the biofilm is detached and cultured. Stubborn pathogens like staphylococci, they can also be isolated, but it is a time intensive procedure. It is not feasible for a large implant. It needs special equipments. It is not available with every laboratory, and handling of large specimen, it may introduce contaminants and ultimately may hamper the results. So where is it recommended? It is recommended to be used in a setup in which sonication facility is available, suspected or proven prosthetic joint infections where preoperative aspirate cultures are negative, and antibiotics were administered previously and it was not possible to practice an antibiotic interval. So this is in short how it is done. So prosthesis, it is collected in a rigid sterile container. 400 ml of ringer solution is added. It is vortexed, sonicated, vortexed again. The fluid is centrifuged, aspirated, and is then cultured on a blood agar plate. As I have already said, swab cultures are less preferred over frank pus and tissue. So whenever possible, avoid sending pus swabs. Obviously, intraoperative swab culture has a limited role and it is not recommended. Blood culture. So whenever we are suspecting a septicemia, blood culture is sent to the laboratory. Volume of the blood in a blood culture bottle plays a crucial role. So as this graph is showing here, that 8 to 10 ml of blood sent in a blood culture bottle will yield a better result. So the volume matters. When it should be collected? It should be collected prior to the fever spike, before starting antibiotic, and before next due dose of antibiotic, if already the patient is given antibiotic. Minimum 2 set of blood culture is recommended, blood culture from 2 sites, to rule out or rule in contamination, and paired blood culture is advised if the patient is having a central line. For urine culture, midstream urine if the patient is not catheterized, or catheter port collection if a patient is catheterized. Again, it should be sent before antibiotic therapy, and urine catheter tips are strict no-no for culture in laboratory. Please send midstream or catheter port collection of urine. So this is in short what I have talked in previous few slides. So the problems and the solutions. So I'll again, like at the cost of being repetitive, I will again say that the quantity matters. Please send the samples before starting antibiotic therapy. Inoculate them directly into the culture bottle wherever possible. Practice longer incubation period, especially in case of prosthetic joint infections and choose appropriate culture methods. That's all from me. Thank you very much for your patience.
Thank you very much, Dr. Vaishali. That was a wonderful talk. And we'll go ahead with the next. Can you stop sharing?
Yeah, sure.
So we'll see if you have any questions. Yeah. So I can't see any question for you. So I would like to share the next Pixar question for prize. That is, yes. What is the single most important factor that contributes to maximum yield of culture positivity? So the option 1 is correct transport media. Second, correct incubation time. Third option, correct timing of specimen collection. And fourth is correct specimen itself. So whoever answers first in the chat box, so they'll be getting Pixart prize. And Madam, thank you very much for your wonderful talk.
Thank you,
And
sir.
yeah, I would like you to stay for some more time so that if we can have some questions on the chat box, we'll discuss at the next talk in.
Definitely.
Thank you so much.
Thank
you so much. So now I would request Dr. Uday Krishna to speak on diagnosis of prosthetic joint infections. Over to you, Dr. Uday.
Yeah, thank you, Dr. Srinivas. Can you hear me?
Yes, yes.
Yeah,
Start sharing.
yeah. Thank you, Dr. Srinivas, as being my colleague, and Dr. Somashekhar Reddy sir, and all the TOSA members. Can you see me?
We can see you, but still it is not shared. Screen is not yet shared.
Yeah, it's coming up between. Because as Dr. Andrew was speaking about the diagnosis, I'll touch upon the basics of diagnosis of a prosthetic joint, because it has been mostly challenging for us. Almost so many years we are working out for better identification of the organism. According to that, we'll able to have treatment options.
Not yet shared, Uday.
Yeah. Can you see? I'm trying to share now. Desktop. Yeah. Can you see, Mark?
Yes.
Yeah. Thank you.
Thank you.
Yeah. I'm exiting full screen, right? Yeah. Thank you, all the members, my senior colleagues, and my dear friends. The diagnosis of prosthetic joint infections is really challenging. As Dr. Andrew was mentioning, the timing is very important. So these are two cases. I think there's no need for any diagnosis whether it's infected or not. One is hip and knee. It appears that the pus is draining in the hip and in the knee. So it's rightly say that it's got grossly infected. This has to be addressed mostly a two-stage. If the organism is not found, again we have to think of any spacer. So this is the easy part. But the hardest part, what Dr. Vaishali was saying, is the identification of the organism. So for that, just I'll put an highlight for our younger colleagues who have started joint replacements, where we have learned throughout our career. So despite significant progress in recent years, the diagnosis of periprosthetic joint infections remain challenged, and no gold standard test exists till now. Because once the patient comes to us, our own operated case, definitely it'll be cumbersome for the patient and to the surgeon, as for the institute, where he has to spend a lot of money involving in multiple operations, and has the highest number of complications leading to stiffness, post-operative, and almost depression. And it seems that periprosthetic joint infection increases the risk of 1-year mortality. That is really a devastation. So it increased 5-fold increase compared to aseptic failure for prosthetic joint infection. So your aim is to identify a periprosthetic joint infection, how to diagnose. That is the key in success of the treatment. So making the diagnosis, the timing is very, very, very critical. Acute versus chronic. Acute again is divided into early post-operative period, where less than 4 weeks to 6 weeks, we can say acute post-operative period, where you operated your knee, he comes back with a huge swelling, then you start investigating suspicion of prosthetic joint infection. Late, it can be acute, like you have operated and the patient was doing well. Apparently, after 6 months or 1 year, 2 years, suddenly he comes with a huge swelling. Then you have to think of any hematologic spread, like from the dental unit tract infection or lung infection, wherever the source of infection, that has to be addressed and start investigating with the prosthetic joint infection. Chronic, the main issue with all the previous speakers, all they're trying to catch hold of the organism is a chronic infection, where it's very, very difficult to identify an organism. If you miss an organism in chronic infection, then your treatment really change. Like either a single stage, it may not be possible. You have to go for 2 stage. So when a patient comes to you with clinical presentation with acute infection, it's simple with pain, erythema, fever, effusion, that can be easily identified. And elevated serum biomarkers and laboratory tests will definitely show some conclusion. And microbiology, it always shows some plurulence, aspiration with a reasonable chance of culturing an organism. Adequate amount of fluid can be collected. But the problem is coming with the right hand, where chronic infection, pain is the main issue. We operate a case and routinely the patient comes every day follow-up for a few weeks, few months, and few years also with the pain, constant pain. The rest pain, that should be a lurk for you suspecting any chronic infection. That should be started investigating with the other biological markers or knee aspiration studies. Usually in this chronic infection or any negative culture, this one, all the radiological tests and microbiology, usually it will be normal. So what are the additional tests can help us to find out in this chronic infection? That I'll emphasize a few points. The main thing is how to think, simplified thinking, but not always correct. Acute infections involve predominantly in planktonic bacteria. Chronic infections involve biofilms. That is a very, very hard polysaccharide matrix, where if you see this diagram in a planktonic phase, where the bacteria are free around and it is definitely susceptible to the antibiotics, whatever you give and culture according to that. Once the biofilm forms, within few seconds to few weeks, where it forms a polysaccharide matrix, it protects itself from the piercement of the antibiotics, then it's very difficult to treat maybe as a single stage or debridement or retention of the processes. So your action should be there or to intervene to retention of the processes at the time of the early diagnosis, where in the planktonic phase with the bacteria free and susceptible to bacteria, or with a good debridement, you can save the joint. If you go late, then you form a matrix and biofilm, and it's very difficult to retain the product joint. So the culture, as Dr. Vaishali was mentioned, is the gold standard. It has been established since 1986, where COX was in COX or TB has been identified. We know the culture medium or the technique what we involve, knee aspiration or culture medium. It all depends upon the surgical dependent and also lab dependent. If you have an accurate fluid or exact amount of fluid or proper amount of medium to transfer, then definitely pathogen identification could be easy. Then you can plan according to your to retain the process or to revise for the 2 stage. So duration of incubation matters very most, because the Propionum acnes, which is a slow growing organism, it has to be cultured up to 2 weeks at least, so that you can identify the organism. So in fast moving organisms like staph, that can be identified. But the incubation period, when you see that you don't have any organism grown within 24 to 48 hours, you have to send for extended incubation period to identify the organisms. Problem with the biofilms, as I mentioned, it's a gold standard, doesn't work always. Because once a biofilm forms, you try to tap it, we always feel that it's a dry tap and no organism. Our microbiologists or our team members, they say that, sir, no organism been found, even with extended culture. That's a problem. That's a problem. The key issue is once the biofilm forms, whether to retain the process or to go for 2 stage, it all depends upon the timing and the identification of the organism. Culture negative up to 50% has been identified according to the literature. Is aseptic loosening is always aseptic loosening? Because this is an interesting article where 54 patients went with aseptic failure, where all the markers, CRP, ESR, cultures, all are negative. But when they found out that out of 54, 7 patients had, after sonification of the implants, they found positive for bacteria. So it, as Dr. Vaishali was mentioning, it requires a certain setup and a proper carriage, like 12 by 12 polyethylene bags, and it could have leaks. That's the main biggest disadvantage of this sonification bags. If it's not properly carried in a proper surface where our sonification is not done, then it have high false positives. But the results of this paper was showing that highest number of organisms were identified with the sonification fluid. So you can identify a number of organisms, or quantity of the organisms can be identified easily compared to your periprosthetic tissue or preoperative cultures. So the most important challenging is the getting the diagnosis in a negative cases. We always aspirate the fluid and it will be dry tap, the negative will be there, negative cultures, negative thing, what to do. So it all depends upon the clinical examination, and the further other biological markers can we have assisted, so that to getting the diagnosis right and to give a good choice for the patient. So diagnosing a posterior joint indirectly by using inflammatory markers, that is routinely used and easy and cheap, and some histological study. Serum biomarkers remain fundamental part of evaluation and diagnosis of hip and knee. It's very reliable, cheap, and it comes very fast. These are the first line of ESR CRP. When your patient sees that you're swelling of a little bit of swelling amount, you definitely send this blood test ESR CRP, the first line of screening test. But it lacks a specificity. That's the problem. If any inflammatory condition or existing any urinary tract infection, or any of the patient is having any of the inflammatory condition, it can't say it's due to because of the prosthetic joint infection. It lacks specificity. That's the problem. So it has to be supplemented with other microbiological tests. D-dimer appears to be promising, but more research is necessary. So the other, when you start suspecting of the prosthetic joint infection, then you start with knee aspiration studies. That is a synovial fluid WBC count and synovial fluid polymorphonucleosides counts, which consistent with American Association of Surgeons and International Disease Society of America guidelines, where it has both sensitivity and specificity. But true diagnostic results depends on successful aspiration. If you have a bloody tap, again it has a false negative. Or if the volume of the synovial fluid is very less, or the patient is not stopped antibiotic 2 weeks prior, then the results are not much effective and always confusing. And metal on metal articulation, especially in the hip, any region, it can give a false positive results. So each has its own merits and demerits. Similarly, this leukocyte esterase test, it has been involved in 2018 criteria of diagnosis of prosthetic joint infection, and MIS criteria as well. It's a simple calorimetric test type where you take an aspiration of the fluid from the joint, put some fluid on this test meter. If you have double plus, then you definitely see that it got infected. It gives a response, host response to this infection. So, but it has its own problem as well. Nearly 30 to 40% if blood tinged it is there, again, it has your decision making can be confusing. So in last decade, there was always a discussion about alpha densin, like whether it is highest specificity to diagnose a prosthetic joint. Definitely it has its own role, and it's involved in the ICM meeting, 2013 meeting, as well as in 2018 defined by the orthopedic surgeons, and consensus have come across where alpha densin has involved in the diagnostic minor criteria. Is an antimicrobial peptide released by neutrophils in response to pathogens. It picks up low virulence organism. That is a very important criteria. Unaffected by prior antibiotics. Of course, some may say, okay, affected, but some better to stop. The most authors say that the antibiotics should be stopped 2 weeks prior to taking a fluid. It has its all problems. It costs around $700 to $1,000 in US, and metal on debris gives false positive results. That is a disadvantage of this. D-dimer, we have already heard a lot about D-dimer and interleukin 6 in recent months due to COVID, and it has also has a role in identifying a prosthetic joint infection. Especially, it has a higher sensitivity and low specificity compared to ESR CRP. because D-dimer rises very fast, 1 or 2 days. If the joint is very, very acute, swollen up, D-dimers give you some sort of measurement, like up to 700 to 800 is normal. Above that, it is more. Then you're thinking of, okay, it could be an early source of infection. You go for debridement or no. But it's not recommended in patient with thrombus and hypercoagulation disorders. Further studies are awaited and necessary. We always feel that it requires more diagnostic test along with the biomarkers is the next generation sequencing is the future. As Andrew was saying, there is an app of this next generation sequencing is coming up where you put all the symptoms, biological reports on the app. It gives all the information whether the joint is infected or not. So it refers to a non-stranger based high throughput DNA sequence. It just sequence a number of species, like nearly 2000 to 2500 species you can identify. It has two types, 16-6 amplicon and shotgun metagenic sequencing. It is easy, short time, cost is less compared to other tests like alpha-densin. Can identify microbial profile of entire profile can be identified, especially bacteria, fungal, yeast, and organisms. And it's most useful where nearly 40 to 50% where cultures are negative. That can be picked up by next-gen sequencing. And polymicrobials. I always feel when we aspirate like the fluid, the first organism, what is dominant is staph, but we miss the other organisms might be there. That could be polymicrobials. That can be picked up by next generation sequence because that is utilized by mostly of the NSA, NASA sequencing technology. So that could be a future in this. So what is the current MSIS, Musculoskeletal Infection Society criteria and international consensus meeting recommended for diagnosis? And what is the new 2018 definition in diagnosis that will, I'll highlight a few points. Especially whatever I've spoken about, biomarker markers or an NGS or a different synovial fluid, it all comes under this criteria. If any person comes with your knee swelling, you should see all these points. That is very, very important. All the diagnostic criteria see that if there is any sinus tract communicating the process, just definitely it's got infected. If any pathogen, single pathogen isolated in a two culture, separate culture, definitely it's infected, then you treat according to your protocols in the hospital. And you have at least 4 to 6 of minor criteria: elevation, ESR, CRP, synovial WBC, and PMN neutrophils, presence of purulence in the affected joint, isolation of periprosthetic tissue fluid of one culture, and 5 unique neutrophils and high power field that has its own effect. So at least 4 out of 6 criteria should be identified saying that it's infected. The international consensus also has the same opinion, but it has divided between acute and chronic, where if you see in acute conditions, the markers are highly elevated and they involve leukocyte estrus strips, 1 or 2 places. It indicates that it definitely has infection. I put a small algorithm. It gives a small algorithm for whether the patient is comes with a normal CRP ESR. In our setup, it comes with a normal CRP ESR separate. What to do? But you find that your knee joint is a little bit of swelling, but your markers are normal. Then you go for joint aspiration. Do simple joint aspiration. Send for cultures. If the cultures are positive, then definitely infection is likely. If the cultures are negative or your minor criteria is not fitting in there, then the confusion starts. What to do next? Then repeat the joint aspiration. If you have any culture positive picked up, then your infection is likely. Then you treat according to your stage 1 or stage 2. But the problem lies with the dry tap. Normally the patient comes with 2 months, 3 months with we aspirate dry tap, nothing can be the thing. Then you think of other modalities like go for biopsy, or you do take help of the scans. Scans are weakly positive, or it can't differentiate between the aseptic and septic loosening. So biopsy can help you. So this is one more and last slide where in 2018 they have refined the definition of ICM as well as MSIS criteria, where those criteria are based upon the expert's opinion, but not on the evidence based. So the new definition has external validation, definitely has a database coming out where sensitivity is about 97.7% compared to Musculoskeletal Infection Society and ICM where it is 86.9, and specificity is 99%. So in this criteria, there is a score of about 6. So there is a minor criteria where it's in a preoperative score. If it's more than 6, then definitely it's infected. Between 2 to 5, then you're probably you to have assistance of any other synovial fluid cultures or any other assistance to take for to diagnose. Anything 0 to 1, it's not affected. In post-operative period, also it has a scoring where it's more than 6. Definitely it's infected. It's between 4 to 5. That's inconclusive. You need to take support of the culture medium and another knee aspiration studies or any other radiological or histopathological results. In less than 3, definitely it's not infected, and you can make sure that to patient to revisit so that you can check for the biochemical markers. So the final slide is take home message is the 4 pillars of diagnosis are very important. Your clinical examination, serum biomarkers, aspiration, and culture studies. These are very, very important. I feel that clinical examination is very important. Your biomarkers, whatever could be negative, but your clinical examination and history taking and your proper examination of the joint, it gives you a lot of information, especially in chronic infection where rest pain, it gives clue to that it has to be investigated more. In 2018, new definition in diagnosis of prosthetic joint definitely stands good. And interleukin 6 and D-dimers, it rises very fast and falls very fast compared to your CRP. It has to be keep in mind, and definitely it has a role in future. Alpha defensin, though it has false positive, but definitely has a good sensitivity. NGS has a pivotal role in diagnosing prosthetic joint infections. Thank you for that.
Thank you very much, Dr. Uday Krishna. Can you stop sharing, Dr. Uday?
Yeah, I'll stop sharing.
So there is one question to Dr. Vaishali. What medium do we send for the infected and surrounding samples? In how much time it needs to reach the lab? Can you hear Dr. Vaishali?
Yeah. I would say as early as possible, but a delay up till 1 hour is acceptable. Usually the laboratory is in the premises of hospital many of the time. So it is easily possible to plan to procure a culture media or a transportation media from the laboratory, keep it handy in the OT, inoculate it at the site to reduce the chance of contamination, and send it to laboratory as early as possible. The delay of 1 hour is acceptable.
Okay. Thank you so much.
Thank you.
And the Pixart question for this talk is, what is the percentage of routine standard cultures in identifying the microorganism? Option 1 is 0 to 25%, option 2 25 to 50%, option 3 50 to 75%, option 4 75 to 100%. So you can answer this in the chat box only. Whoever answers it first will have a chance to win Pixar prize. Let us move on to the next talk. Is by Dr. Vivek Trika from AIMS New Delhi, who is going to talk on local antibiotic delivery systems. Thank you, sir. Over to you. You're not audible. We can see your screen, but not audible. Dr. Vivek, sir, we are not able to hear you. The voice is not audible.
Okay.
Yeah, now it is.
Now you can hear me, right?
Yeah. Thanks.
Okay, fine. Sorry.
Can you hear me now also?
Yes, perfect.
Okay, so we will be, after looking and listening to the various talks on infection, how to diagnose it, we will be coming to looking at the various antibiotic and the local antibiotic delivery systems which are available for us in the infected cases. What our learning objectives are going to be to understand the indications for these local antibiotic delivery system, and to analyze what are the various types which are available to us, and the rationale and the various benefits of these local antibiotic systems. We all know in infected cases, we require most important things is radical surgical debridement, excision of devitalized tissues, proper soft tissue coverage, and along with that, antibiotic therapy. But what happens in an infected case is we all have seen that there can be a biofilm which requires the antibiotic concentration of even up to 100 times what we actually give in a systemic antibiotic, which may not be feasible to give because of the various adverse events. There is improper blood flow, which may not allow the exact amount of concentration of the antibiotic to reach the place where we want it to. And hence, if we are not able to do that, the high concentrations are not reached, then it cannot. And if we are able to do that, even then there will be systemic complications which are there. So ideally, in ideal circumstances, what exactly should be the ideal antibiotic delivery system? It should give us local systems and deliveries of antibiotics. Just like if you see 40 years back, bronchial asthma was treated by systemic relaxants, muscle relaxants. But now with the local inhalers, the treatment of asthma has changed dramatically. The same thing we might be requiring, especially for after controlling the systemic thing, the local effects of the infection. So we require controlled and sustained release of antibiotics. If possible, provide physiological loading support, low exothermic reaction, and to ask for much more if it can provide us a scaffold absorbable one where the bone can regenerate in a case of bone defect. That will be the most ideal thing which we can ever think of. There are two types of antibiotic delivery systems at present. One is a non-resorbable ones like the PMMA based cement type, and the other ones which have recently come up, especially in our country, and I'll be focusing only on those ones which are available to us, are the biodegradable ones. They include the bone graft and the bone substitutes, protein-based natural polymers, and the synthetic polymers also which have come. If we start with the antibiotic-loaded bone cement or the local, which is the most common local delivery system which we are using, we find that it was started with gentamicin beads. It filled the dead space after the debridement, and it was in 1979 they found that they had quite a good success rate when they treated it in chronic osteomyelitis and put in the beads and the bone cement out there. So how do we select any antibiotic for a bone cement? We have to have an elution in high concentration from that. It has to be a thermostable antibiotic which we have to give, because remember, when you are putting in the cement, then at the time of its mixing, it goes up to 80 degrees centigrade, the temperature. It has to be bactericidal, and it has to be effective against the most common microbes which can be there, which may be Staph aureus and the gram A beta hemolytic streptococcus and the gram negative bacteria. Most of the common types which we use are the aminoglycosides and the beta lactam agents which can be used here. How much antibiotic and dosage can be used? The maximum if you can use and go about is 20% of the amount of the bone cement. Usually you go around 10%. Addition of more than 10 to 12% will significantly weaken the bone cement which is there. And the antibiotics added in liquid form drastically reduce the cement strength. Hence, they are not used, especially in bone cement. We do not use antibiotics in liquid form here. How does it elute? How much time does it take? Remember that whatever antibiotic you are giving, it goes only up to 10% is only released. And in bone cement, the maximum rate of elution is in the first 3 to 4 days or 7 days maximum. So if you are going it for the first 1 week, you will have the highest concentration, maybe 100 times the MIC levels, more than 1,000 times also. But later on, it is not giving us the high antibiotic release. And the amount of the antibiotic which gets released, it depends on the sizes of the bead, and higher the surface area, more is going to be the elution. So you have to make having a much more surface area should be there. And that's where the beads come into play. The beads having as high surface area as possible. Any limitations of ALBCs? High exothermic, as I said, 80 degrees centigrade can be there. So only powdered antibiotics are used. Only limited elution is possible, that too from the pores and the cracks of the cement. And that makes it slightly less viable for us. Non-biodegradable, does not participate in bone healing to the biggest of extent, though it creates a membrane which can be used. If you are not removing it after 28 to 48, 20 to 30 days or 3 months maximum, remember all the antibiotics have eluted. So at that time, it can act as a foreign body acting as a nidus for infection. And that is what many a times can bring back the infection and the layers and the biofilms which can be there. So that brings us, it is a very commonly used antibiotic loaded bone cement, but what we want is a bioresorbable ones if they can be available to us. People have been using collagen based, which has been the septocols which have been we using. But the negative point of these septocol which we were using is it has got a very short elution time. It is in hours, if you can see. The 100 MIC levels and the concentration levels 100 times, within 3 to 4 days, it goes down dramatically. So it is below the therapeutic level even. And various studies have shown that they can act only for the initial 2 or 3 days, these septocol or the collagen beads or the collagen part based material which we are using. There have been in the recent 3 to 5 years, newer ones which have come, which are using calcium sulfate. And the commercial one is there, which is available in India. These are patented things. The benefit of them is it is completely resorbed in 6 to 8 weeks, they say, but actually in our experience, it is from 3 to 6 months that you will find that it completely resorbs and goes away from the X-ray shadows even. And that will help us by giving no nidus for biofilm formation later on as a subsequent secondary nidus. The benefit of this is, though it is not said that it is wide range of antibiotics can be used both in powder and the liquid forms, and a long time of sustained elution is possible up to 3 to 4 weeks by these sort of resorbable LADS systems. If you look at this graph, you will find that the MIC levels and the concentration of the antibiotics of most commonly used gentamicin, vanco, and tobra up to 28 to 30 days remained around 800 to 500 to 800 times levels which we wanted as an MIC part. After 28 days, they decrease, but not to, even then they are up to 30-35 days, up to 100 times they are still there. But what is more important is in the first 1 month, the standard time of antibiotic treatment which we have been giving for the first 6 weeks for the infection treatment, at that time they are giving us more than 100 times the antibiotic concentration which we require at the local area, and later on they resolve. And this is what makes it the most useful thing. In my hospital, the flora has changed dramatically. It is now a very, not the Staph aureus which we are worried about, it's the gram negative, coagulase negative ones which are causing us problems. And the most common antibiotics which we find sensitive are the colistins, the tigecyclines, and the carbapenems, vanco and tobra. So most commonly what we have to use are the colistin, tigecycline, and vanco tobra. And all of these can be used with these local antibiotic delivery systems, and you can mix them with the calcium sulfate, and then you can use them as a local system. This is how we prepare it. You can see we have added this tigecycline out there that will give us the orangish sort of a color. And once you mix it, remember that there are certain and setting times changes when you put in the antibiotics in them. So you have to be cautious. Like tigecycline, I would say from my personal experience, it takes nearly 30 minutes for it to settle down. So while we are doing the debridement and the other stuff, we have somebody is already preparing this with tigecycline. And when we make this, finally, you will have this powdered form with having a high concentrations of tigecycline, which can be used. And 30 minutes is the time. Otherwise, you get frustrated, you are impatient, and then you try to put in whatever way you can inside for the local debridement system. So many of these cases have been used, and you can see after 3 months, it looks like completely resolved and hopefully has given the effect which it was there for. Another case, a lot of infection out there, change the product, change the implant fixations, and put in stimulant helps us. Besides giving systemic for some time, if you want, you can definitely add these local antibiotic, which will give a very high concentration of antibiotics and can get resorbed. Later on, you can see that how resorption happened and some form of bone formation is also there. Even when you are infected, implant removal is being done. Maybe at that time also to prevent the flare-ups, you can do. This is a very old case with a lot of skin, which was skin grafted circumferentially. There also, after opening up, when we put in the nails and after shortening, these act as giving a local systems for us. So a lot of wide usage of calcium sulfate is there. There is another one which is available in our country, which is calcium sulfate with hydroxyapatite. And that has 60-40 concentration of that. It can be used as a paste and can also be used to fill the voids and the gaps which are available there, because it takes the shape of those voids and gaps. It is said because of the hydroxyapatite that it can help in delivering the antibiotics and also promote bone healing by providing the scaffold. But remember that both these local antibiotic resorbable systems are quite expensive right now, and we do require some made in India indigenous way of using these calcium sulfate or calcium sulfate hydroxyapatite baited things, where we can put in antibiotics and give these local antibiotic delivery systems. If we look at this CS, calcium sulfate with hydroxyapatite, it also gives us the MIC levels high elution till 28 days. And there have been a lot of papers from UK, Martin McNally and other people who have said that this can be used as a more patient-friendly treatment compared with other modalities which are there, because it gets resolved and avoids a resurgery most of the time, which has to be done with a lesser expensive, more effective bone cement antibiotic delivery systems. So in many of the cases where there's infection, you are opening up, debriding the thing, having a bone void, you feel that you have completely debrided, then you can add this liquid paste sort of a system which comes with only gentamicin. The problem is here is you cannot add antibiotic of your choice. You can use only gentamicin, which is pre-made and commercially available. You cannot add gentamicin of your own concentration in this, and it is highly expensive also. The other problem with this is that you require a bloodless field most of the time to put in that jelly. If you do not, then it will come out. So sometimes you make them into solid form and then put them there so that it does not have and resorbs and comes out fast. There are newer materials which are coming up, like chitosan based and polylactide and PLGA based materials, which are coated for the antibiotic nails which are available. And sometimes the newer ones which are coming up are the antibiotic coated plates also coming up, not yet available in our country, mostly specially made to order they are. But many of these are there which can be used for the nails which are there, especially with gentamicin, sometimes with other aminoglycosides as well. There are other newer modalities which are being thought of, like bioactive glasses, which can provide scaffolds also, along with antibiotic delivery system, which will help us for bone healing growth. I told in the beginning, the ideal one which is going to be there will be which can get resorbed, gives higher antibiotics to us, and also provides the scaffold where if you inject later some osteoinductive or osteogenetic potential things, it also leads to bone formation, especially in trauma cases where you need the bones to unite as well. So finally, I would say that local antibiotic delivery systems are the things of the future, and a lot of work is going on right now, which will help us to improve the therapeutic outcomes. Till that time, our cheaper friend for us is the antibiotic loaded bone cement, which can be used and very effective, but needs a second surgery. The other ones, as I said, are much more promising right now. And many other strategies of biofilm disruptors, some immunotherapies, and bioceramic materials of bioactive glasses are the things which are being used and being investigated as the modalities of near future. Thank you very much.
Thank you very much, Dr. Vivek. That was a wonderful, comprehensive talk on local antibiotic delivery systems. Can you have stopped sharing? I'll just put up a question. Yeah. So the next question for Pixart prize is: different antibiotic types can be used, and which type of delivery? Sorry, I lost the question. Just a minute.
People have already answered.
Just a minute. Meanwhile, you have one question from Dr. Ashok Gavaskar. Can you ask Ashok directly?
Yes, Srinivas. Yes.
Yeah.
Hi, Vivek.
Hi.
Do you use any specific combination in PMMA or like single antibiotic?
No, normally the most common one which we are using is vanco and tobramycin, and we are using that's the highest because it has been shown in various studies that the combination of vanco and tobra is having not a supplement, it's a geometrical mean sort of an effect. It increases the effectivity of the individual antibiotics more than 100% of tobra and vanco.
Yeah.
So we normally try to use. The problem is to get them in powder form in India, and that is something which is truth
Yeah,
problem.
tobra in powder form is not routinely available. Yeah.
Yes, so that is a crucial thing. We sometimes have to get properly with the other people. That's the thing.
Right. Thanks. The question is, in which type of antibiotic delivery system you can use both solid and liquid? So option 1 is antibiotic loaded bone cement. Option 2, resorbable LADS calcium sulfate. Option 3, collage based local antibiotic delivery systems. Option 4 is antibiotic coated nails. So you can answer this in chat box and have a chance to win a Pixart prize if you answer it. Those who answer first. Yeah, let's just move on with the next talk, which is related with the same local antibiotic delivery systems by our Dr. Somashekar Reddy sir, TCOS president. Sir, over to you.
Yeah, thank you.
The topic is cement debonding. Is it a problem with antibiotic cement coated nails? To me, it is yes. Sir, over to you.
Is sharing on?
Yes, sir.
Right. Yeah, I think I'll just continue the same philosophy started by Dr. Vivek Trika about the local antibiotic delivery systems. These are the cases where the infection is diagnosed and confirmed already. Now the question is that, okay, how to treat it? Now the different ways of treating, now with the advent of antibiotic deliveries, local antibiotic system, we have got various systems in place, but we are experiencing some problems of that one, and which Dr. Trika mentioned about the cement actually acting like a source of nidus in later on if it is not removed. In that connection, I would like to start this talk. What is the problem here? Infection in the medullary canal, which is secondary to either open injuries, coated with antibiotic impregnated cement. So the antibiotic cement coated nails have come into place. They serve two purposes. One is local delivery of the antibiotic in high concentrations. But another advantage of cement, despite whatever side effects, what he has, disadvantages it has, is that it also works like a spacer to avoid dead space, preventing contractures in hips and knees, and in which the other modalities, however good they are, because they are dissolving, they can't offer this particular advantage to us. Now, coming to antibiotic cement coated nails, what are the problems particular to these nails? The cement actually, which we want them to be sticking onto the nail, it won't stick well. So the debonding or delamination of the cement, and so the persistent focus of infection, and they block or they interfere with the next definitive procedure, whatever we may want to do. So going into how and when the debonding happens and what is the remedy. Is there any special nail or a special process to stop or prevent this cement debonding. Now, when does this debonding happens? The debonding can happen while actually preparing. We have antibiotic coated cement in a bowl and a nail in the hand, and most of the cement, while trying to apply onto the nail, most of the cement may end up on our gloves. It won't even stick to the nail properly, and it's a difficult process to put the cement onto the nail. And other common reason is while inserting, especially in some segmental defects. Here in this case, you can see by the time the spacer got inserted, the lower half of the nail has almost no cement, because while putting itself, the cement coating has come off. Now, other common area when we come across this debonding is at the time of removal. Somehow you managed to coat the nail well and you inserted the nail, and once the infection is controlled, fracture may or may not have joined, then you wanted to remove the cement coated nail, and unfortunately, the nail easily just slides out of the canal, leaving the entire cement mantle inside, like as in this case. And we may end up like opening the fracture and removing the remaining almost all cement mantle from the bone. But in this particular case, we are in a way fortunate because the fracture has not united. So we have to open the fracture site anyway, and we managed to remove the cement. Imagine in this case, the fracture has united, but the infection has persisted. Because the fracture has united, there is no way of going in, and infection has persisted, and we have to remove the cement thing, but we can't remove from the top. There is no way we can remove all these bits. But in this particular case, because the non-union, who opened the fracture, got everything out, and then, okay, did the other definitive procedure. So now the question is how to prevent the debonding. The reported complications of delamination or debonding is up to 20% of the total cases done in different series, but no solution how to prevent it is reported in the literature. So there are techniques which were described and tried is allowing time for the cement to set well and bond with the nail. So while preparing, you have to be a bit patient and try and make sure that the cement really sticks to the nail well. That's one technique described. And adequate water reaming so that the canal is spacious, and while pushing it, the cement may not come out of the nail, and without using any force, drive the nail by hand. And maybe punctured nails or slotted nails may be better because the cement may go into the slots and may allow it to stick well. And some matte finished nails, which are titanium matte finished nails, and some nails with threaded core. These nails are not available to us, and in places where they are available, they are expensive actually. And after all these things, we had to hope for the best that there is not going to be any cement debonding, and while removing it, okay, it will come. So, but otherwise no specific solution. So we thought that we have to devise some technique. We'll try some technique which may help to prevent or decrease the debonding. And we started a special way of preparing a nail, which is encircled with a wire. The procedure is the same: thorough debridement, reaming, wash, and correct antibiotic to be selected after discussing with your own hospital microbiologist, and select a nail or a pin depending on the diameter of the bone where you are using, which is should be the nail or pin should be at least 4 millimeter narrower to give room for the bone cement coating. So if you use a reamer of like a 12 size, the nail can't be more than 8 mm diameter, and select a wire. If it is a hip with a roomy proximal femur, maybe 22 gauge wire. But if it is 18 gauge wire, and if it is a narrow canal tibia or something, use a thinner wire, which is a 22 gauge wire. So this is how we prepare. Select appropriate sized nail or a rod or whatever. And in this case, in a tibia scenario, use a thin wire, which is a 20 or 22 gauge wire. In case of a hip implant, we used a 18 gauge thick wire. So you can see when it has served its purpose after 6 weeks to 12 weeks, when we think that we are ready for the second stage definitive surgery, when we go in, when we want to remove the wire encircled nail out, you will get the process like that without any remnants of the cement being left in the medullary canal. So going a bit, if somebody wants a more detailed information on these antibiotic coated nails, the indications, how to use, and these are the two papers is with Vasco et al. And Macredis et al., which are quite informative, and the juniors are advised to actually refer to these papers. Thank you.
Thank you so much, sir. Sir, so even I had a problem 3 years back, but after going, observing at Dr. Samir Mehta at University of Philadelphia, I started using simple threaded rods of Ilizaro, and I don't have any problem since then. So I've been using for the last 3 years now. So simple threaded rod with your ET tube.
Yeah, yes, Srinivas, I agree. Like that works best.
Yeah.
But like if you want to use an interlocking nail, I would suggest a technique like you can the same wires. Like you don't have to sort of like go through the entire thing, but you can just use it on the distal aspect to increase the diameter of the tip, so that like when you pull it out, that wire sort of like takes all the cement out. You can see a video on YouTube under the name Fabricio Videla. He was a colleague fellow in my Denver Health, like he has described it. It works pretty well.
The one thing which you can, like Srinivas was saying, was the crucial thing in that chest tube is use a 40 French chest tube if you can. If you are using the regular 32 French or 28 French which are available, they will give you with the Ilizarov threaded rod only a 6 to 7 mm diameter nail, which will not prevent your rotational stability. So try to use 36 or 40 French, which will give you roughly an 11 millimeter, 10 to 11 millimeter with the cement coated on the nail. Otherwise, the rotational stability you might not get with that threaded rod of Ilizaro.
Thanks, Dr. Somashekhar, sir. Let us move on with next talk. So for a change, Dr. Ashok, can you just start with your talk, a mild change in the program schedule? Dr.
Oh, mine is it? Okay.
Prasad, sir, yeah, wants to talk after you. So fracture related infection, ways to avoid ring fixation. So probably this local antibiotic delivery system must be one of the ways. But over to you, Ashok Sunil Gavaskar.
Yeah, thank you. Can you see it, guys?
Yeah.
Just a moment. Okay.
Yes.
So I would be speaking on fracture-related infection, focusing on techniques for bone healing without the ring fixator. I'm not able to progress. Srinivas, can you hear me?
Yeah, I can hear you.
My screen is stuck. I'm stuck actually. 1 minute. It might be 1 moment. I'm not able. It's just completely stuck. Not able to.
Probably you may have to escape. You can press escape.
Not able to
use Mac, right?
Escape. Yes, not able to escape as well.
Okay.
One moment. No, nothing works. Can I log out and log in? So can I probably
sure. Meanwhile, we'll take a question. Yes, sure. You can log out and come back. So there is a question. Is there still a place for continuous closed irrigation as a modality in bone infections? So you can answer, Dr. Vivek Trika. Can you answer this? Is there still a place for continuous closed irrigation as a modality in bone infections?
Difficult question to answer. We have not been using it, but yes, if I look at the literature, there are reports and people are still using it, but in a constrained environment. That's what I would say, because there are much more newer modalities which are available, which you can use for doing the same thing.
Got it. Sunil, you can enlarge your screen. We can see your screen.
Yeah. Is it okay now?
Yes, yes. Just check whether it's moving.
Okay. Yeah. Okay. So fracture-related infection was not properly defined actually, like until recently with the sort of interest in prosthetic joint infection. So the fracture-related infection consensus group also started defining this based on certain criteria. So they defined a set of 5 confirmatory criteria and then few more suggestive criteria. So the confirmatory criteria, they described initially 4. If you look at them: presence of a fistula, sinus, or obvious wound breakdown. If you have a purulent discharge, either through the wound or during exploration. If you can culture pathogens, 2 separate cultures on deep tissues or from implant surfaces. Or if you can demonstrate microorganisms during intraoperative exploration, which can be demonstrated by histopathological examination or by specific staining techniques, including the ones for acid fast bacilli and fungus. So if you can sort of like have either one of these criteria, then it confirms your infection. So, and then like, sorry, it's getting stuck again. So like, and then the Oxford group finally added one more confirmatory criteria, which is especially useful in chronic and late cases. So this is like when you are doing surgery and take deep tissue cultures, if you can demonstrate greater than 5 polymorphonucleus cells per eye power field, it is also a confirmatory criteria for fracture-related infection. So if you can either have any one of these 5 criteria, it more or less confirms your infection. Apart from this, you may not always have confirmatory infections. Infections may not be very obvious sometimes. So you have to rely on suggestive criteria to suggest you that your fracture that you are dealing with might be obviously infected. So some of this include clinical criteria like local redness, warmth, or other signs of inflammation. Also look for systemic signs like fever. You have to rely on imaging modalities, most commonly X-ray, where you can see periosteal reactions, osteolysis around the fracture, and more importantly, lack of progression in fracture healing. Nuclear modalities like white blood cell scintigraphy and FDG PET have been shown to be extremely reliable. And
Dr. Ashok,
yep.
Yeah, the screen
Yes.
sharing is not there.
Oh,
We could see
I'm
only
really
your
sorry.
face.
So, okay, I think one moment, like again, like
Start share screening.
Can I be seen? Can I be? Am I audible?
You are seen.
Your face only seen.
Yes. Yeah, I know. I haven't started sharing right now. I don't know, some problem. I'm sorry about it. Okay,
Yeah.
so
Now it is seen.
fine. Yeah, so I think I need to keep the tab on my right. In fact, if I minimize it, it stops working. I don't know why. So okay, like imaging techniques like white blood cell scintigraphy and FDG PET have been shown to be very useful. And in fact, if you look at the recent studies, these 2 techniques have been shown to be highly sensitive and really specific as well. Though we have included them in suggestive criteria till now, these 2 techniques can be really useful if you are not getting any confirmatory criteria to suggest you that you could be dealing with an FRI. Apart from the imaging, you also have to look at laboratory modalities like the most common ones that we use, CRP and ESR. These not only help you to suggest infection, but also helps you to track infection after you start treating them. Presence of suggestive criteria lets you know that you need to look further for confirmatory criteria. But if you have only suggestive criteria, not any confirmatory criteria, and if you have a high index of suspicion, you can still go ahead, use your clinical judgment and treat them as FRI. So some of the basic principles that you need to follow in treatment of fracture-related infection, it involves two broad categories: surgical and antimicrobial treatment. Antimicrobial treatment has gone by leaps and bounds. Like we know that based on recent evidence that long-term antimicrobial treatment is not often required. What we follow is 7 days of intravenous therapy, culture appropriate, followed by around 5 weeks of oral therapy if we have removed the implant, and around 12 weeks of antimicrobial oral therapy if we have retained the implant. But this is on base with our multidisciplinary treatment team, but you can have your own because the duration of antibiotic prophylaxis is not well defined in literature. With regards to surgical treatment, it depends on whether you have a fracture that has healed or you have an unhealed fracture. It's obvious that if you have a healed fracture, your job is going to be easy because you can remove the implant. Otherwise, you got to be you got to follow certain principles. Some of these are highlighted here. The first and foremost is like you need to get good soft tissue sampling. Superficial cultures or swabs are not reliable. You need to rely on deep cultures. You have to focus on adequate debridement, which includes both the bone and the soft tissues. Your fractures need to be stably fixed because if your fracture is unstable, it can propagate infection. Dead space management is important, again, focusing on both bone and soft tissues. Local antibiotic delivery systems have shown to be really useful, and that is almost a must in this era. And finally, you also have to focus on getting your soft tissue covered to bring in back the blood supply and to support fracture healing. So these are some of the key principles that you need to keep in mind when dealing with FRI. So keeping these in mind, our treatment goals in FRI are we need to heal the fracture, heal the soft tissues, restore function for the patient, and control infection, either by eradication or by suppression, because not always eradication is possible. And how to achieve these goals? You can either do them by retaining your implant or by exchanging implant, which might be done in more than one stage. And whatever you do, which will depend on quite a few number of factors, which I will discuss subsequently, you need to do them under cover of appropriate antimicrobial therapy. And remember, when you're dealing with FRI, eradication of infection is not always a goal, and in fact is not always necessary, unlike prosthetic joint infection. So how to decide whether to retain your implant or to exchange it? These are some of the key factors that you can consider when you are dealing with an infected implant. The first thing would be the time after injury or fixation, because the longer it takes to sort of diagnose or deal with infection, you are always already dealing with biofilm formation, and fracture healing also becomes a difficult problem. And the success that you can achieve by retaining the implant in a fracture that is 6 months old is much lesser compared to a fracture that is 3 weeks old. So if you are sort of going anywhere beyond 3 to 6 weeks, your success rates with retaining the implant drastically comes down. The second thing is to look at your construct. Either it could be a nail, plate, or whatever, whether that construct is stable. If you have a stable construct, there is a possibility to retain them and still sufficiently treat infection. The next thing you need to look at is whether you can do a sufficient debridement of both bone and soft tissues. If you have a plate, it obviously allows you to debride sufficiently the bone as well, but if you have a nail, it becomes difficult because you do not have access to the zone of infection. You also need to consider what kind of infection that you are dealing with. Is it a single microbial, polymicrobial, fungal? What kind of antibiotic sensitivity pattern that you have? Can you eradicate infection, or you'll be able to only suppress it? All these things need to be taken into account. Location can also be a factor, because if you are dealing with articular infection, sometimes your debridement have to be conservative because you can't sacrifice key articular segments. And finally, look at what kind of soft tissue environment you have, improve it if you need to. And also do not forget the OST quality, whether like it is immunocompromised or immunocompetent, because that can have an influence on how you treat them. So obviously, as I said, if you have a yield fracture, it is much easier. This is a patient who was 60 years, who had an IM nail for a tibia fracture 2 years ago. Said he was diabetic, had delayed infection. The nail was removed. He says it was debrided. The note says as well. And he presents to us with a CRP, which was I. And you can see there is a confirmatory sign as well. The fracture has healed. There is no implant inside, but you can see a sinus there. And it is obviously easy to treat this one rather than treating an unhealed fracture. So we went again, debrided it using a RIA. This is a first generation RIA which starts from 12 mm. So you have to be very careful if you're using it in a tibial fracture, because like sometimes most tibias may not accommodate a 12 reamer. We also did a local flap to improve vascularity, debrided using a cortical window, remove the sequestrum, and then use a humeral nail as an antibiotic coated nail, and then left it there. The patient got better, his infection was controlled. The nail was not removed. Of course, this is debatable. There are evidences to support that you can leave an antibiotic coated nail inside. And there is some evidence to suggest that a PMMA, if it retained for a long time, can harbor new infection as well. So that is an individual call. So this was a 52-year-old female who had an MVA, initially operated at 2 centers, underwent multiple arthroplastic procedures. And finally, as a definitive one, she underwent lateral lock plating on the right side and an intramedullary nail on the left side. And this was I will deal with only on the right side because her left side is still undealt with. So this is the right side, this is the initial X-ray. And if you look at this as a construct, okay, this construct looks reasonably stable. And even though I probably won't take this construct when I do my revision, but like this is something like a stable construct. So your construct stability is important when you consider treating FRIs. But when she presented to us around like 3 or 4 months after her initial injury, she had a history of recurrent sinuses. This is a soft tissue. She didn't have any active sinus at that time. She was wheelchair bound. We made her walk full weight bearing on the left side because there was a nail inside. Her CRP was raised, and these are the X-rays. You can see the screws getting loose right now, and the fracture is unhealed. And this is what we did when we went inside. We were able to debride adequately. So that is what a plate allows you. It gives you access to debride your zone of infection. So we debrided adequately. Thought about a single stage, adding a medial plate and grafted, but our intraoperative frozen section showed greater than 5 polymorphonuclear cells. So we decided to do it in stages. And this was after the first stage, application of an antibiotic called cement spacer. And at stage 2, after around 5-6 weeks, we went in, sort of added a medial plate, bone grafted, and we also improved our local blood supply by adding a flap cover as well. And this is at 3 months. You can see good consolidation, and she's weight bearing as tolerated on this side too. And we have now started focusing on our left side. A similar case, again, a young female operated a couple of times for distal tibial shaft fracture, history of recurrent infection. And this is the initial construct, the second surgery. But like, if you come to me with this construct, I have good access to that zone of infection again. But when she came to us, she had already had a couple of screws broken. So we revised her construct, put in a cement spacer. And then at 6 weeks, when the CRP came down, did intramembranous bone grafting. And then these are our serial X-rays at 20 months. You can see good bone consolidation, and an infection never came back. So another thing to focus is like whatever construct, either plate or nail, it has to be stable. It has to hold the fracture well. Apart from giving you access to debridement, the construct stability is an important factor as well. This was a young male who had an open fracture, which was inadequately debrided outside, fixed inadequately as well. When he presented to us 3 weeks after the initial injury, he had an unstable fracture and also a draining wound. These were the initial clinical image and the fracture. No way I'm going to retain this construct. So obviously I'm going to revise it and also add some soft tissue cover to it. So if you have an unstable fracture situation, if you have a construct that is not holding the fracture well, it leads to continuous movement at the fracture site, which promotes ongoing soft tissue trauma, interrupts neovascularity, promotes further osteolysis. And all these factors can facilitate further implant loosening and bacterial proliferation. So it is important that you have a good, stable construct, either internally or externally. So this is what we did at stage 1. We debrided it, improved our soft tissue cover, gave our local antibiotic, and then fixed it in a stable manner. And then once the wounds were all settled down, we went again and did posterolateral bone grafting, removed the spacer from posteriorly, and then did a posterolateral bone grafting. And these are the X-rays at 16 weeks. You can see good consolidation and synostosis. So this is another young 29-year-old male who had a femur and a tibia fracture. History of wound healing problems, both femur and the tibia. He had 2 tibial platings, and this was 5 months after injury. As you can see, the fracture is not reduced well. This is also not an appropriate construct for this fracture. So we went again and debrided and then put him on an external fixator. He grew positive cultures and we had put him on culture specific antibiotics. And this is at 6 weeks where we wanted to did a intramembranous bone grafting and then convert him into an intramedullary nail. But he was not ready to undergo another internal fixation. He was just adamant that he will not have another nail inside because of his wound healing problems in the femur as well. So we sort of continued the fixator, and this is at 24 weeks. You can see that it is not happening. The bone is not healing, and so we then converted into a ring fixator, sort of like made him to weight bear, and then compressed the non-union, which went on to heal, and then we removed the frame, and he's doing pretty well, and his infection also never came back. But when you are dealing with intramedullary nail, it is a problem because you do not have access to the zone of infection unless you remove them, unlike a plate. So this is a case, a 48-year-old male, motor vehicle accident, closed fracture, operated 7 months ago, complaints of pain on weight bearing. He was dynamized, and now he presents with a sinus over the fracture site. And you can see the fracture is not healed as well. He has got raised inflammatory markers. So if I'm going to debride this fracture at this point of time, it is very unlikely I can retain this implant. So this is a study that we did for International Society of Fracture Repair. If you can look at it, intramedullary infection after nailing goes through 3 stages, from bacterial cellulitis to frank intramedullary osteomyelitis over a period of time. So if anything beyond 6 weeks with an IM nail, if you're going to retain it, the chances that you might fail is quite high. So if you look at both the literature and also the experts that we surveyed, most experts and the literature would agree that beyond 6 weeks, we have to employ techniques that remove the nail, adequately debride the intramedullary canal, and then use an alternate mode of fixation. It could be another nail again, or it could be an external fixator too. So that is what we did. We removed the implant. We put in an antibiotic-coated guide rod with vanco and gentamicin. The cultures were positive. We are gram-negative organism, which was sensitive to ceprofloxacin. So if it's sensitive to ceprofloxacin, that means we know that eradication of infection is possible because it is a biofilm active antibiotic. So not all antibiotics are biofilm active. So like you need to keep that in mind. Rifampicin is one antibiotic which is effective against gram-positive organisms, biofilms, and fluoroquinolones against most gram-negative organisms. So we know that we could eradicate infection in this case. And after 6 weeks, like we went ahead and did an exchange nailing with a more robust nail. And this is at 4 months. You can see 3 cortical bridging except the medial side. And he had no pain on weight bearing and was pretty comfortable. Another case, similar principles, 67-year-old female with initially external fixated with a flap cover and then converted to a nail. Fulminant infection, discharge, raised markers at 4 months. She was initially removed, the nail was removed and she was casted, but it didn't help. She had persistent discharge, instability. And at this time, we went again, did a thorough debridement again with the RIA, removed the segment of bone which was necrotic. And then we used a technique that we had published in recently, where we used a supportive cage to share the loads after intramedullary nailing. It also helps you to contain the graft and promote osseointegration. And this was at 6 months. You can see the bone defect has consolidated. You can see bridging of bone both inside and outside the cage. And the patient was weight bearing from day 1 after the 2nd stage procedure. And final case, like to highlight the os status, this was a 52-year-old male who had a motor vehicle accident, who had a closed tibial shaft fracture. He had no injuries. He is a diabetic and had a history of CAD. And he was nailed in this manner. I don't have his pre-op X-ray, so it was a straightforward tibia fracture. So nailed in this manner, allowed weight bearing as tolerated, discharged 2nd day. But he presented to us on 14th day with increasing pain, knee swelling. The wounds were okay. And his random blood sugars were 420 milligrams per deciliter, was way through the roof, and his hemoglobin A1C was 13%. So we aspirated his knee, which confirmed infection. It was purulent, so we went again and debrided him first, retaining the nail because it was only 14th day, put in some calcium sulfate cement, and his infection was extending above mid-thigh. He underwent semi-extended nailing through and lateral parapatellar arthrotomy. He had fulminant infection going up through the proximal thigh. We had to debride him, but he didn't settle down. and he continued to drain. And then we did a second debridement. This was the image after the second debridement. We removed the nail, put in a guide rod, coated with antibiotics and an external fixator. And his sugars were always fluctuant, we never achieved good glycemic control over a period of time. And we decided to retain his fixator as long as possible. His wounds healed, his knee ROM was regained, and this is at 18 weeks when we removed the fixator after dynamization. And this is him after some time. We sent this image yesterday, actually. Like, he's doing pretty well, his fractures are consolidated and he's active. So sometimes you need to take the OS status into account as well, so be less aggressive with your instrumentation. So in summary, like a fracture-related infection, it can be a difficult problem to treat, especially when the fracture is unhealed. You need to consider a lot of factors into account before thinking about a suitable treatment option. The chances of retaining your implant diminishes significantly with time, and either you retain or exchange, you need to do it under appropriate antibiotic therapy. And always do not forget to consider local and systemic risk factors and also soft tissue management. Thank you.
Thank you very much, Dr. Ashok. That was a wonderful talk. Can you stop sharing so that I'll put a question? Yeah, the Pixart question is 48-year-old. It is from the same case series which is shown by Dr. Ashok. Operated 7 months ago, dynamized, pain on weight bearing, sinus over medial aspect, CRP 18, ESR 34, WBC 11,200. What would be the best treatment option? Debridement, antibiotic and weight, debridement plus local antibiotic beads plus bone grafting, nail removal, intramedullary debridement, antibiotic coated nail followed by delayed nailing. So fourth option is nail removal, intramedullary debridement, exchange nailing. So you can answer directly in the chat box. So whoever answers it first will get a chance to win Pixart prize. Next, we'll go ahead with the next talk. That is fracture-related infection management with ring fixator by Dr. Prasad sir. Sir, over to you.
Thank you, Dr. Kasha, for giving me this opportunity. I thank the TCOS for giving me this opportunity.
Can you share, sir?
Yeah.
Yeah.
Can you see?
Yes, yes.
As per Dr. Gavaskar, the requires a stable fixation, elimination of 1 minute. Elimination of the dead space and soft tissue coverage should be good, effective drainage and appropriate antibiotics to control the bone infection. This is the concept of reconstruction of an infected bone, and the bone defect is the main issue after infection control. Early restoration of function is of prime importance as the bones are already osteoporotic if the treatment is delayed by many months. But if you interfere early, this may not be a problem. But by the time 2 to 3 surgeries and patient is non-weight bearing, and this leads to a lot of osteoporosis. And sometimes these are on steroids. These infections will come on patients with steroids and old age. And these things will influence your treatment protocols. But this early function can be restored only by Elizero frame. Cases of this type can be treated either by the methods that were shown by Ashok or by Elizero method. The only difference is the full weight bearing with Elizero and partial weight bearing with the other types of implant fixation. This type of infection involving small fragment can be removed, bone cement spacer can be kept, and instead of using a plate or nail for stabilization, a simple Elizarov frame can also be added for early mobility. Later, when the membrane is formed, you can remove the spacer and fill it with the bone graft. But meanwhile, in this method, compared to the earlier methods, the patient will be fully weight bearing with Elizarov frame. The only difference, what I am saying, this is between 5 to 8 centimeters of infection can be treated very well with either of the method except the weight bearing factor. Or if you don't want to go with that, you can go for a bone transport. Here there is infection and then the bone has been excised, a catectomy has been done at the lower end and gradually transported and docked, and this is the union. And in severe osteoporosis, after X-fix for so many months, the bones look like very osteoporosis with an almost overriding of about 7 centimeters of the fibula, which says that there is a shortening, and this much of shortening along with removal of the excision of the bone requires a very long transport, and you cannot do with regular your methods of membrane formation and then bone filling, because it requires a lot of bone to fill the gap. And so even with the cage, you may not be able to do this. So severe osteoporosis after X-fix. So in these cases also you require Elizarov fixation, and a bone transport has been carried out from the upper end here, and you can see a good improvement in osteoporosis and what you can say, the improvements in bone density, you can say. And here another case with the same this thing, as Dr. Gavaskar has pointed out, that skin condition should be good, but in this type of skin condition you may not be able to do an internal fixation, and so it requires Elizarov fixation, and equinus foot is corrected by adding a half ring to the foot. Another case, but in this type of cases where already comminuted compound femur, lower third, intra-articular, it went from a periphery to a government teaching hospital, and then 2 days elapsed in transit, and from there they went to another corporate hospital where they have operated with the plating, a good reduction and good acceptable implant position. But this was done about 3 days after the injury, but got infected because of delay in obtaining the treatment. And so they could not control it. They have debrided thoroughly, but retained the implant because that is good. Infection is not under control even after that, but they have not put the bone cement as per the antibiotic coated bone cement. At this situation, they might have used that, but a third surgery was done, removing the implant and debriding the total this thing. He came to me with a knee brace at this stage, but on observation, I have seen some amount of freak callus formation in this area. You can see that there is white specks here and there. And so I thought of just putting a fixator and then wait and watch. So gradually those streaks have become consolidated with the frame and started regenerating without doing any bone graft at this stage, except giving the stability. I have not done anything except giving the stability. And at the end, I thought that there is some lateral, there is a gap. So I thought that it may break, and I added some bone grafting at this point, at the end stage. And then this is the final result. A simple fracture femur which was treated with intramedullary nail, Kunshner nail, got infected, and then that Kunshner nail was removed and interlock nail was done, but the debridement was not done, I think, and exchange nailing was done, but that also got infected, and then the screws became loose, and he came to me after removal of the nail and with this stage. And there was shortening in this, and so I removed the infected portion in toto, and then a corticotomy at the supracondylar area. You can see one hole here, that is the interlock screw hole, which is much widened because of infection, and gradually that has been transported and docked to the upper third femur, and this is the final result, and I got a knee flexion of about more than 90 degrees. His function has been restored well. Another case, a 12 years boy with history of RTA. He came back with the necrotic bone at the lower end of the tibia and loss of skin, and on treatment outside with initial debridement and only posterior slab. So a very large gap was there. And so then all the necrotic tissue has been removed and Elizarov fixator applied. Bone transport carried out in this boy of about 14 centimeters of bone transport has been carried out, and I could achieve good result in this case. These type of long transports cannot be done with other methods except Elizarov. Another case of compound tibia, almost 1 month old, with slough and skin is very bad situation, and it has been operated with the excision of the necrotic bone, and a large gap was there, and I could not get away with a single I could get away with a single corticotomy with wire interposition for a long bone transport, and this is the almost 14 centimeters of here also about 11 centimeters of bone transport carried out, and you can and you can see the bone transport in this. Another case of compound comminuted tibia with bone loss. He was initially applied external fixator and a flap was done, and he came to me with this much of gap, and actually this intermediate fragment is not a total fragment. It is something like a flake of bone which could not be retained and could not be used for transport, and so that has been removed at the end, and a small portion has been removed, and it is malunited already. So I have to do a angulation correction by corticotomy at the upper end, and a double corticotomy has been carried out from lower to upper and upper to lower, and the middle segment of flake has been removed, and almost about 23 centimeters of bone transport has been carried out in this person with the 12 centimeters from above and 11 centimeters from below. And at the end, these transport segments were very small and they became rounded by the time they reached for docking. And so I have to freshen the edges of these segments, which are very small, of 4 to 5 centimeters long only. And still I could get a consolidation in this case. So almost 23 centimeters of transport has been done, which cannot be used because LRS cannot be used in this because the transport segments were very small. Another young man with compound comminuted segmental tibia, he had head injury, and under the treatment of the neurosurgeon and he could not give a consent for surgery for about 3 days. And so what are the options in this case? 3 days, the bone segment is seen outside, part of it is seen outside, and they have called me for Elizarov surgery. They thought that it is not possible to do any internal fixation and other external fixation methods. So debridement and primary L0 was done. Two rings at the proximals and segment and one ring each to the lower segments along with a drop wire. Good reduction has been obtained, and at this stage we thought that you may need only a bone grafting at a later date once the infection or the wound is healthy. So it is well aligned with the L0 frame, but after a few months the middle segment started absorbing on its own, and almost 50% of the length has been absorbed. And so we have to revise this again to remove the middle segment in toto. So total debridement was done and remove the middle segment, and double level bone transport has been carried out. Tandem type of bone transport has been carried out. You can see the corticotomy at the upper segment, and you can see the wires passing into the distal segment, and this is the final result. So be prepared for the revision even after L0. A good reduction is essential for a good result. The goal is that you should be able to do an interlock if it is needed in future, if he has any fracture afterwards. And this is another case of 2-month-old compound supracondylar fracture femur on native treatment with bone protruding outside and looking like a red eye. L0 frame applied and gradually distracted and aligned, which is not possible in any other mode of treatment except L0. And it has been gradually distracted and could achieve full correction, but I could not get full movements in this case. Only about 30° of flexion I could get. Another case, this is a TKR got infected, and so the implant has been removed and tried for arthrodesis by dual plating. You can see that the dual plating is seen here, but it came out with a supracondylar fracture again, and this was stabilized with another third plate, and still they could not get the union there. And so everything has been removed and L0 frame applied for arthrodesis, and both the fracture and the TKR got consolidated. Another case of TKR, and this patient with double plating for arthrodesis, and this patient, because there is a lot of shortening after removal of the implant, this patient wants correction of the length also, and even with plating they could not get this arthrodosed, and so I've done L0, and then lengthening also has been corrected by a corticotomy at the middle third of the tibia, and we could achieve good correction. So L0 method works where other systems of treatment fail, and L0 method of treatment is useful in severely osteoporotic bones and improves the bone density because of early rehabilitation. It is most useful where we require distraction in delayed cases, as it allows early new bone formation called distraction osteogenesis, and there is no comparison in reconstruction of large bone defects. Skin condition is one that prevents us to choose the other modes of treatment. So when the skin condition is bad, try to choose L0. Thank you.
Thank you so much, sir. That was a wonderful talk where L0 is the only option in such a kind of a situation. All the cases are shown in, that mangled or bad shape. Thanks for sharing, sir. Next, we'll go ahead with the next talk by Dr. Krishna Kiran. The topic is prosthetic joint infection, single stage, when, where and how. So he has sent a video. Hope he is not there. He has sent a video. I'm just going to play that. Okay, I want to share desktop. Can you all see my screen?
Yeah, we
Yes.
could see.
Yes. So I'm just playing Dr. Krishna Kiran's video.
Good morning. I'm supposed to talk about single stage revision, and I will share my experience with the use of primary implants for infected total knee arthroplasty. Now, two-stage exchange is considered the gold standard for infection after total knee arthroplasty, and single stage revision is indicated in selected cases or contraindicated whenever there is a multi-drug resistant organism in an immunocompromised host. There are several selection criteria which have been proposed for single stage revision. These include relatively younger age group, good general medical condition, delay between infection occurrence and surgery, well-identified responsible pathogen, low virulence pathogen which is sensitive to antibiotics, no fistula or sinus formation, lack of severe bone loss requiring bone reconstruction. However, there is currently little evidence regarding the effectiveness of such a selective process in available literature. And in this study, they compared patient selection based on these criteria and unselected one-stage exchange, and found that in this French study, there was no difference in outcomes between selected one-stage and non-selected one-stage exchange for infected total knee arthroplasty. And this group continues to do unselected one-stage revision for all patients with infected total knee arthroplasty. Initially, we embarked on the use of articulating spacers as a part of two-stage revision. So we would autoclave the femoral and tibial components and use a new polyethylene, and it was published way back by Hoffman et al. In 2005. And we noticed that several patients did not come back for a revision procedure. So that gave us more confidence to start using this as a sort of a one-stage procedure, where the second stage was not fixed at 6 to 8 weeks once the ESR sed rate comes down, CRP comes down, but as a flexible procedure as and when this implant became aseptically loose. So as the duration from the index first stage increased, the risk of having reinfection after the second stage revision reduced. So that is why we started doing this procedure. Now, the success of one-stage revision has been validated in literature with an 81 to 100% success rate. One advantage of doing a one-stage procedure is, instead of doing two-stage procedure, suppose we had a successful two-stage procedure in 100 patients, we would do 200 operations. But if it was a successful one-stage procedure, even in 85% of patients, you would end up doing only 115 operations. So a lot of cost saving as well as made intuitive sense. And we all know that the key element of any two-stage is the debridement. And then you give the patient antibiotics. And if it's a sensitive organism, then the success rate of one stage would be similar to that of a two-stage procedure. In 1,200 consecutive patients in 12 studies and a meta-analysis, the eradication rate was 83%. And not surprisingly, worse outcomes were seen with polymicrobial infections, MRSA, and gram-negative organisms. The prerequisites for a single-stage revision are immunocompetent patient, thorough debridement, ability to remove implants without bone loss, intact collateral ligaments, and wound closure in our hands. However, we have the endoclinic experience which suggests that aggressive debridement, including removal of the collateral ligaments and use of a primary hinge, was their way to go. But we chose to do it only in situations where the bone loss was permitting us to use primary implants, and also that collateral ligaments should be intact. Since 2008, I have treated around 70 patients with one-stage revision, and of these, 47 knees have a minimum 2 to 12 year follow-up, The mean follow-up was 5.5 years, and one-stage revision was done either with autoclaved implants in the first 23 cases, and nowadays we use fresh primary implants, which was done in 24 of the knees. The mean age of the patient ranged from 51 to 84 years and was 63. There were 27 men and 20 women. The mean BMI was 28.2. The duration of symptoms was 6 months to 2 years following the index primary knee replacement. ESR and CRP were elevated in all the patients. 3 patients had subcutaneous abscess over the tibia. All the patients were counseled and consented for a stage 1 of a 2-stage revision with articulating spacer, either using autoclaved implant with a fresh poly or with a new set of primary implants wherever it was possible, to remove the implants without too much of bone loss and wherever the collateral ligaments were intact. The second stage, we told the patients, would be done as and when was deemed necessary based on the incidence of aseptic loosening at that point in time or failure to control infection. We did a preoperative knee aspiration in all the patients and sent 6 intraoperative cultures using separate set of instruments, and found that 34% of our patients were culture negative. An organism was isolated preoperatively in 22 of the 47 patients. 16 had MSSA, 1 had Candida tropicalis, 2 Pseudomonas, 1 MRSA, and 2 E. coli. Further, 9 patients grew intraoperative cultures, 4 MSSA, 2 E. coli, 2 Pseudomonas, and 1 Klebsiella. So although MRSA and gram-negative infections are traditionally not good idea to do a one-stage procedure, we still went ahead and did the first stage of the 2-stage revision procedure, but cemented the implants well using vancomycin 4 grams in the cement. And I will come in detail on the technique. So this is typically how the leg looks like, multiple scars and sinuses, and one must use the lateral most incision while planning surgery. And if you have scars at acute angles, then it is safer to cross only beyond 60 degrees. If you have less than 60 degrees crossing, then you must anticipate the need for preoperative soft tissue expansion or the need for a gastrocnemius flap. So this is a case example, and the surgical steps are always through the lateral most incision, medial parapatellar approach, the use of a rectus snip as and when deemed necessary. Most of these knees are stiff, and although there may not be frank pus, there is significant synovial hypertrophy, and the steps include creation of medial and lateral gutters through thorough anterior synovectomy, and also recreating the anterior interval between the vastus intermedius and the femur in order to mobilize and achieve flexion in some of these patients. So this is a video showing the technique of exposure. You can see here that the knee is swollen and it is stiff. The incision is the pre-existing midline incision. And once this is done, we must not do any sort of a mid-vastus or subvastus approach in these cases. It is safer to do a medial parapatellar approach, which can be extended in the form of a rectus snip, or rarely if there are cemented implants or it's a re-revision, you may have to do a tibial tubercle osteotomy in some of these cases. Once the medial parapatellar arthrotomy is done, the Alice is used to hold the medial and lateral flaps of the quadriceps mechanism, and an avascular plane can be created between the synovium and the muscle, which is very clear, and we can do a thorough synovectomy. And wherever it is required, we can do a rectus snip into the quadriceps tendon, which increases the exposure without compromising the patellar tendon. At the same time, it will also allow us no changes in the postoperative rehabilitation, because once you repair it, you don't need to brace it or immobilize the patient. A pin in the patellar tendon will prevent avulsion. Recreating the medial and lateral gutters is important, as is a circumtibial release in order to mobilize the knee and achieve adequate flexion. Now the implants are removed. Initially, the polyethylene liner is removed to create some sort of space and allow access for posterior synovectomy, which again is a critical element of the debridement. When the tibia is exposed and removed first, one can choose to remove the femoral component as well. So initially, you use an osteotome to create a sort of a space between the cement mantle and the tibial component, and the dissection must be done between the cement mantle and the implant. Because we're choosing to do a one-stage procedure using primary implants, it is absolutely critical to minimize the bone loss that is caused during the time of implant removal. We normally use a saw blade to cut the interface between the implant tibia as well as femur and the cement mantle. And once the implant is freed, some of these cases may be loose, but other cases are usually well fixed, and the infection is usually indolent. It is not characterized by frank pus formation. The patient will have pain, will have elevated ESR, elevated CRP, but the pain is not that much. So once the junction between the implants are made, and you must be sure that everything is freed up, now you can use the tibial extractor to remove the tibia, and you can see that the extraction has taken place at the junction of the implant and cement. We must not dissect at the cement bone interface. Similarly, the femoral component again is freed up at the cement implant interface using an oscillating saw. You can use a reciprocating saw if it is available with you. And then once the implant is well freed on all the sides, then you can carefully remove it without causing without causing much bone loss. It is tempting to use these sort of devices, but they sometimes bring a full segment of condyle along with it, so we don't use it. We gently free up the implant and then use osteotomes on both sides to be able to remove the implant without causing too much of bone loss. And you can see here that both condyles are retained and there is hardly any cancellous bone loss. Once the debridement is complete, you re-trip and drape the patient, and then check for the integrity of the collateral ligament with your trial reduction, and use antibiotics 4 grams of vancomycin while doing the cementing. So these are the autoclaved implants which we use, and this is a vancomycin impregnated bone cement. We use 4 grams of vancomycin, which is mixed into the bone cement, and you must make sure that it's not mixed well. Previously, when using autoclaved implants, we would not, cement the components well, but now we cement them as well as we can, because we know that this will last a few years for the patient. And we use a fresh polyethylene based on the flexion extension gap and the stability for the patient. And then the wound is closed just like you would do for any other revision procedure. The key steps for the procedure are thorough debridement, which includes synovectomy, recreation of the gutters, circumtibial release, and implant removal without additional bone loss, as I showed you in the video. Preservation of the collateral ligaments is again important. And revision with primary implants using 4 grams vancomycin and 40 grams of bone cement. We also use intra-articular pigtail catheter with 500 milligrams of vancomycin delivery for the first 1 week. It's similar to Leo Whiteside technique. He uses antibiotics only intra-articularly for 6 weeks, and he has measured the synovial fluid as well as blood concentration of the antibiotic and found that to be having adequate MIC to kill any sort of bacteria. And it is a useful tool wherever we have multi-drug resistant or gram-negative infection, especially when we have to use toxic drugs like colistin. Intra-articular infiltration is a useful tool. And we always use the intra-articular pigtail catheter for a week to 2 weeks in our patients. We give IV antibiotics based on the culture for 2 weeks. If we have culture-negative infection, we use miropranolol along with teicoplanin for our patients as an empirical therapy, followed by oral antibiotics for 4 weeks based on culture and antibiotic sensitivity test. And some of them, based on their ESR and CRP, receive antibiotics for between 8 to 12 weeks post-surgery. This is the example of a functional outcome. So this patient is around 4 years out following a single stage revision using primary implants, and you can see the patient has got good functional outcome. And looking at our own outcomes, the mean range of motion was between 0 to 100 degrees. The knee society score improved from 21 to 87 in our patients. 2 patients had requirement of a gastrocnemius flap coverage due to inferior wound breakdown. And 3 patients had recurrent infections needing subsequent 2-stage revision between 6 and 18 months following the 1-stage revision procedure. And 1 patient had aseptic loosening at 8.5 years and required revision procedure. overall 91.4% infection-free survival was noted in our series. This is an example of a gastrocnemius flap which was needed, and these patients had uneventful recovery later on. And this is an example of an aseptic loosening after 8.5 years. Initially, it was done in 2011, and this patient was well functioning, and he came back with aseptic loosening of the femoral component, which was subsequently revised to LCCK. The take-home message: single-stage revision is useful in patients who are immunocompetent with a good soft tissue envelope and a drug in an organism which is sensitive. But in our own experience, even though you don't identify the organism, as long as you are able to remove the previous implants without bone loss and the collateral ligaments are intact, you can still use primary implants as a temporizing procedure, which may last for a few years in these patients without the necessity to do the second stage of the two-stage procedure. Surgical technique is key for success, and role of local antibiotics is extremely important in our own experience. Thank you.
Thank you, Dr. Krishna Kiran. This was the video which was shared by him. So the next thing is Pixart question for this particular talk. So single stage knee revision can be done in all except. The option 1 is immunocompetent host. Option 2, sensitive organism identified preoperatively. Option 3, polymicrobial infection. Option 4, absence of fistula. So you can answer this in chat box. Whoever answers first will get a Pixart prize. And I'll just stop sharing. Yeah. So the next talk is by Dr. Sudhir Reddy. He has also sent a video which I am going to play now. That will be followed by panel discussion. So I'll go ahead and play the next video. Can you all see my screen? Can you all see my screen?
Yes, sir. We can see your screen.
Yeah, yes. Great. So I am playing Dr. Sudhir Reddy's talk.
Hello. Good morning. I'm going to speak about the space for two-stage revision in infected prosthetic joint surgeries, both hip and knee. So let me share my screen. Okay, before I start, I have to admit that I'm more and more a single-stage revision surgeon, and I'm convinced that more and more patients should be given the benefit of single-stage revision surgeries. But despite that, 50% of my practice is still two-stage procedures for various regions, some of which we will discuss in the next few slides. So, for all our orthoplastic surgeons, the most dreaded fear is risk of infections. It's a disaster for you, disaster for the patients, and it will all be traveling down an uncertain future. In addition to that, there are a good number of late prosthetic joint infections that are turning up, who come a few years after the original index surgery with newly developed infection. And many times it's very challenging to diagnose infection because no test is 100% sensitive and specific. Patients keep complaining of pain, they're unhappy, but clinically you don't find anything. You don't find any signs of inflammation. You don't find any signs on the X-ray. There is nothing to aspirate in the knee, and it's very difficult to take a call of whether it is infected or not because the consequences are drastic. So you have to use a combination of your clinical assessment, serological tests, imaging, aspirations, and biopsies, and then arrive at a conclusion. And as National Joint Registry of England and Wales shows, prevalence of revisions due to PGI is increasing, following both primary knee replacements as well as the revision knee replacement. It has increased by 2.5 to 7.54 in 2005 to 2013. So we're all going to see these more and more, and the volumes of primary knee replacements are also increasing tremendously. So we're all going to face this situation more and more. So what are the goals of treatment? As with any surgery, the first and foremost is eradication of infection and re-establishment of a pain-free and well-functioning joint. So two-stage revision in PGI is considered as a gold standard for revision, and it is first described by Vienza. It is the dominant method in North America, Asia, and many European countries. And we do have a large amount of data in the literature to support that the method is fairly successful and gives rise to approximately 90% success rate in most of the series. You must do good preoperative workup to identify what is the causative organism and what are the sensitivities. Because if you identify what is the organism and sensitivities, the chances that you're going to succeed in infection goes up much higher. If you don't know, then you run a high risk of not being able to eradicate the infection. So you must stop antibiotics for at least 4 weeks. You must aspirate the joint before the surgery and try to identify the organism before the first stage itself so that you can incorporate those antibiotics into the cement spacer. Sometimes you may be able to see fairly clear osteolysis and loosening underneath the implants, and we may be able to raise the diagnosis. Sometimes you may not see any evident loosening, and you may have to do additional tests. This is showing a sinogram. This patient had a small sinus there. We were not sure where it was coming from. Whether it's only subcutaneous or it's extending into the joint, because she didn't have much pain. But the discharge started increasing. So I'm first going to describe the procedure. So what do you do in the first stage? Obviously, you have to consider the past incisions, previous incisions, to choose what is the best alternative. You have to do a radical debridement of all potentially infected and devitalated tissue. This debridement has to be really meticulous and radical, and some surgeons even advocate debridement of all the tissues, including collaterals. You have to remove all the implants very meticulously and carefully, preserving the maximum bone stock, because this will make your life much easier later on when you go to second stage. I believe the first stage of the two stages is more important and requires more experience, because that will determine the entire success of your second stage and how easily you can do the second stage. You have to take several samples for and meticulous removal of all cement and any foreign material that is present in the joint. You have to ream the medullary canals, and you have to thoroughly lavage so that you can get rid of as much as microbiological load as possible. And then you have to use cement spacers, and all these are antibiotic impregnated. You can use either articulating or non-articulating. Articulating are more expensive, many patients cannot afford, but people use innovative methods to make their own articulating spacers. Spacers have several advantages. They are mainly there for antibiotic delivery, as well as preserve some movement and then prevent contractures of collaterals and capsule. And then they're also more functional. This is a picture showing one of our patients after first stage revision. It shows this patient already had a stem in the middle canal, so we cleared that off, and we used the cement spacer to go all the way into the tibial canal. This is another patient. You can see we've inserted cement spacer all the way to the middle canal, both in the femur and tibia. So once the first stage is done, what is done in the interval period? So you have to give antibiotics for 6 weeks, preferably systemic and preferably combination. You should start with broad spectrum antibiotics if you don't know what is the organism, and then once you get the cultures and sensitivities, you modify the antibiotics accordingly. Once the antibiotic course is completed, you should give an antibiotic-free period. In this period, you have to make sure that you're confident that the infection has been eradicated before you plan the second stage. So how do you determine the resolution of infection? Both clinically, serological markers, and if in doubt, aspirate the joint and see, and make sure you have eradicated the infection before you plan the second stage. In the second stage, you remove the spacer. Again, meticulously remove all the foreign material, take tissue samples again, and do a meticulous debridement again, then reimplant using revision implants, working on stability of the implant, where you may have to use augments, and depending on the stability of the joint, which is collateral ligaments, you have to decide on what kind of constraint you're going to need. So choosing the appropriate implant, you have to reimplant and use antibiotic impregnated cement in this. And post-operatively, you use antibiotic for 4 to 5 days till culture results are available. If cultures come positive, then again, you should continue the antibiotics for about 6 weeks. This is the same patient what one of the patients what we had seen before, showing the post-operative X-ray after the second stage revision. And there are several studies in the literature which show that after a fairly long follow-up, the rate of infection control using a 2-stage revision knee arthroplasty is in the range of about 90s. And when you look at the evidence for single stage and 2-stage, evidence for both of them is not of a very high quality, but the evidence basis for 2-stage revisions is significantly larger in the literature. But there are also several controversies in the 2-stage revision. There are debates on what is the timing of the second stage procedure, what is the ideal duration of antibiotic dosage, and the use of antibiotic-loaded cement in the second stage. And some people debate about allograft bone grafting and the use of uncemented components. My take on this is timing of the second stage procedure is when you are confident that infection has been eradicated, both clinically and by serological markers and aspiration of the knee. The ideal duration of antibiotic dosage is standard accepted practice is 6 weeks. 6 weeks, but there is now evidence showing that maybe a shorter duration of antibiotic course may be equally effective. So there are certain situations which are more suitable for a 2-stage revision, and probably single-stage revision is not advocated. These are when the patient has such systemic manifestation of infections, and when we don't know the organisms, at least when you do the first aid, it gives you a chance, better chance, much higher chance to identify which is the organism. So you have a chance to give appropriate antibiotics for an adequate duration of period before you go for reimplantation of the definitive implants. And sometimes your preoperative cultures show that organisms that are grown are multi-resistant and then difficult to treat, then you are probably better off with 2-stage because you get a chance for a longer period of antibiotics and you get a chance to debride twice. Sometimes when the discharge is obviously purulent, you may not want to put a fresh set of implants into that even after a good debridement. And in a patient who is immunocompromised, I think it's common sense to do a 2-stage revision surgery. And when there is an inadequate soft tissue coverage, again, doing a 2-stage will be more appropriate. So given various indications, many times you find that many of the patients are not suitable for a single stage and much more suitable for 2-stage. So a 2-stage revision PGI gives a good infection-free survival rates in the range of 80 to 100% in most of the literature. It ensures adequate delivery of antibiotic, both locally and systemically, and the opportunity for second debridement if needed. And it is usually considered as a gold standard. So in conclusion, it is a proven method. It is preferred option in many situations, probably more accepted among peers, and probably easier to explain to patient should this fail. A single stage revision is gaining more popularity for sure. Thank you.
Thank you so much, Dr. Sudhir Reddy. That was a wonderful talk. Let me just close this. Yeah. So let us move on with the question, Pixart question for the last talk. What does the X-ray show in this particular picture? So option A, loosening due to infection. Option B, aseptic loosening. Option C, heterotopic ossification. Option D, cyanogram showing the extent of tract. So you can answer this in chat box and have a chance to win Pixart prize. Let us move on with the panel discussion by Dr. KJ Reddy sir on prosthetic joint infection. So you got a beautiful ground, sir, and background prepared by 2 speakers on single stage and 2-stage revisions. And the panelists are Dr. Ved Prakash, Dr. Uday Prakash, Dr. Mithinachi, Dr. Sudhir Reddy, Dr. Ashok Raju, Dr. Ivy Reddy sir, Dr. Aditya Krapur. So hope you are all available in the panelist list. Over to you, KJ Reddy sir.
Good afternoon. Hello, Kasha, Srinivas. You've done wonderful job.
Thank you, sir.
I think like always, and it's a very good topic. I think the theme of the meeting is excellent because that is what is required now. And as you rightly said, I think I was listening to lectures. So we will go on to discussion about panel discussion about the infections, because I think for the benefit of the delegates, PJI is involved with high morbidity and the survival is worse than some of the cancers. So it is important, those orthoplasty surgeons, they should know how to deal with infections too. And Kasha, did I miss anyone? All the panelists are there.
I hope so, sir. Dr.
Can you just check whether Sudhir is he back?
I hope. I think he is not there, but are you there?
Should be.
Sudhir.
Ved Prakash
I'm
is
here,
there.
sir. I'm here, sir. Veda is here. Sudhir, I can't.
Yes, very good. Good morning.
Sudhir. Good morning, sir.
Dr. Uday Prakash, Uday is there? Still in golf?
I can't see his name.
I didn't see him in the morning, but whether he's still there or not.
Prakash, I think he'll be joining, sir.
Okay. Mithinachi?
Sir, I'm there, sir. Good afternoon, sir.
Good afternoon, Mithun. You're always there. Sudhir, Ashok Raju.
Can't see his name also, sir.
Ivy Reddy.
Yes, I'm here.
Oh, hi, Ivy. Nice to talk to you.
Yeah.
Aditya Kapoor.
Can't see his name, sir.
Okay. So I think we will move on to discussion. I have some variety of cases so that we can have little information about both the knees and hips, as Kasha requested me. I just
Sir,
want to thank the panelist.
Hello, sir.
There are some rules for the panelists and myself. It should be, the answer should be brief and crisp and clear, and only one message. And it's a combination of your experience and the evidence. There's no point in quoting it's evidence if we don't need to. So it's a combination. You are the experts, and you give a message. What would you do in that situation? And there's no point in repeating same somebody already spoke about it. I just wanted to know from the panelists.
Hello, sir.
Policy,
Sir, Dr. Aditya sir is there, sir, already.
Sorry?
Good morning, sir. I've managed to join.
Dr. Aditya Kapoor is...
Aditya, how are you?
Very well, sir.
We can't do, big man, we can't do without you.
Very kind of you.
Sir, even Dr. Ashok Raju sir also there, sir. He's there with the panelist group, actually.
Good morning. Has he joined? Has he joined?
Yeah, I joined, sir. I'm there.
Yeah, very good. Good morning. Good afternoon, rather. It was supposed to be good morning, but now good afternoon.
Good afternoon. Yeah, sure.
Yeah. Okay. So I will ask each one of you briefly, antibiotic policy for primary joints. When do you start? When do you stop? Quickly. Ivy, you start with that.
For the primary, for the first dose will be given just before the inflation of the tunicate, maybe about 10 to 15 minutes before the inflation of the tunicate in my practice.
Sure.
And we give 2 post-operative doses, 18 hours and 16 hours post-operative. That's all.
Very good. Very good. Anybody else differ with him, or everybody agrees with him? Anybody gives, because I see quite a few people, patients, I mean, quite a few people continuing antibiotics of 5 days, 7 days, sometimes 14 days. Anybody continues beyond 24, 48 hours?
No.
No, that's very good.
I don't, sir, but as you rightly said, what we see in these panel discussions is quite different from what we observe.
Yeah, that's important.
Practice, sir. Probably 90% of discharge summaries, if I'm not wrong.
Yeah.
Anti-nodal antibiotics.
There is a hospital policy for infection control, which is tailored by local hospitals. That is different from what you as a surgeon would practice.
But you should insist, you talk to microbiologist,
absolutely,
tell them not to use antibiotics. So if you give antibiotics more than 24 hours, you're treating yourself, not the patient. And it doesn't do any good. So be confident, do not extend and do not discharge patients with antibiotics. Okay. And for the benefit of delegates.
The only patient I would like to say is that the only patients I would continue are those who are rheumatoids or those who are on immunosuppressants.
I wouldn't agree. There is no evidence. There's no evidence. I don't think you need to do. Revision surgery. Revision surgery, if it is a 2-stage, I think we are talking to, last Sudhir was talking, I'll just give my opinion. 2-stage revision. So, again, I'll start with you, Veda Prakash. 2-stage revision, what is your antibiotic policy? Stage 1, stage 2.
The stage 1 certainly is done after trying to get as much information as possible by preoperative aspiration.
We're just talking about antibiotic policy. I'm talking about duration.
Duration of antibiotic. Okay, sir. Okay. After first stage, we'll give for at least 4 to 6 weeks, sir, depending on the type of organism.
Sure.
And always guided by the ESR and other clinical and radiological signs as well.
Sure.
And post second stage, again, there is a little bit of conflict over there, but still I would go for similar duration, sir. 4 weeks.
4 to 6 weeks.
After after the second stage as well. Yeah.
Okay. Anybody else? Anybody else differ with him, or everybody agrees with him? Ivy?
I think I agree with him. Yes.
Anybody else? Aditya? Because I disagree with him.
Pretty much the same.
Yeah. I think 2-stage revision. First stage, of course, 4 to 6 weeks. IV antibiotics. Sometimes, if ESR, CRP doesn't come down, I would go for re-debridement instead of extending antibiotic policy. And the second stage, the clean surgery, is like a primary. There's no point in giving prolonged antibiotics. There's no evidence to say, I will not give. It's like exactly like a primary. You are operating on a clean tissue. It's not a single stage, 2 stage. That means second stage is clean. And the antibiotic loaded cement, so it's exactly like your primary joint. So there is no logic extending antibiotics for 4 to 6 weeks. Anybody contradict?
There is a little controversy, sir. Technically, what you say certainly holds good. But if you look at the literature, there is a conflicting evidence. I think if Dr. Sudhir is there, probably he would be the best person to answer because he just delivered it.
Yeah, we had recently, not recently, last year with Parvezi, Haddad, and this was the agreement that if it is a clean joint you're operating 2 stage, and we should not extend antibiotics. If extending antibiotics means you're not dealing with a clean joint. That's an opinion. And I think literature, though differs, but I think the current protocol is clean joint when you're operating. Second stage, if a clean joint, similar to first joint.
But my opinion is, it is, even though you say that it is like something like a primary joint as far as the organisms are concerned, the soft tissue quality is not the same as you would expect it a primary joint replacement. And the metal, that a quantity of metal that you are going to implant in a revision setup is more than what you do in the case of primary joint replacements. So for these reasons, I think I will not be confident to leave the patient with your 3 doses regimen as is the case of primary joint replacement. I can't.
Yeah, I respect your opinion, but there's I think most of the people, those who do, I think standard goals 2 stage would agree with me. Like anyway, single stage revision, I think Sudhir was talking and 2 stage, and Krishnakiran was talking about a single stage. So single stage, what your opinion? Aditya, you start off.
So I think single stage in our country must follow very clear
No, what I'm asking your protocol. What would you do? Here, you're all experts, so you give your opinion.
I would go if there is a low virulence, definitely known organism.
Would you do single stage?
Yes, I would.
And how long would you give antibiotic? My question is duration of antibiotics in single stage revision.
Again, if you're going with a single stage revision, only if you are sure that your debridement, and I believe that loading the cement with high amount of antibiotics, which is more important than giving sustained post-op. So I would go for about 2 to 3 weeks post-op for antibiotics, not up to 6 weeks. But I would monitor the CRP in case.
Anybody else?
I think in single stage, you are constrained with the amount of antibiotic you are going to use with the cement. You can't go on adding any amount of cement because the cement strength will go down. So in a single stage, I would not stop with I would like to extend my antibiotic prophylaxis at least for 2 months, initially 2 weeks of IV and then oral antibiotic.
Sure. That's a valid point. Anybody else? I think the consensus is in a single stage, you extend. People have extended up to 6 months.
Yes.
That's why you should do single stage where you can give antibiotic, which is non-toxic, which you can do oral antibiotic, which you can do a long time. So standard protocol is up to 6 weeks to 2 months, but you can extend longer than that. Yes. Because it's single stage. If you're not happy, you're going to for another revision. So you can extend up to 6 months. And you can go back and read Parvezi book.
In the literature, several authors have mentioned 3 to 6 months.
Parvezi, latest book, I'll show you at the end of my talk. You must read that one, the latest one, Parvezi 2019 one. Okay. So I think I'll just take you through. Can you see this picture? This is a, oh, sorry, I'll just go. Yeah, you can see. This is the 59-year-old, 2 months post-op. Who is not talking? Yeah, anybody can take. I think Ivy, you start off, senior person.
So obviously it looks like infected knee.
Yeah.
As I do in many of the cases, I would think of going for a 2-stage procedure.
Yeah.
So in the first stage, I will remove all the implants, as has been already said, maintaining as much of bone stock as possible.
Yeah.
With a minimal damage to the bone stock, and do a thorough debridement after removing the implants to take out all the cement that is there. And of course, I will be taking samples for culture and sensitivity, all those things, and then put a spacer, cement spacer.
Sure. Mithun, would you go for a single stage in this case?
No, sir. Actually, in this case, preoperatively, just before I put my incision, I would just take aspiration and send it to the patho lab, and I'll just wait for the neutrophil count. That will give me a much better idea of how bad the infection is. Even though it looks very bad, I would definitely not go for a single.
Yeah. I can tell you this was aspirated. We aspirated. Sometimes it's a pus. What happens, Mithun? I think it's a 2 months for immediate post-op. There will be plenty of material inside. What you have to do is you have to get good material, then send it. It's a grown culture, so it's very easy these cases, because revision, if you identify the organism, would be easy to revise. So it is identified, and I think most of the people, if it's a purulent, very septic like this, would not do a single stage revision. I think the gold standard is 2 stage, because you have 2 chances of debridement at the joint. Okay, so that was done. So when you open up, as you can see, yeah.
Sir, can I just quickly ask, sir?
Sure.
You said 2 months post primary surgery, is it? This one, 15 years, 2 months post, you said. Is it 2 months post primary surgery? That's
2 months post-op.
2 months post-op.
2 months.
And how long was the duration of symptoms actually? When did we first suspect clinically that there could be infection here?
This was he was complaining of pain from the day 1. Post-op pain.
Okay.
2 months, there was some discharge. They continued with antibiotics and carried on. So
Okay.
it's a
I was just thinking
post-op infection. You can take it. So
I was just thinking whether it is a case where we could have tried implant retention, liner exchange.
That's what I was going to say. That's what I was asked about. So can you try retaining the implants and spacer change? I shouldn't have shown the tibial component.
Debridement and implant retention has the best result if it is done within the first 2 weeks. When an infection lasts more than 3 weeks, it is chronic, and the DARE goes down.
But it has been said that the symptoms, if the symptoms have been there for more than 48 hours, your implant retention programs are not going to work. You should act very, very fast. As soon as you come to know that it is going to be an infection, the symptoms suggest that they have been there for 2 to 3 days. You have to act immediately, not like after 2 weeks or 3 weeks.
Absolutely. I think in a case of a hip, it can go up to maybe 2 weeks. In a case of knee, 10 days. And of course, you should assess on the table. You can't just retain the implants. Implants are well retained, and there is no way you can retain implants here. Can you see bottom of the tibia and on the posterior aspect? There is no way you can access these parts by retaining implants. Of course, the first criteria is implant should be well fixed. This was well fixed, but sometimes we can got erosions and go underneath. So there is no way you can retain implants and do repeated debridements. And we all know that debridements can be not more than two times. We do more often, probably it's not very successful. And success rate is about 50 to 60% retaining implants. So you have to know the result. Yes, IB.
Just one point here. While trying to retain the implants, one has to be very, very careful not to damage the surface of the implant.
Yeah.
See, if you are trying to think of doing an extensive debridement in the presence of infection, you are likely to scratch the implants, bearing surfaces, and which will shorten the life of the implant. That's why you have to be extremely cautious in doing that. So when there is extensive infection there, trying to do a thorough debridement, you are likely to damage the bearing surfaces, which is not desirable. So better to go for total exchange rather than trying to retain them.
But sometimes what happens, see, I have done.
It should be what I want to say is
I have done spacer exchange in my own cases where you get in immediately.
Yeah, that's what I'm saying. It cannot be a debridement. It should be a simple irrigation and exchange of the liner. Thorough irrigation. Not a debridement procedure. If it requires debridement procedure, it should go for a 2-stage or whatever. Total exchange.
debridement means whatever tissues are there, you have to, of course, you can't leave dead tissues there, but
That's
you
what
have to.
you should not wait until that stage. It should be just irrigation.
You're right.
Yes.
You're right. But if you feel you're not able to debride thoroughly, or you have any doubt, it's better to revise. There's no point in knowingly you cannot close the wound and what is that? Trust the antibiotics. Antibiotics will not do if there is a pus, any necrotic tissue like this. There's no way you can cure it. Okay, so it was done 2-stage, 2 months later, and I just wanted to know. I think probably I've already put up. And what would be the gap between two stages? Ashok Raju is there?
I generally don't do knees at all.
Yeah. Okay. I got a nice hip case for you because I've seen this one. I'll get you a case, but in that case, what do you think in a case of hip? How long do you take? I think it applies both hips and knees.
Once I put an antibiotic spacer, I generally redo my second stage, generally between the 3rd and 4th week.
Okay. So you want to do early. You don't want to wait till 4 weeks of antibiotics.
Yeah, generally I give them 3rd week because most of the antibiotic is leached in the first week. It's 2 weeks becomes a little early for surgery. So I wait for the 3rd week to 4th week time to do. I generally do between the 3rd and the 4th week time.
Anybody revises within 6 weeks? Anybody?
Yeah, my standard will be 4 weeks. At the end of 4 weeks, I look for the parameters. If everything is favorable, I go. That is my wishful way of thinking.
Sure.
Suppose if the parameters are in doubt, I will extend for another 2 weeks time, 6 weeks. I will make it 6 weeks. Yes.
Anybody differs? Okay, I think most of my cases, about 80%, I wait 6 weeks. Sometimes if infection is not that much, a case like this I have seen, I will wait. I'll decide beforehand. This is going to go for 6 weeks because otherwise I won't be comfortable. If it is not that bad, probably I would have done in 4 weeks, but minimum in 4 weeks. My opinion, I think 4 weeks minimum. Then probably 6 weeks. And how long you can wait? What is that maximum?
No, there's no point in waiting beyond 2 months. I think 2 months is the maximum. Suppose if your parameters are not coming down and clinically also the patient will go for another revision. Like that is something like a first stage.
Yeah, absolutely. Or you can do if it is second single stage revision.
Take the risk and go ahead.
Yeah, absolutely. Okay. So this was done, 2-stage revision. And one word about of course, this is a handmade, quite available now, commercially available, which are expensive. And this is a handmade one. You can mix the antibiotic. And the biggest advantage is you have some degree of mobility. And some people, I think I've done more than about 80 in my series we sent for publication and published as well. Some never came back, but they didn't want revision because they're quite happy. The biggest problem is in those people, cement can break, bone can damage, so you have to warn them. And that's the reason, and Chris Teckner made very good point. See, people with articulated spacer, they were happy. They continued, carried on life. So that made us confident doing a single stage revision. If we can do 2-stage revision, leave the people with the articulated cement spacer, why can't we do a single stage? I think that was the reason why people thought about doing single stage revision. And this one, 60-year-old lady, 1 year post-op, pain stiffness, ESR, CRP. This is the X-ray. Aditya, can you just...
I can see quite significant osteolysis, especially around the femur, sir. Little bit around the tibia.
Very good point.
So I would like to... What
do you think about the knee? She had a good range of movements, Aditya, to be honest with you.
Sure.
Can you see her knee scar is quite healthy? Effusion is there,
yes.
but not much. I think I'll check you. This is inside. I couldn't see any pus.
Okay.
And I was a little suspicious. Am I dealing with something else? What do you think?
So I do think that there could, obviously that does show a possibility of infection, but if an ESR, CRP, did you take any intraoperative aspiration and cultures and also, did you get any gram stain, anything at all?
All negative.
All negative.
All negative.
I think this would be a case that could qualify for a single stage, provided we see what you get when you remove the implant.
Okay, anybody else?
Actually, you should have stopped at the stage of showing the X-ray. Will you please go back to the first?
Yeah, go on.
Yeah.
A lot of postulant.
At this stage, I would like to see the immediate post-op X-ray to compare with this before I take any decision.
Unfortunately, we don't. I don't have. It came from. I can see. It's
from
one of our physician mother came operated in Kolkata. So,
but there is quite a lot of soft tissue swelling as well, sir, and
there is effusion. Yes, you can see there is effusion
on the X-ray as well. And,
you can see here. Yes, you're right. Absolutely, there is synovial hypertrophy
and quite a bit of osteolysis in tibia and femur.
Yeah.
Unless proved otherwise, this is an infected case.
Yeah,
of course, we agree.
I mean, if you were to err on one side, you have to err on the side of infection. And more so when you can't get any positive cultures in such case. You should treat with a two-stage revision with quite a bit of samples, intraoperative samples sent for microbiological investigations to find out any unusual organisms, and wait for those culture reports to come back before you go for a single stage thing. I think
your point is well taken. Well taken, Ved Prakash.
This is a relative contraindication for one-stage revision, sir. This case.
I just want to share
this
one
is a
of
relative contraindication for a one-stage
single stage. Yes, you're right. Ivy, you wanted to say something?
Just I had recently one experience like this where it was looking like an infection to me on the X-ray because there was lysis, but it was involving only one component. The other component, there was no sign of any infection on the radiologically. And patient, as you said, having reasonably good range of movement. And I felt, initially I thought it could be infection, but ultimately it turned out to be something like aseptic on one side. The other side, there was, after opening also, there was no sign of infection. So in this case, of course, I do agree with them saying that it is a case of infection, but always we have to keep that also in mind for sometimes.
As you can see, this is tissue side, couldn't get much of tissue, but but there is significant erosion, as you can see, the tibia, significant bone loss. And whether I have one, yes, you can see, end of the femur. Femur is almost
God.
significant, but quite granulating tissue, good to healthy tissue. It's very tempting to do a single stage revision in this kind of situation. But generally, I do not do, if I don't isolate the organism, I do not do single stage revision. Any possibilities, Aditya, what else you can think? If I say it is infection, but what could be the infection? What kind of infection can give this kind of picture?
Is there any history of tuberculosis, sir?
No history of TB, no.
Fungal, sir?
Possible.
Yeah, I think yes, that's a good point. I think probably I'll go through this. This is the articulated spacer, and culture came positive for Candida.
Wow.
So I think, of course, routinely I take from 6 sites, send for 4 different bottles.
Yes.
One for standard, one for anaerobic, one for TB, including atypical, and the other one for fungal. Routinely, I send 4 specimens with 4 different prescriptions. Some microbiology, even I'm a microbiologist. If you mix up one sample, they do not do all these things. So I send 4 samples in 4 bottles, taking from various sites. And
is it your practice regularly?
Yes, every day, every infection I send for all. I send for aerobic, TB, and fungal routinely. I think we should all do, because my publication was there. It will tell you there is more and more atypical. See, those cases where we are not able to isolate the regular organisms, it could be fungal, it could be TB, it could be atypical TB. Recently, of course, I had one case where it's atypical TB, because as you know, to treat atypical TB, it's more toxic than leaving them well alone. So you must send cultures for TB as well as Candida or fungal.
Sir, KJ Reddy sir, Dr. Uday Prakash is also in the panel.
Uday, my friend. Uday, are you there? Unmute. I think you probably muted your mic.
Yeah.
Oh yeah, can you hear me now? Hello?
Uday, are you there?
Yes, can you hear me?
Yes, I can hear you.
Hello.
I can't see
Okay.
you, but I can hear you.
I know. I'm here, very much here.
I thought you only do 9 holes today. I did 9 holes only.
No, I'm done with the golf. I mean, I've just joined about 5 minutes ago, so I was just listening to your current problems. So I agree with you. It's very important to send anaerobic and aerobic. I don't always send fungal, especially if I know what the organism is. If you don't know what the organism is, before you do your first stage,
Sure.
That's
what I was telling you. Uday, if you do not, because the cases like this where you do not have organism preoperatively.
Yeah,
When
absolutely.
you do not isolate the organism preoperatively, you must send this for cultures. If you know the organism, most of the time it's a single organism. Though sometimes we isolate, but if you have a staph aureus or staph epidermis, you're unlikely to isolate to TB or fungal. But when you do not know the organism preoperatively,
But gentlemen, what the problem here is, many of our patients have already been on antibiotics for so long that many a time we get a negative culture.
Sure.
And that's when,
but if it is not septic, Uday, I stop antibiotics for 10 days before I take aspirate. 10 days to 2 weeks.
2 weeks.
They're painful. I give good painkillers. If we do not suspect any that they're going to do septicemia, I stop antibiotics 10 days to 2 weeks before I take any specimen. Aspiration. Sometimes aspiration. So I have a lot of debate about aspiration, but I take synovial biopsy. To be honest with you, I take them to theater, take good piece of synovium, and send for all the cultures.
Sure.
So this one, I think I will post-operatively. I will not much of inflammation, and this is how many? When I took about, I think, because as you know, we have to. It was treated with antifungal. My policy is we give 6 weeks before we go for second stage, and it had to be continued for. I mean, based on your culture sensitivity and your microbiology, we continued up to 3 months in this case. And it was a significant bone loss, which was revised into this. And we published, this was published in 2013. I have long follow-up. I think she's doing well, no recurrence of infection. Any comments about fungal infection? Uday, have you come across any fungal infection? I have.
To be honest, I've never actually come across fungal infection.
I have 4 cases. 4 cases of fungal infection, 2 cases are atypical, and 3 cases of TB. Atypical mycobacteria, 3 cases of TB. So we have to know, unless you send cultures, probably sometimes difficult to. And she got good range of movements. And range of movements always related to the degree of scar tissue. If scar tissue not much, probably you can get good range of movements. One more, Uday, for you. I think this is a 65-year-old, 1 year post-op, immediate post-op was all right. I think he developed few months later with a discharging sinus. As you can see, 2 scars. The second scar, probably they try to debride it. How do you deal with this? Before I do, Kasha, I think when you say half time, I will go for hips. I think at least hip surgeons are there. Maybe 2 cases hip we'll discuss. Probably after this. Is that okay?
Yes, sir.
Yeah. Uday, would you like to?
So, this is a classic situation which should be avoided. We should not make any other incision around the previous incision. I think they could have dealt with this without doing what they did. This should not have been done to start with. Would you agree?
Yeah. Of course, that's gone. But things do happen. We say so many things, but things do happen. But what would you do now?
So obviously, I think there is a definite infection here. We should, from the way it looks, you should do your blood and get a baseline. This needs the proper evaluation before you do anything. Stop the antibiotic. Try and get an organism before your first stage debridement, and then do what you did, in the previous slides where you debride the knee, get as many samples as possible, send as many samples as possible for microbiology, put a spacer, and then carry on with what you've said before.
Sure. And would you get in this situation, would you send a culture swab from the sinus or from the joint?
See, I don't always trust the sinus swabs because always you get some sort of a contamination. It's always best to rely on deep tissue.
That's important. I think that's one valid point, because if it is an active discharge, probably you can send the discharge, but always better to get from the joint. And because most of the time you get multiple organisms from the sinus tract, because other things, commensals will be sitting there. So this was 2-stage was done. And as you can see, second stage. And most of the time is a chronic infection. What happens? They will not get full range of movements. I think we should warn the patients, because they end up with some degree of fixed flexion deformity. And if you get 90 degrees, I think you should be happy. You should warn the patients, because we're getting rid of pain and the infection, and we're not operating for the range of movements. As you can see, other side has got severe osteoarthritis, but if he's refused to get operated more than 15 years, still, I think doing well with osteoarthritis one side, other side. This one, recently, I think I haven't seen him for a few years, but I think I saw a 12 years follow-up. Afterwards, I think no, lost to follow-up.
So I would just like to say something here, KJ.
Yeah,
it is very important. It's very important to figure out why this person got the infection in the first place.
Yeah.
So when he said for a year he was fine, why did he get the infection?
Probably, I think the history was not clear. Because it was a sinus, Uday. So probably it's a long-standing infection. Probably they might have treated initial infection with antibiotics, ended up with an abscess. There's a drainage of abscess and continue with antibiotics. So they were doing suppression of infection rather than eradication of infection.
No, so my point is, it's always best to figure out where the infection has come from. So it's very important for the physician and the surgeon to figure out whether he's got a dental issue, whether he's got a bladder issue, whether he's got something else, which could be the source of infection.
So you believe, do you strongly believe that UTI, dental infection will be responsible for PJI? What do you think? What percentage of dental organisms will be responsible for PJI?
No, I wouldn't put a percentage on it, but I have seen in the past several occasions where a dental infection has caused a hip infection, a UTI has caused hip infection as well as a knee infection. So it is, I think, very important that you deal with that at the same time.
Understand. You should not operate, but the incidence is 0.2, less than 0.2%. Dental organisms causing infection of joints, periprosthetic joint, is less than 0.2%. So we worry too much. Of course, we should worry, but probably the literature says, that's what the literature says. UTI, of course, E. coli is one of the common organisms.
We have another 20 minutes.
Sir, fungal is a hydrogenic infection, or what is the reason for the fungal infection, sir? Is it hydrogenic?
Fungal infection. That's a good question. That's a good question. We don't know. And I was speaking to most of the microbiologists. If it is atypical, mycobacteria or a fungal, it could be contamination of your instruments. Definitely atypical mycobacteria. Fungal, we don't know. Probably immunosuppression, but she was not immunosuppressed. It could be contamination. We don't know. To be honest, I don't know. To be honest with you, you have any answer? We lost you. Yeah, I think probably I won't show this one. I think we'll go to the hip because Kasha says only it's 20 minutes. And one more this thing, what I wanted to say is, whenever you feel exposure is not appropriate, you must use extended approaches, whether quadriceps snip or most of the time it's that stiff knee. If you can't bend more than 10 degrees, I do elective tibial tuberculosis. I think that's a message we should pass it on to the delegates. This one, I think probably Ashok Raju. You still there, Ashok Raju?
I'm there.
Yeah, go on. This one is a 51-year-old female. Total hip was done 2 years ago. Post-op dislocation at 48 hours. Failed closed reduction. They did an open reduction. Complicated by post-op infection. initially treated by antibiotics, infection continued for 6 months. Ended up with a chronic discharging sinus like this, bedridden for last 6 months, and that's the X-ray. So as you can see, there is, I think they took the stem out, but still the cup is there, cement is there. You can see loosened this one. How would you deal with this?
So it is clearly an infected case. So I would open up and do remove all the cement what is left along with the cup. So my way of debridement has changed over a period of time. What I do presently is I use diluted methylene blue I open up the joint. I take the samples from the acetabulum as well as the femur.
So do you feel it's advantageous to use methylene blue?
The one thing is that methylene blue helps me to clearly do my debridement almost till 99%, I would say, because it demarcates whether I have removed the tissue or not.
Anybody else use methylene? I don't use methylene blue, but anybody else uses? Uday, Ivy?
I have not.
Uday?
No, I don't either.
No, sir, I don't.
Because I read only in articles, books, but I don't use it. And probably I tried for other not in joints. I did not, to be honest with you, I did not find very helpful, but probably you have, of course, your experience. So you feel it is useful.
No, it only makes me sure that I have debrided that area.
Okay.
So
you want to do two stage or single stage for this?
No, I would do a 2-stage procedure for them.
Can you just a little comment other hip? Other side.
The other hip is a dysplastic hip.
So do you think it could be? I think I felt it could be because, see, the cup alignment also not good, but they did not recognize it was done for a dysplastic hip. That was the reason dislocated. And within 48 hours, as we all know, if any joint taken into theater second time for any reason, especially hematoma or dislocation, the incidence of infection is very high. That's what happened here. So you want to take the cement, remaining cup, everything out?
Yes, I would
That's
like
a
to
closer view, as you can see, and isolate the organism. And how do you plan?
So I would put a spacer inside, if possible, and then whatever the culture reports come based on that, I continue my.
I did this. This was when I came back to India about 2003.
Yeah, I don't think so. I would put a beads in that now at all. I would make a monoblock cement spacer, and then so that it maintains soft tissue tension and everything, and I will be able to mobilize on that for the first 4 weeks time.
Yeah, and okay, so you want to do second stage revision? That's on the right side.
Yeah, I would.
What do you want to do? When do you want to deal? Because she's got pain, limping, because she was not walking well, but the movements were painful. She was not limping because she's not walking last 6 months. Left hip, how do you want to deal with the left hip?
I don't think so. I would touch the left hip till I finish my first hip.
Okay.
Because it's an infected thing. The right hip is infected unless my whole right hip is sure that I will not. The infection is totally off. I would not touch the left hip at all.
Anybody else?
So, KJ, I would like to say something. I think what Dr. Ashok Raju said is absolutely fine. In addition, I think these days we have this thing called stimulant. And this is something I'm increasingly using. This allows us to mix in the appropriate antibiotics.
You can mix, you're right.
Yes. And this dissolves completely over time. And of course, when you do the cement spacer also, you should make sure that you put in additional antibiotics to the gentamicin, like vancomycin. And whatever antibiotic you put in, it should be in the powder form. It should never be in the liquid form. This is very important for the delegates to understand.
Absolutely. I think that's a very valid point. Sometimes we do use liquid, but I think it's important to use powder with powder.
Absolutely.
For the stimulant, you can use liquid also, sir. That's the advantage of using stimulant actually, as opposed to PMMA.
Yes.
In stimulant, liquid is very much usable, but it increases the time of setting. It may go up to 30 to 40 minutes. but you can still use it when there is no choice.
Yeah. That's, I think, with the stimulant exception. So I did this 3 months later. I took everything out, debride. Other side, of course, 6 weeks they treated with. Movements were painful, so I did other side just to see different way. Uday, what do you think?
Wonderful job, sir. Wonderful job. I think technically that's a fabulous issue, but I would still be a little reluctant to be doing this exercise. Yeah. So, but what you've done is really good technically, great achievement with the autograft solidly screwed in, securely put in the cup, and it's got a fantastic posterior superior cover, which is usually missing in these cases. So I think that's a good job you've done, and also you've used cement on the other side too, which you've covered from all angles. And I hope it's antibiotic cement that you've used, the standard one.
Yes, I did.
Yeah,
Ashok, would you worry about this other hip or this hip? I mean, it's left hip.
I'm not as bold as you, sir, to do the left hip.
No, it's not like that. But I think, of course, this was those days, of course, maybe about 20 years ago. Yes, I took a chance. I took a chance because I want to make her walk, and I thought this will work. So after 4 months, I did other side. As you can see, I took allograft those days. I took the iliac crest there and grafted in. Though there's a lot of debate about using a cortical graft. These are 4 months later, and 9 years follow-up. I think I was probably lucky, but I would do one side at a time. But I took a chance doing the normal hip first and other side. But when we're in this age group, rather in this era where we can do a single stage revision, I don't think there is any reason. If you have to assess the patient. If other hip is bad, probably if you're sure of eradicating infection one side, now I don't feel uncomfortable dealing with the bad hip first. Any comments, Ivy? Ivy's still
Yeah,
there.
I think it's something like what the first hip was, something like Girdlestons, which is expected to give infection-free status very fast. It's very well known in the literature. So after a couple of months or 3 months or so, you are justified in thinking of, because the patient is used to this hip for a long time. So now the other hip is giving a lot of trouble. You can try. There's nothing wrong in that. And you have been successful. I must congratulate you. Wonderful job you have done.
I think she has got, okay. Probably. Kasha, how much time you got, Srinivas? 1 case, 2 cases?
Sir, what is there at the down?
One
on
case.
The right side, there is some splinter.
There was, that's a cement. That's a cement. There is, as you can see, it's leaked. There was leaked from there. It's cement only. Cement from day one is there. It's not a periosteal reaction and infection. Don't worry. Yes, previous meetings, people got worried whether it is periosteal reaction. That's a cement, leaked out cement.
Okay.
Can I discuss 2 more cases or 1 case?
One case, sir.
Okay, so I'll skip this one. What I think Ashok was telling, I use, as you rightly said, I think I use nowadays. I use the spacer like this. I use my own with a Steinman pin, and I use the mold from uncemented stems. I use that as a mold, and I use a Steinman pen to put it and revise that one. This one for Ashok. He's a 28-year-old male, fracture dislocation. About a year ago, 2 weeks later, dislocated, painful, discharging sinus, unable to bear 6 months now. Can you see X-rays?
Yes, sir. I can see that.
And a sinus as well.
Yeah. So I think
He's
you have
from Nigeria.
two issues with this. One is infection. And the second thing you can expect is bone loss in the posterior and superior aspect of the acetabulum. So there are 2 issues.
How would you deal with this case?
The first one would be to address the infectious part of it. So I would open up, do a thorough debridement, remove the implant. I would not retain the implant in these cases, and then put a spacer if possible. And then I would definitely remove all the dead bone, especially in the wall part of it, which is dead. I would remove it, and then most probably go ahead with the spacer and then come back again after at the end of 4 weeks, at the time of 4 weeks, and then relook into it, and then go ahead with the prime.
So you would plan with 2-stage THR,
yeah,
total hip replacement. That's what you're saying.
2-stage replacement.
Yeah. Anybody, Ivy?
I think 2-stage only. Femoral side, there should not be any problem. It will be straightforward. But on the acetabular side, significant bone loss will be there. Yeah. Probably in the second stage, we would consider trabecular meshwork augments and other things. Probably because the patient is very young. And of course, the final option is girdle stents always there.
Yeah.
If it doesn't work.
Aditya?
2-stage, sir.
I'm keeping quiet. You're keeping quiet. That's why I want to.
No.
Wake you up.
Yeah, I agree with you, sir. Completely agree.
Anything else? Anything else? Would you like to leave? The question is, would you like to plan for replacement or would you like to leave him well alone? Control the infection.
Always we have to think of replacement because he's young. He can't be left like that for so long. If that final leaving him alone is the final thing.
Mithun, are you there?
Yes, sir. I'm there, sir.
Anything else I want to say?
Nothing extra to add, sir. I would go for a 2-stage revision with replacement.
Uday, anything?
I think we should discuss this with the patient also, sir. Yeah. I mean, girdle stone is after all not a no surgery.
Of course, that is the final.
For an infected knee, there may not be any other option but to operate in one way or the other. But for an infected hip, girdle stone is still a valid option given the lifestyle of the patient as well. If the patient is someone from a non-affordable family and is doing some work which entails him to sit on the floor and stuff like that, probably after thorough discussion with the patient, leaving him as a girdle stone is not a wrong choice, I would say.
Sure, you could always fine. But the acceptance nowadays, Veda Prakash, if you explain to the patient,
certainly low.
Because they take about 100 opinions, isn't it? Out of 100, maybe 20 would say girdle bone, 80 will say replacement. So they want patient always goes what he wants to get it done, isn't it? Nowadays,
that's one thing.
He already decided something, then they'll go to surgeon where he will do what he wants. Yeah. Uday, how do you approach from now on? So it's a play-free mode. I think good thing this thing is I feel very comfortable if I isolate organism. I feel very worried if I don't have any organism. So if probably I think Veda Prakash said if it's organism not sure and all those things, probably we think about girdle stone. But once you know the organism, probably you can be very confident. Yes.
So KJ, basically, I think once you do the first stage, you'll know what the situation is, what the cup looks like, and I think in India, it's I mean theoretically, you should be able to get rid of the infection. Go back and
now you got everything is normal now. As you can see, stop 4 years treated by 6 weeks antibiotics, ESR, CRP, everything come down to ESR little high, but CRP come down. Now we feel the infection is clear.
Yeah. So if you look at the acetabulum, there's a lot of bone loss.
Yeah.
And you need to really be. What you need to do is to have to reconstruct the acetabulum, which is the key here. Sure. And the way you reconstruct the acetabulum will involve things like tantalum mesh and tantalum augments and things like that, which is extremely expensive. And providing the patient can afford it, I would definitely go for a total hip replacement.
Sure.
But if not, we shouldn't do a half a job. I think you should be very honest with the patient and consider a girdle stone if you think that the patient cannot afford it and you cannot do a good job. And if you can't do a good job, don't do a half a job.
Yeah. And would you prefer cemented, non-cemented, or doesn't really matter?
It probably doesn't matter, providing you've isolated the organism, you've treated the infection. And I feel uncemented allows, blood supply to go very close to the prosthesis. And I'm not worried about it.
Sure. That's why. Anybody else?
Yeah,
Ivy, you wanted to say?
I always, if I am doing a revision for infection, of course, we all know on the acetabular side, it should be as far as possible uncemented. And on the femoral side, I prefer to go for cemented because I can use the antibiotic loaded cement. That will help to some extent. Even literature supports that.
Yeah. Anybody else? Ashok, would you cemented, uncemented?
I would do an uncemented cup. Cemented femur, plus or minus. I'm not really worried. on the femoral side because the femur doesn't look infected per se, one. And I would like the femoral head to be taken as a autograft if it looks good on this side, and then reconstruct the acetabulum.
Sure.
And then
Well,
go.
Kasha, you're not in the panel. Anything to add? What would you do, Srinivas? I shouldn't ask you a question because you can give your advice. Kasha, are you there?
Sir, I was sorry, I was not following the case.
Okay, no problem. I think you're not.
Yeah.
So I think I don't feel it should be cemented, uncemented, because once you treated infection, this is a primary, like a hip, difficult hip. And I don't think there is any evidence to say you should use a cemented, uncemented. Your choice, personal choice. Though, as everybody said, I like to use a uncemented cup, and I use it uncemented. And Uday, you rightly said you have to be careful about the acetabular reconstruction. I prepared for all the everything, but you can see the CT scan is not there. There's a good amount of medial wall. So I didn't go for a big cup. I used a small cup, put it inside. As you can see, I rimmed, bottomed up, gone down, and I could get without any major reconstruction and a reasonable cover. Probably posteriorly, it was 20% uncovered, but you can see superiorly, the side is reasonably covered. What do you think, Uday?
Yeah, I think, from what I see here, it looks fine. You can have up to 30% uncoverage, but the problem is I don't know what the posterior superior wall looks like.
Yeah, you can see that. Whatever
yeah.
Other side. Yeah.
No. If you were happy with it, I'm happy with it. It's during the.
I could get good screws. Can you see? I think. Yeah. Well, initially, I think, Uday, I used to get worried about putting a screw across. Now I intentionally put it. In case where stability is a problem, I put the screw inside.
Okay.
And I don't think if we are careful, drilling is problem. Putting a screw is not a problem. When you're drilling, you should be careful, but putting a screw is not a problem. You're not going to damage.
I've had
not going to damage the structures. And as you can see here, I got a good screw on the isthmus. I think stability is important. If you're happy with the stability, I think you should get away.
So one more point.
Yeah, but I'm a bit worried about looking at the bottom X-ray.
Yeah.
Because you said posteriorly it is deficient, superiorly also. I would have gone for a little higher, not in the natural location, a high hip center, so that I would have got a better contact with the bone superiorly also.
Yeah, I think what I meant to say posterior superiorly, but IV, as you know, recently, I think I prefer to come down to center of natural center of rotation as much as possible.
But bone contact also is very important.
Superiorly placed cups failed early. So
no, up to 1 centimeter, of course. 1 centimeter, of course, it won't make any difference. If it is too far high, then of course things will be different. In this case, probably by going up by another, say, 8 millimeters or so, I feel that you would have got better coverage of the cup.
Yeah, I can understand that. But as you can see, this may be from this screw. We got a good hole there, and majority of the cup down. And here also you can see. And I could get about, I said, 20% uncoverage posterior superiorly.
No, so, I agree, KJ. I think a jumbo cup in this situation gives you much better hold because you've got inferior wall, which is good antero medial and posterior medial wall, which gives you the support that you need when you don't have a posterior superior wall, which is not very good. I think it's important to inferiorize it as much as possible rather than superiorize.
And I've gone deep. As you can see, I gone up to there's not much of medial wall. It's gone deep. So medialized intentionally, and I got good coverage and good quality of bone. And the good thing is he's a young man. Quality of bone was good. Though it's infected, but it's a young man. Is about how many? Very young. I think 30s, in 30s. So that was and I think infection was cured. I think we had some follow-up afterwards, but I think everybody should read. The message is should read articles. There's so much literature on what is that infection, and we should be aware because that's a common problem, and everybody gets. I get infections. Everybody gets infections. So we should be able to deal with them. Early diagnosis, early treatment, and aggressive treatment is the key. So thank you very much for all the panelists and Srinivas for organizing excellent midterm TOSA meeting. That was a wonderful experience.
Thank you, sir.
Thank you, sir. Thank you, gadgets.
Thank you so much, sir.
In the chat section, I sent a link of ICM Philly, which is a good source for all the infection-related, musculoskeletal infection-related articles. ICMphilly.com. In the chat section, it's available for everyone.
Yeah.
Thank you so much, sir. That was a wonderful session.
Thank you. Thank you.
Next, I would like to request Dr. Praveen Mireddy to go on with next panel discussion, that is fracture-related infections. And the panelists are Dr. PNVSV Prasad, sir, Dr. Hari Sharma, sir, Dr. Vivek Trika, Dr. Myself, Srinivas Kasha, and Dr. Ashok Sunil Gavaskar.
Can you all hear me?
Yes. Can you hear me?
Yes, sir. I can hear you, Hari Sharma, sir.
Yeah, thank you.
I'm just trying to do the slideshow. For some reason, it's not allowing me. It still says screen sharing is paused.
Okay. We are getting, you started screen sharing, but
yeah, it takes a little time, I think, to come up.
Yeah, so while I'm waiting at the outset, I would like to thank the organizers for giving me this opportunity. So I would welcome Dr. PNVSV Prasad, sir, and Dr. Hari Sharma, sir, Dr. Vivek Trika, sir, and Dr. Srinivas Kasha, and Dr. Ashok Gavaskar as well. So all of us are waiting for our lunch, and it's nearly 1:35. So I'll try to not ask too many questions and try to go through some interesting cases, not generate too much discussion. So let us try and stick to simple answers and philosophy. Right. Shall I just say resume share?
It's not possible. Probably you stop it and why don't you restart? Yeah.
It's come up. Right. So let's move on. I think most of us have come across this paper in the last year's publication in Journal of Orthopedic Trauma.
We are not able to see it still.
I'm able to see it on the screen. And
what about other
shall I just say new share?
Better.
Not able to see it, man.
So please stop
I'll
this.
just say new share.
Yeah.
Now it's okay. Now
it's okay. Yeah.
Now we can see.
Yeah. So diagnosing fracture-related infection, the current concepts and recommendations. This was a consensus group from predominantly Europe and basically UK as well. So coming to their consensus guidelines, there were a few guidelines which were laid based on the current evidence. So these were covered. In the clinical signs, basically you're looking at an obvious pus pouring area, a sinus, or signs of inflammation are there, like redness, swelling. These are some of the features. And if somebody has been having temperature of more than 38.3 degrees Celsius. Coming to the inflammatory markers, individually they do not have a significant role, but as a combined, they still have a role, although this current paper which I'm talking about says it is not sufficient to confirm or rule out the presence of chronic or late onset fracture-related infection. So imaging, we all know there is definite role for imaging in suspected cases where there is no obvious sinus or a discharging wound or no local signs of inflammation, then imaging is definitely helpful. Most of the imaging which is done, plain radiograph itself gives a lot of clues. However, the CT can be utilized, especially when there is a non-union, and MRI to assess for periosteal reaction, subperiosteal abscesses, etc. White cell scintigraphy, yes, it is laborious, but it does have a role in certain cases. And PET scan also does have a role. But these are very rarely done in fracture-related infections because most of the time it is obvious either with a wound infection or a discharging sinus. But delayed presentations, especially subacute or the chronic ones where there are no clinical signs of infection, then they definitely have a role. So I think this is all covered. So again, going back to basics, plain X-ray gives a lot of clues. Look at implant loosening. If there is any radiolucent line around the implant, whether it is a nail or the plate, look for bone lysis, then failure of progression of bone healing, and especially periosteal new bone formation. Either it is on the screw or around the fracture site, if you see irregular, like almost like a sunburst type of periosteal reaction, you start seeing not just in osteosarcoma, but even in infection, you should start looking for these things. And if you have obvious sequestrum, then that can be picked up as well. MRI, we discussed briefly. The sensitivity and specificity of MRI for the detection of FRI are reported to be between 82% and 100%. And the sensitivity was 82 to 100, but specificity is between 43 and 60%. Bone scan, not very useful in fracture-related infection. WC scintigraphy does have a role. The PET scan again does have a role. So we'll try and go through some case examples. Microbiology definitely has a significant role to play. This is your important message here is that if you can isolate the organism, whether it is a PJI or a FRI, the infection control becomes a lot easier because you know what antibiotics to put in, whether you're going to use stimulant, whether you're going to put bone cement, whatever you're going to use, if you have an organism, then it is definitely very useful. But that may be isolated only 50-60% of the cases, but still we all try to isolate the organism. I think the microbiology has been already covered in detail. We'll try and skip as much as possible. Sonication, this has been recently been tried and that has also been mentioned, but there's no significant role compared to normal tissue cultures. There's no additional advantage of sonication in sending implants for culture directly, where they use ultrasound to remove the biofilm and then that with the fluid is cultured. Histopathology, yes, definitely has a role, especially when you're dealing with things which are not routine, and especially when you're thinking in terms of atypical mycobacteria or fungi or some other weird organisms, definitely does have a role. So let's move on to the cases now. Start with the simple one, post-polio residual paralysis, guy with open wound over the distal femur. Did this, was asymptomatic for 2 years and then had a little trivial injury, came with a swelling and then which became an abscess over the next couple of weeks. This is the X-ray. We had to use a proximal tibial plate as a distal femoral plate, taking the post-polio residual paralysis guy into consideration that his femur was like humerus. So let's start with Dr. Ashok Gavaskar. In this situation, there's no discharging sinus, elevated CRP and ESR, white cell count normal, and this guy came with severe pain and now he has an abscess. What would you do in this situation?
So he's got an abscess. Where does he got the abscess? Like he's got draining sinus, is it?
No draining sinus, no open wound, but just came with severe pain and following an injury, which after 2 weeks he presented to me after an injury saying severe pain and all the inflammatory markers were all elevated. This is 2 years post-op.
Yeah, if you are definite that he's got an abscess, you can try aspirate at sterile conditions and look for an organism to confirm infection. So correct. If that's not the case, then yeah.
Any other different thoughts from the rest of the panel?
If it is an acute abscess, raise temperature and then kind of
you're breaking up, Srinivas.
You may have been proactive. Can you listen to me? Can you hear me?
No, I'm unable to hear you clearly. Yeah.
Okay. My internet.
So basically, this guy had aspiration done and that had grown pseudomonas. So where did it come from? I really don't know, but it came. Maybe it was an open fracture with a small puncture wound which had a low-grade lingering infection which did not present as a acute infection, but after 2 years he presented as infection established. So what are the options now to treat other than draining the abscess? Would you retain the implant because it's only 2 weeks old, or would you do anything different? To the panel, anybody can answer.
Dr. Kasha has got disconnected, sir. He will again join.
I am back. I am back.
Yeah.
So I was just mentioning whether it is acute abscess with increased temperature and then patient is in sepsis versus a chronic abscess. That is one thing. And where exactly is the location, whether it is deep enough or just underneath the skin. So
abscess is over the medial aspect of the distal femur around the knee.
Okay. So that's what it is. So if it is just chronic, you can acute need to be proactive and then drain it off as soon as possible. And I would definitely do an ultrasound to see the plane, where exactly is how deep is the infection. So
okay, fair enough.
Sometimes it is just superficial to the deep fascia. We need not go in and then unnecessarily contaminate our fracture area or implant area.
Okay, fine, fair enough. So any other thoughts, sir, before we move on?
I think to me, this is a FRI. Like if you are confirmed with an organism, this has to be an FRI. You are dealing with an unhealed fracture at 2 years with probably a construct that is not very stable. So I probably would deal with it in 2 stages. Like this has to come out, and then probably like using your culture as and I'll probably put in a spacer and then wait. And in the second stage, it would be again getting sufficient stability with my new construct. So I probably might go in for a ring fixate.
Fine, fair enough. So let's move on. What we have done was on the same lines, but slightly different, trying to remove the implant. And there was some support. It was not a completely wobbly distal femur kind of thing. But at the same time, there was a frank non-union as well. So it was more of some fibrous tissue was still holding on. So we managed to put just the stimulant. And interestingly, I mean, only very 2 out of all the stimulant uses which we have done, cases which we have done, basically this is one case where it went on to heal without any other internal fixation later on. At 3 months, he was completely asymptomatic and pain-free and wound had healed. So just the learning points in this case, well, infection in this case could have been caused by hematoma or secondary infection, or the other possibility of low-grade infection that has been lingering for a long time. And stimulant in this case has definitely, went on to heal. So any other questions at this stage or any critique at this stage before we move on to the next case, please?
Yeah, only thing is I would have probably supported the fracture with at least an external fixator. So
fair enough. Point to be taken. But with it being a post-polio residual paralysis, he was unable to weight bear on that side anyway. We did it in the first place. You could have asked, why did you not think of treating non-operatively? Just because it was an open fracture, we debrided it and went on with the internal fixation.
Just one point out here, Dr. Reddy. Yeah. I want to highlight the fact that stimulant is not an antibiotic until unless you add antibiotics to it. It is not an antibiotic preventing or controlling agent.
Correct.
So what we should be emphasizing is not stimulant, but because it's a delivery agent, but the antibiotic which we have put into it, which was able to control the Pseudomonas aeruginosa.
Absolutely.
Stimulant is just a scaffold which is healing in bone, may have stimulated fracture healing, but actually it was the high grade antibiotic in which with high concentration that has helped you in controlling infection.
No, absolutely. It is being used as the antibiotic delivery system itself, sir.
Yes.
Agree. So let's move on to the next one. So this is a 29-year-old lady with a closed tibial fracture that was nailed elsewhere. Patient also had delayed union. So they tried fibular osteotomy, dynamization, fibular osteotomy, and then bone grafting from iliac crest as well. Still, it's a recalcitrant non-union. And over a period of time, I think within 6 months from the index surgery, she developed a small blister or swelling over the leg part, and then started oozing from there. So this is when I took the help of one of the specialists and asked for his opinion. And before I go on to what we have done, let us put it across to the panel. Dr. Hari Sharma sir, in this situation, what would you do, sir?
Yeah, basically, from what you have said, there is a blister. It's probably containing pus, I suppose. And this is a 6 months old surgery. And this being an intramedullary nail, where exactly is the blister? Is it at the interlocking screw area, or is it the fracture site?
Mid part of the leg, not exactly at the fracture site.
Not exactly at the fracture site. So is this the current X-ray or the latest X-ray? So in this X-ray anyway,
it's been treated. It's been treated.
Yeah, I mean to say this is just before treatment.
Yeah, correct.
Okay. So now the options are, one is to confirm that there is infection in the fracture.
Okay.
So you can do any of those investigations like scans, etc., to find out. Second thing is, your sinus, what you said, is in the middle of the leg. It's probably, it's not a sinus, it's a blister. So we really do not know whether it is communicating with the fracture. The second thing is, we have seen some cases where there is lingering and mild infection at the fracture site, and the fracture will not heal. And when you open it up to do, let us say, bone grafting or something, then you will find some granulation tissue type of appearance there. And in those cases, particularly if it is a plate, you can do a thorough debridement and cleaning, etc., and probably even add your stimulant and things like that, and then leave it, particularly if the implant is stable. The problem with a nail is that you don't have access to clean it as much like in a plate. So if you open the fracture site and you find that there is infection there, then the best thing is to remove the implant and then do either an external fixator or thorough debridement and a redo nailing or something like that, and you can add a bone graft with antibiotic and things like that.
Sure, sir. Any other different thoughts, sir, other than
Actually, the nail looks like very tight, because even after dynamization and it has not got dynamized. The gap is seen as it is, even though the two screws are not there in the upper part. The nail looks like very tight, and it could not get dynamized.
Right, sir.
So there is no point in trying for dynamization even further.
Correct.
So you have to remove the nail and then give some compression. Or what I do in this type of situation, I apply 2 rings, one above and one below, and then give compression.
Okay.
Just simply give 2 rings, one above and one below, and give some compression with that so that it will get dynamized. And it gives stability, and you can allow walking with that.
But sir, in this case, we are suspecting infection now because there is a blister and...
You treat infection, but at the same time, just removing the infection will not heal the fracture there. So you require some compression at the part so that, and you have to improve the stability, and also you have to improve the weight-bearing status of the patient. Then it improves.
Sure, sir. Any other different thoughts? Rest of the panel, please. Okay.
Yeah. I think like this state, infection.
Shall I move on?
See, as you have presented this case in this forum, we have to consider that there is infection on
yes,
at the
sir.
fracture site.
Absolutely
accordingly.
Okay. But what kind of situations and how do they present? So various presentations, I'm just trying to go through different treatment options as well. So yeah, fair enough. So took the help of Dr. Harish, who's currently working in care, and we did this. So basically, he felt that there's nothing else with the infection and the non-union. Probably this will be the best option for this particular patient. So Elizaro was done, and at this stage, it was quite comfortable. Wound is healing fine, but even at 6 months, again there was no progress of any healing of the bone. The soft tissue healed, the infection got controlled, but again, there's no clear-cut evidence to say that there is any sign of healing, even with patient full weight bearing for almost 6 months. What would you do now, sir?
There is a lytic area of the upper segment nearer the fracture site, and the bone looks like a bit sclerosed, absorbing, getting absorbed.
Correct, sir.
So you require, actually, you have applied the ring with provision for a bone transport in future, because there are 5 rings and 3 rings in the upper segment. So you can excise that part of the superior fragment and near the fracture site by about 3 to 4 centimeters, and then do a catectomy and then transport it to the same thing, the same frame on.
Any other different thoughts, sir?
One point. Can I ask one question?
Please, please.
Sir, Prasad sir, in these situations, when you have at least sometimes you are left with only 3 cortices or sometimes 2 cortices, even after debridement. In that situation, do you want to completely excise that and make a tubular bone and before you transport, or you just go ahead with 3 cortices?
I go ahead with removal of all the cortices and then transport.
Okay.
Dr. Hari Sharma wanted to say something, sir.
Yeah, actually the same point which I wanted to bring out. Like in this X-ray, the other cortex you are not able to see because of the superposition of the shadow of the rod.
Correct.
But basically it is non-existing there. That's why we are seeing in the other view like a lytic area.
Correct. Correct.
So basically here what we are trying to attempt is, you know, in the basic principles, if there is more than 50% of alignment or less than 50% of alignment in the conservative treatment also, it's not very acceptable. So here also it is basically in both the views I'm talking about. So yeah. here also the contact is so less. And one more point, see, Ilizaro is not a rigid fixation.
Yeah.
It is basically a stable fixation. It allows certain movements there. If the contact is good and the forces are more equally distributed, it will go into compression and things like that. But if the contact is like a point like this, then there will be sliding movement there, which is not good. So which will not heal. So the ideal thing should have been in the primary sitting itself, we should have got a very good contact. As Prasad said, you could have excised it and planned for a transport. At this point, one best option is that. Yeah. The other option is now that there is no infection, you can always do like, you know, do a bone grafting and put a small plate inside for giving stability and things like that.
Okay, you can correct the angulation and give a full contact by using some hinges or distraction.
Right. So
the best option is as what Prasad said, you excise that, get a good tubular bone contact. The ultimate result will be
even then there is some angulation of the distal segment, which is even after transport, there will be the same problem of not getting in full contact because it is a very thin bone, and for getting full contact, unless you correct the distal fragment angulation, you are not going into alignment of the proximal segment even after transport.
Sure. Dr. Ashok, any other different thoughts, sir?
Yeah, the ring fixator in this case, like, wouldn't have been my first choice to start with, but right now I think that's the best way to go. Whatever, I concur with the panelist here.
So, if not ring fixator, what would you have done?
No, initially, like, I would have removed the nail. I would have done an intramedullary debridement, put in an antibiotic coated rod, and then converted into another nail.
Oh,
and if required,
even I would have done the same thing.
Because it is very small fragment of necrosis, you can go ahead with your membrane osteosynthesis.
Okay, fine, fair enough. So interestingly, this lady had what do you call? When we went in this time, there was literally sequestrum of almost 7 centimeters. So going back and looking at the pre-op X-ray, she had a very, very narrow canal, and she wouldn't even have accepted a 9 nail. So they probably had to struggle to ream the cortices to get a snug fit nail. And looking at that, for a closed fracture, low velocity injury, fallen from a standing height, we started thinking this is beyond just an infection. There's some cortical necrosis happening, probably secondary to thermal induced. So that's when we thought we should put a spacer and then come out, not take any risks. And then this is was done. And then later on, corticotomy and bone transport, as Dr. Prasad sir suggested. And finally, once it came to docking stage, basically, even after weight bearing for a few months after this docking stage also, again, she was not uniting. So we went ahead and had to do small cancellous bone grafting for the iliac, from the iliac crest to the tibial fracture, and ultimately she went on to heal. She had a good result both clinically and radiologically. Any comments, sir?
So can I comment?
Yeah, please.
So probably initial debridement, as we have discussed, if it were to be a circumferential debridement, probably you would have had the same gap in the first instance. That is just a comment.
Yeah.
And in such a situation, once you debride it, you can as well dock it and then start lengthening. By the time
active docking and then lengthening is an option.
By the time you reach the length, you will have the fracture healed, and you need not graft it. That is one point which I just wanted to add.
Yeah, absolutely. Any other comments, sir?
Yeah, your observation is right, and my observation coincided with that the nail was tight.
Correct,
so,
sir.
So that is dermal necrosis, and that caused the problem, maybe.
So let's move on to the next one if there are no other discussion points. So just wanted to bring the same points. Thermal necrosis is a possibility, and then Elixir or ring fixator still has a significant role to play in non-union treatment, especially in infected non-unions with bone loss. And the causal organism in this particular patient was E. coli. Now, where did she get it from? I don't know. Maybe from UTI prior to that. Don't know. So let's move on. This is a 49-year-old male. Was involved in a road traffic accident, had a puncture wound, was initially treated elsewhere, and came to us at 6 weeks with this panel. Let's ask Dr. Prasad sir first.
So there is a sinus now.
Yes, sir.
And there is some comminution,
yes,
which might be getting necrosed, and the butterfly is maybe the cause for the sinus because of avascularity of that butterfly.
Yes, sir.
And now it is 6 weeks. And you can do a debridement and then look for it, and if there is need to remove the butterfly, you can remove that and continue with if there is no active discharge, you can continue with the nail because there is no loosening of the screws except the distal screw is off the hole.
Correct.
Distal screw, one of the distal screws is not there in that, and you can reinforce. You can wait and the nail looks like.
Any other different thoughts, sir? Would you retain the implant, exchange nail it, or do a frame like what we discussed? What would you do? Dr. Srinivas?
Yeah, what I would do is I definitely remove the nail and then debride that area and put an antibiotic nail and go in after 6 weeks and put another nail. But at this point of time, whatever that comminution, probably which is avascular, must be the culprit, which should be out.
Dr. Ashok?
The laboratory markers.
Hello?
Hello.
Can't hear. Can't hear.
Hello. Praveen, how bad are the markers?
Markers, inflammatory markers were elevated, about 30 of ESR and positive CRP.
But the construct looks still at 0.6. Is it comorbid?
No comorbid conditions, no.
Yeah,
You're breaking up actually, unable to hear.
Can you hear me?
Yeah, I can hear you now.
Hello.
Yes, I can hear you now.
Yeah, I think a consideration can be given to retain the implant. The constraint looks stable at this point, 6 weeks. So I can probably plan to debride, retain the implant, and then deliver some local antibiotics, and then wait for few weeks. Try to get some cultures. If they grow something, then put later.
Sure. Hari Sharma sir, any other different thought process?
No, I agree with that.
Okay. So let's move on. So thorough debridement was done, implant was removed, exchange nail was done, and bone cement was used. He had a significant soft tissue and the butterfly bone fragment loss. That was all sequestrated. It was a dead piece, as Dr. Prasad rightly said, that needs to come out. And this was done with the help of plastic surgeon as well. And did the stage 1 masklay for this. You can see a triangular defect of the main butterfly and then extending onto the posterior part on the lateral view.
And Praveen, why was the nail removed? And why was the nail removed and what was done?
It was infected. The discharge was coming from proximal and mid part of the shaft as well.
No, why a nail again in the first stage?
Pardon? You're asking why did you choose a nail again?
It offer in the first stage?
In the first stage, because we have done a thorough debridement and excised all the dead and necrotic tissue, and we were assuming that it is going to be clean. And as stage 1 procedure, along with bone cement with topical antibiotic, along with bone cement, and also intramedullary reaming was done to accept a larger nail. And the previous nail also was obviously with a distal locking screw, only one screw. We did not want to accept that. We could have put an external fixator or a ring fixator, but we chose to do the nail. So at second stage, we went ahead with basically cancellous chips as advised in the induced membrane technique. And this went on to heal without any major problems. Learning points in this case, obviously thorough debridement is essential, and then involve the plastic surgeon early in whenever you suspect that there is a discharging sinus and with the bone loss with soft tissue, significant injury. And then flap coverage also helps. And in this, the causal organism was only Staphylococcus aureus.
Can I ask one question up to all the panelists? Sometimes you have an infection which is just localized at the fracture site, and your medullary canal is spared. What I mean to say is, like, if you get a bone scan, it is just localized at the fracture site.
Okay.
So how do you deal, especially if it is the situation of this particular case? If there is no intramedullary infection and just localized to the fracture site.
Yeah, I think in this case, like considering the time frame, we can probably take it that intramedullary canal is still not, it is not intramedullary osteomyelitis yet. So there were a couple of uncommon butterfly fragments. I think like with the nail inside, we could have still debrided this adequately and then put in a local antibiotic delivery system, deliver antibiotics, and then go ahead and graft it at second stage.
But how to find out?
That's probably reasonable.
Sometimes you open
like,
the entry site and
I don't think you will be able to confirm it with any kind of investigation, definitely. So, but regards to histological studies, like I think it's a safe bet to go on and do that.
Okay, let's move on. Even personally, there is no role for bone scan or any other scan at this stage. MRI also would not be of great help if you are suspecting soft tissue spread. Then you can pick up on MRI. But again, metal artifact reduction sequence, all those also still it will cause significant artifact, and inflammation also can look like infection when you do an MRI. So let's move on. So this was a 46-year-old lady known to have diabetes, and this was treated elsewhere, presented to us at 8 weeks following this initial treatment. Initially, they had put external fixator, and this is the status of the wound at the moment. The patient came in with this to us. Sharma sir, can you please start?
So this is basically an open fracture which was treated like this.
Yes, sir. Open fracture.
Okay.
This was
And
treated
this is
with an
about
external.
2 months.
Yeah, about 2 months. Yes.
Okay. So here, there is obviously some bone necrosis there, if I can see in the wound. So you need to do a thorough debridement, and there will be a gap because of the soft tissue injury and all that. Also, there will be avascularity of the fragment. So you will end up with a gap, and ideal thing would be an Ilizarov in this case.
Yeah, definitely, definitely option to consider with Ilizarov. Yes.
And you have to have a soft tissue cover for that. Probably, if you are maintaining the gap, then you need a flap cover or something like that. Sometimes what happens is, if the wounds are small, you can do acute shortening. You can let the wound become smaller, and you can close the wound, and then later on do lengthening as a delayed process.
Sure. Any other different options, sir?
You might have done the flap cover when the external fixator was there itself, instead of waiting and then.
Possibly. It looks more like a skin grafting or something like that.
SSG was done, but not a flap at that time.
Like that.
Yeah.
So now the only Ilizarov is the option. I go for Ilizarov only.
Okay, sir.
End excision, end excision, and then bone transport. If there is more than 3 to 4 centimeters of shortening, I go for the bone transport and LLD correction.
Sure, sir. In this particular case, so with the help of plastic surgeon only, we debrided thoroughly, went ahead with the induced membrane technique. So basically, chose to nail it, and then with the flap coverage, her sugars were all haywire as well. Post surgery, she needed colistin for controlling the infection because it was resistant to all the other antibiotics, and she needed to stop colistin, and after 2 weeks we had to stop the colistin because she was developing acute kidney injury as well. So she had almost 7 to 7.5 centimeters of tibial defect because of dead and necrotic bone. And then we went ahead with stage 2 mascula as well. She consolidated well, and this is one of the large defects which we managed with the vasculae. Ilizarov was probably option 1, but this went on to heal without any major problems later on. But once the acute kidney injury settled, basically when we stopped the colistin, within 6 weeks, her creatinine and everything came back to normal.
So in the bone cement, you added antibiotic again?
Yes, sir.
And what antibiotic was that?
In the bone cement, we used only this one, sir, vancomycin. At that time, we did not have culture results available. Only intraoperative samples had grown this. So post-operative, IV antibiotics when we had to give colistin because that was resistant to all the normal antibiotics like tigecycline and other things, meropenem, we had to go for this one. After discussing with the nephrologist, it was picked up that most of them recover following AKI, but better to be very watchful and careful about giving colistin in anybody, not just diabetics. So the learning points in this case, as I mentioned, early plastic surgery intervention is crucial, and thorough debridement of dividless tissue is essential. And to get a clearance of the dead bone is, I think, key, and it plays a vital role to achieve good plastic cover to get a union. This is an international patient from Africa. He has been walking around with this for 1 year, and there was no discharging sinus or anything. His inflammatory markers were just barely elevated. Came with this clinical presentation and radiological presentation. Just because of lack of time, we'll try and.
This is last case.
Last case, yeah, fine, fair enough.
So this is maluniting rather.
Okay,
and
sir.
The broken implant.
Okay, sir.
And you have to implant should be out, and I go for Ilizarov reconstruction with angulation correction, and if there is a need for correction of the length. Usually the length should be equal by the time the angulation is corrected because there is not much of overlap at the fibula except for a centimeter. So there should be only 1 centimeter shortening, and with angulation correction, its LLD should be corrected. But removal of the distal segment will pose a problem. Very difficult to remove the distal segment.
Yes, sir.
Unless you open it and remove it through some window you have to make, and then you remove that. Or you correct the angle intraoperatively and then you enter with a long hook from the superior part only into the distal segment and pull it out. That is one difficult problem. You are going to face it for removal of the implant.
Yes, sir. Yeah. Any other comments, sir?
Anyways, I'm sure you are going to open the fracture, no, sir?
Correct.
No, I am not going to open the fracture if I can manage removal of the distal part.
Okay.
Was the deformity correctable on table? No, obviously. I think
No,
the
sir.
fibula also fibula is
unless the fibula osteotomy is done, then only we will come to know whether it is correctable or not.
Yeah.
Correct.
So I would definitely open the fracture section ends, remove the nail through that, and probably if it is in the soft tissue and the shortening is not going to be much, I would just nail it and graft it.
True.
So exchange nailing and grafting, yeah.
There is no active infection as such at this stage, right?
Yeah.
No pouring pus or no discharging sinus or anything, but just mild elevation of inflammatory markers. That's it.
Then you can go ahead with Kasha's plan also, and you can graft it and nail it and properly and lock it distally, because there are no locks in the distal part except one which is not crossing the nail, and lock it properly, give stability, and that may heal.
Sure, sir. So
now, one question to you: how much shortening do you accept in tibia?
Question to me?
Usually about 3 centimeters also I accept shortening.
Okay.
Right? But these international patients, they are more worried about this shortening and they want more correction of the length.
Absolutely. They're so particular about it.
Except the Indians, they don't accept shortening.
So anyway, intraoperatively, the fracture site did not look very, normal. It was looking, as if there is a possibility of low-grade infection, which did not present to us. So we changed the plan and went ahead with the stage 1 masculine. In this particular case, basically with the gross varus deformity correction, we anticipated some problems, so involved the plastic surgeon early itself, and then got a flap done, and then it was more of a fasciocutaneous flap, and then they covered it with the skin graft. And he went ahead to heal. He sent a follow-up X-ray from Somalia, so he has done well. So I'll just quickly run through. I'm not going to ask the panel. Just run through some learning points in this case as well. So basically, long-standing deformity, you need to keep in the back of the mind that you just don't correct the deformity. There's a possibility of skin problems, soft tissue problems, and also suspect infection whenever there is non-union. That is one important message which I wanted to put it across. And he grew Staph aureus. African patients, a lot of them are still growing only Staph aureus, interestingly. So I'll just go through some case examples only.
Just to add one more point to your last case.
Yeah, please, Srinivas.
Same, you already covered it. So whenever you are just planning a mass clay, so this vascularized coverage is a must to have the to prevent graft resorption in the future, or better incorporation of the graft.
Absolutely. Completely agree. Yeah. So this case I've just shown, and then this is an interesting one, which if you permit me, I'll just present this one, just an eye opener in a simple one last case. I will just go through a little detail because this is really troubled us. So basically, it's a 24-year-old healthy lady, no diabetes, nothing, had a puncture wound over the ulna, and she came because of the lockdown period 4 days after the injury. So basically, normal debridement, and then went ahead, plated it. So that was the post-op X-ray. At 6 weeks, she comes like this to the clinic. That was just 2-3 days before she came to us, the first picture on the left hand side, and the right hand side.
Ulnar side or radial side?
This is on the radial side. Puncture wound was on the ulnar side.
Okay.
So again, standard, we thought, infection, we need to somehow get the organism grown. So sent samples, everything, no, what do you call, growth, first time. What would you do at this stage? This was the X-ray at 6 weeks. What are the treatment options quickly? Okay, anyway, because of lack of time, I'll just go through what we have done and then the learning points. So this one we thought, okay, let's retain the implants because it is early days, and put some Stimulan in there, put the Stimulan, retain the implants. Patient comes back with this. Then we started thinking, this is not right. I mean, a low grade, small puncture wound causing so many problems. So again, sent for same standard, tissue, soft tissue, culture.
Any retain thing?
Pardon? I didn't get that.
In the first stage, when you have opened, in the first stage, in the sense, the previous operation, when you have opened the fracture site.
Correct, sir.
The sinus actually was leading to the fracture site or the bone.
You mean the first open fracture? That was on the ulnar side?
No. I'm talking about the second operation which you have done with the stimulant and all that. So at that time.
Any retain bodies, Praveen?
I didn't get you.
Anything retained in the?
You're asking about retained foreign body.
No retained foreign body, nothing. I mean, we opened both sides, and there was no obvious foreign body or any other foreign material which could have been a potential source for infection. So we thoroughly washed it and went in second time. That time also again, thorough debridement and sent for standard cultures and also for atypical mycobacteria and fungal. So
what was the appearance of the bone at that time when you have done the debridement and all that and putting the stimulant?
When we opened the bone was looking a little avascular at the fracture site, where because of the previous open reduction. So it was difficult to determine whether it was because of the initial injury or the first surgery, but it was looking a little pale and white rather than a normal blood.
But without any soft tissue attachment.
Yeah, soft tissue attachment, as we said, the extensive soft tissue dissection was not done in the first time. So that was all disturbed. So we had to think of removing the implants because she, persisted to ooze. This time we thought we will not put any internal fixation, sent for samples this time. And later on, we came to know that she was not growing anything in routine bacterial, anaerobic, aerobic, but they had to send samples from our lab to another hospital just because somebody is more into looking at fungi specifically, and they managed to isolate a fungal organism. And on the histopathology, it just showed inflammatory granulation tissue with focal necrosis. No atypical mycobacteria as such. So then we went ahead with stage 1 masculae, put an external fixator for the radius because already there was a big raw area developing and we didn't want to take any risks. So we put this bone cement with in the suspicion of possible atypical mycobacteria as well. At that time, we still hadn't isolated the fungus. So this is what was done. And we went ahead finally after 3 months of antifungal treatment, did this just about 4 weeks ago. Just wanted to share this just to keep in the background of some open fracture coming little delayed presentation and has grown a fungus. So just to keep that in the background of working diagnosis that, there could be a fungal infection as well. I know on the PJI, people have started talking about fungal infection for a few years now, but fracture related, especially in farmyard injuries, there is a risk of fungal infection. So just to keep that in the background. Just to summarize, I'll just go through few this thing, the last 2 slides to just summarize the whole thing. So infection could be resistant to antibiotics and may need repeat procedures to control or suppress infection. And at times, especially when dealing with virulent or resistant organisms, once the biofilm has formed, it may be beneficial to consider external fixation to control infection. And it is always good to warn the patient regarding persistence or recurrence of infection in any patient with fracture-related infection, because we may be able to only suppress in certain individuals, we may be able to get a cure in certain individuals, and once infection settles, it can always come back with a vengeance. So just so things to remember, FRI, you need to prevent it before you develop it. You have to plan it properly, and then you need to counsel both the patient and the relatives, because every time each person will come back and ask, why is it coming back? Why is it coming back again and again? Especially in this young lady, which we talked about, the fungal infection. She did, patient was absolutely fine, but the father had a lot of questions and we had to answer them. It was not anybody's mistake, but atypical presentation. So multidisciplinary team involvement, use the microbiologist early, plastic surgeons, and know your bugs. And bugs to be wary of, I just put a mnemonic so that we remember. Pseudomonas, be very wary about it. Enterococcus, E. coli, Klebsiella, Staphylococcus. Staphylococcus, especially MRSA, if you're thinking about it. The order which I put KPs is specifically saying those are your nightmares. In the last 8 years since we have been practicing in India, these were the nightmare organisms to get rid of. So thorough and aggressive debridement is the key, and you need to be patient in treating infections, both for the patient and the surgeon. Thank you very much for the opportunity. And I wanted to acknowledge my team, especially Dr. Ved Prakash, Dr. Shashikant, Dr. Rajendra, and Vamshi, and Bharat, and plastic surgeon. Fortunately, when I was in care, he was there, and even in Yashoda Somajaguda, he's still there. So, and microbiologist has a significant role to play in treating these complex situations. Thank you very much.
Thank you, Dr. Praveen. So
any take-home messages from the seniors, and before we wind up, sir?
No, nothing. You already covered everything.
Thank you so much, Praveen.
Thank you. Thanks so much.
Yeah.
Thank you, Praveen, and thank you, Kasha.
Thank you, Praveen.
Thank you, sir.
A wonderful conference.
Thank you, Srinivas, for the opportunity.
Thank you, sir.
Thank you.
Can you stop sharing? I need to share this.
Yeah, I'll just do. Thank you.
So now the program has come to an end. I'll just announce the answers for the questions and then we'll close it. So the first question was, what is the most important factor in reducing the infection in orthopedic surgery? Is theater discipline. And the prize winner is Dr. Neha N. The second question is limb preparation. So the routine rhodone iodine which should be used is 10%. That is the answer given by Dr. Muhammad Ali. He is the second Pixar prize winner. Third question is our delay in the treatment increases the risk of infection and leads to death. That is the critical phase is 45 hours. That is the critical phase. And this was answered by Amarnath, and he is the Pixar prize winner for third question. And fourth question, the single most important factor that contributes to maximizing the culture positivity is correct timing of the specimen collection, which was answered by Dr. Reshma Tirunamalli. And next question is prosthetics joint infections. What is the percentage of routine standard cultures in identifying the organism? Is 25 to 50%. And Dr. Beam Singh is the winner. And different antibiotic types that can be used in both antibiotic delivery, both solid and liquid antibiotics can be used in resorbable calcium sulfate. That was answered by Dr. Monica. And Sunil's question, what would be the best treatment option is option 3, nail removal, intramedullary debridement, antibiotic coated nail, followed by nailing. So 2 stages. Dr. Lokesh is the winner. And Dr. Krishna Kiran's talk, single stage knee revision can be done in all except in polymicrobial infections is answer. And Dr. Uddhav Shalke is the prize winner. And Dr. Sudhir Reddy's talk, what does the X-ray show? This is a sinogram showing extent of the tract. So which was answered by Dr. Shahil Shah. These are the winners, and I would like to thank everybody. Dr. Somashekar sir. Sir is there? Somashekar sir is there? So, Dr.
He's there, sir, actually.
Okay, fine. Yeah. So, Dr. Sudhir Kumar sir, President, TOSA. Sudhir Kumar sir. Okay, so they are on mute. Dr. Vijay Bhaskar sir, Secretary TOSA. Everybody is on mute. Somebody has to give a vote of thanks. So, let me just, where is there? Okay, fine. With this, I thank all the faculty for giving their valuable time on this particular Sunday and sharing their knowledge. And it was quite useful for young as well as practicing orthopedic surgeons. Thank you very much for your contribution to each and every faculty. And I must thank Janssen people for their continuous support. I must also thank Pixart people for providing this particular Pixart prize for each session. Thank you one and all. So with this, we call it a day. Thank you so much.